with the Indian Chest Society. I am Dr. Sandeep Salvi, the immediate past president of the Indian Chest Society. And before we start the program, I would like to say a few words about the Indian Chest Society. The Indian Chest Society was founded in 1980, 45 years ago, in the city of Mumbai, and since then it has grown by leaps and bounds. We have more than 3,900 members with the ICS, and it is growing. Every year, around 1,000 doctors complete their post-graduation in the field of respiratory medicine, and therefore the Indian Chest Society will grow much more rapidly over the forthcoming years. The whole objective of the Indian Chest Society as a non-profit organization is to upgrade the knowledge base of pulmonologists across the country, give them the latest knowledge in the field of respiratory medicine, encourage them to conduct research in areas where there are knowledge gaps, and then also to help the lay people become aware about the lung and its importance and the various respiratory ailments. We have been actively conducting training programs for the respiratory community, and since the COVID-19 pandemic, when we started with the webinars, we have, in the last 1 year, we have conducted around 50 webinars. And I must tell you very proudly that each of these webinars are very attended with large numbers, with at least around 1,500 doctors listening to the latest knowledge that we have to share with them. Apart from the work that we have been doing in India, the Indian Chest Society has been partnering with all the international respiratory societies, and one of our favorite international partners is the European Respiratory Society, with whom we have been partnering for more than a decade. Dr. Rajadhar has been instrumental in helping conduct the Hermes exam with the European Respiratory Society, and so far more than 500 doctors across India have got the European Diploma in Adult Respiratory Medicine. That's a very strong partnership that was established with the European Respiratory Society. We have a very strong presence at the European Respiratory Society congresses that are held every year in different parts of the world. We have more than 2,000 Indian Chest Society members who are also members of the European Respiratory Society and gain benefit from the educational knowledge and the database that the ERS has. The Indian Chest Society also offers travel grants to postgraduate students of respiratory medicine to attend the European Respiratory Society Congress, especially those whose abstracts have been accepted for presentation at this international meeting. Apart from that, we have also received ERS short-term fellowships and a whole host of other collaborations with the European Respiratory Society. So it gives me immense pleasure to have this wonderful ERS India Summit in the city of Kochi. This is the third one that we have organized. The first one was in Mumbai, the next one was in Delhi, and today is the last ERS India Summit in this wonderful city of Kochi. So with these few words, I would like to invite the President of the European Respiratory Society, Professor Silke Ryan, to come on the stage and say a few words about the European Respiratory Society.
Yeah, it's my immense pleasure to welcome you also on behalf of the European Respiratory Society to the ERS Indian Summit. I mean, we are immensely delighted to be here. I mean, as Dr. Sandeep said, it's the third event within the summit. So we have spent about a week now in India. For me, it's the first time in India, and I have to say I'm overwhelmed by the wonderfulness of people, the amazing culture, the cuisine, So we really had a great time, and I for sure will come back. As Dr. Sandeep said, the ERS has a long and strong relationship with the Indian Chess Society, and we currently have about 2,000 members from India in the ERS, and your commitment, dedication, not only to our society, but to global respiratory health is truly commendable, and we are just delighted that this is a possibility, an opportunity for us to somehow give back by coming here to India and have this joint event. So the only way of tackling the global respiratory problem is that we work and collaborate together, sharing science, promote respiratory health, and work towards a future where respiratory health is a priority for all. And so I'm immensely looking forward to another event which I'm sure will be full of sharing cutting-edge science, but even more so to foster our friendships and collaborations. So I wish you all a wonderful and immensely inspiring conference, and thank you again for allowing us to be here. Thank you. Dhanyavad.
As part of the Indian tradition, I would like to offer a very formal shawl to the President of the European Respiratory Society. It's called Veshti, which is a very Kerala shawl that is offered to guests before the start of a program. So can I please request the brain and the spine behind this ERS India Summit 2025 has been Dr. Rajadhar, the Secretary of the Indian Chess Society, who despite having an accident recently has put in all his heart and soul into making this program happen. So I would like to invite Dr. Rajadhar to come on the stage and say a few words.
Thank you, everyone. Today is the final day of a very historic ERS India Summit 2025. Historic because it's the first meeting that's been organized by the joint collaboration of these two societies, which, as you've heard, both from Silka and from Sandeep, have had close ties for a very long time. I would like to thank my colleagues within the Indian Chess Society, within the Indian Chess Society governing body, led by Sandeep, who've actually shown the way of this collaboration and held it together for a lot of years, and then come forward and put this all together for the final meeting that you see today. I call this the final meeting. I hope it's the first summit of many of its kind in the coming years, and I'm sure that's going to happen through 2026 and beyond. I have to thank the European Respiratory Society for being actively involved in every step, from the inception of this meeting, making the framework of the program, selecting topics, and then selecting the appropriate faculty for this wonderful academic feast that you're going to witness today. The Indian Chess Society and the European Respiratory Society are equal partners in this summit. The speakers, as I said, have been carefully curated for all of you, and we have kept in mind that we have the very best in the country represent the India and the Indian Chess Society. Unfortunately, we've only got about 7 learning hours as a part of this meeting, so some senior respective faculty we have not managed to include this time, but I hope they are in the audience today. They would actively listen, participate, ask questions in the course of the meeting and enrich us and the meeting through the course of the day today. Going forward, there'll be many opportunities for such collaboration, and I hope we'll be all inclusive going forward in including all of these people. For the same reason, I said we've got about 7 learning hours. The time allotted to every speaker, moderator, panelist, subject expert has been kept short, because what we want is a representation of every area of respiratory medicine, chronic respiratory disease, the burden of which is immense in our country. The emphasis has been on lots of panel discussion, case discussions. We want to make sure that we have a discussion with all of you, but also within these panels, so that this clinical carry home messages for all of you. Going forward, when you go back to your clinics tomorrow, practice respiratory medicine, you're updated with these clinical nuggets, which will help you to move 2 steps forward, 2 steps up in practicing what you do on a day-to-day basis. Hence, it's imperative that we stick to time. The responsibility of sticking to time lies with all of the faculty, it lies with the subject experts and chairpersons. We'll hear a bell 2 minutes before the end, and then at 2 minutes, after the 2 minutes are up, the slides will be blanked out for a few seconds. I apologize from before for this, but otherwise there's no way we can actually finish this super packed program. My colleague Dr. Shyam Krishnan is going to be the MC for this program, and you will see him soon, but it's a composite responsibility of all of us to make sure that the program runs on time. There's an online portal for you to ask questions also. So there's microphones that you see stationed here. There's also an online portal where you can ask questions. It will be shown to you by our colleagues from CIPLA, by ourselves. Please do ask those questions on the online platform. The moderator gets to see your questions. If we do not manage to answer all your questions here, we will, I promise, send you a compendium of answers, collate all the questions together, collate all the answers, and send them back to you in the not so distant future. There are microphones in various locations that you see. We will ensure that people are audible. Sometimes it's difficult to hear across the stage. So there's people stationed here who will be helping with making sure that we are speaking into the microphone. If the audience cannot hear us, please do point that out, that you're not being able to hear or not being able to see, and we'll make sure that things go accordingly. We have also invited posters to be submitted by our younger brigade. This was a bit of a last minute effort from all of us, and again I apologize that it happened last minute. However, in spite of that, we've got 11 posters which will be judged by the European Respiratory Society and Indian Chest Society faculty. This will happen at 11:30 a.m. So I'll say this again, 11:30 a.m. for the poster session. It happens at lobby level, Grand Ceylon 2. So lobby level, Grand Ceylon 2 at 11:30. We won't make a separate announcement for this. So for all the youngsters who are going to present their posters, it's a fervent request from my side to go and stand by your posters at the time. The faculty will come to you. They have been allotted separate posters, and they'll do the judgment between 11:30 to 12. The other thing I wanted to take this occasion to request all of you is feedback. So like I said, this is definitely not the last ERS India Summit that we are holding. So it's your feedback which will help us to make this program better for all of you. So do write in your feedback before you go away. That's again on an online portal, and we'll show you how it works. But do give us your feedback, put in free text, tell us what you want which is different, tell us what you want us to do in a modified manner. There's a lot of people I need to thank, and there'll be a valedictory session at the end, but a big thank you to our platinum sponsors, CIPLA. They have worked with us in every step during the course of the meeting, and without people like Shubhadeep, Shobin, etc., I think doing the meeting would have been a huge challenge for the ICS and the ERS. So big round of applause for Team CIPLA for helping us take this through. Equally a big thanks to Sedna, Juventus, Schiller, who have been the other partners. They have supported us financially for a meeting which has been a challenging event for all of us. So big thank you to Sedna, Juventus and Schiller for supporting us through the course of this meeting. Impresario have been the event organizers. You would agree that the setup, the get-up of the meeting, the feel of the meeting compares with any international meeting, and it's all thanks to to the event organizers who've done a great job in helping us put this through. Like I said, the most important people who want to thank in this particular event is the European Respiratory Society. They've not only collated the program together, there's 9 of the faculty and 2 of the administrative heads who have actually flown in as a part of the meeting. And because this is the final of the 3-leg meeting that we have, it gives us great pleasure to just give them a memento from our side, to honor them in front of all of you. And if I can invite Dr. C. Ravindran, the Vice President of the Indian Chest Society, along with our immediate outgoing President, Dr. Sandeep Salvi, together to do the honors for us. Dr. Ravindran, please come on stage. If I can, in alphabetical order, call Professor Carlos Rubalo Cordero, please, on the stage. Professor Cordero. Thank you so much. Can I request Professor Hilary Pinnock to come onto the stage, please? Professor Hilary Pinnock, please. To come up on the stage, please. James, please. Can I have Professor Judith Garcia come up on the stage, please? Can I have Dr. Mark Miravatilis come up on that stage, please? Can I have Professor Monica Gappa come up on the stage, please? Can I have the honor of requesting Professor Nicola Roche to come up on the stage, please? Can I please request my good friend Professor Umar Usmani to come up on the stage, please? Professor Silka Ryan is on the stage already, so we would want to honor you with a memento, please. This program would not be complete without the support, without the efforts, without the number of hours that Mr. Stephen Seeley has not actually slept is immense, and the same stands true for Werner Bill. So big thank you to them, and let me have the honor of calling Steve up on the stage, please. Steve. Let's have a loud round of applause, please, guys. And then last but not the least, Werner Bill. Werner, please come up on the stage for us. He's told me he's been in India for the first time in 1983 and has made multiple trips and loves coming to our country. So welcome again, and thank you for all that you've done for this collaboration, Werner. There's also someone else we are missing here today, which is Amy Farr. So Amy is from the administrative branch of the education wing, and she's given us unstinted support virtually online, getting this program together. So while she's not here listening to us, guys, please put your hands together for Amy Farr from the ERS.
The lighting of the lamp.
Sandeep, can I just say on behalf of the ERS faculty, we are really at awe for your generosity and for your friendship. I mean, it has been such a wonderful collaborative approach to developing the program, organizing the event, but you did most of the hard work, and we are just so grateful, and thank you for honoring us in this way. And we hope we see you at our Congress at the ERS this year, and this is a long-lasting friendship, and we will appreciate it. Thank you.
Thank you, Professor Silka Ryan.
प्रतिरूपं गणनाथं प्रणवं प्रथमनादं प्रतिरूपं गणनाथं वरणे चिन्तयिलाद्यं गणपति तन् नामनिवेद्यं वरणे चिन्तयिलाद्यं गणपति तन् नामनिवेद्यं प्रणवं प्रथमनादं प्रतिरूपं गणनाथम् കുടികൊള്ളും മൂല്യമുണരാ മൂലാധാരതലത്തിൽ കുടികൊള്ളും മൂല്യമുണരാ പ്രാണൻ മീട്ടണവാദ്യം തിരുവോങ്കാരത്തിൻ വാദ്യം പ്രാണൻ മീട്ടണവാദ്യം തിരുവോങ്കാരത്തിൻ വാദ്യം.
Very quick housekeeping messages for all of us. Please keep your phone on silent mode. On your name badge at the back side is a QR code. If you scan that, it will tell you the entire program for today's events. This notebook that you have, if you open the first page, on the first page you will see the QR code for any queries that you would like to send and also for your feedback. So please scan these codes. With this now I would like to declare that the ERS India Summit 2025 in the city of Kochi is now open, and I would now like to invite my very good friend Dr. Shyam Krishnan to take the proceedings for today's events ahead. Dr. Shyam Krishnan, please.
So, very good morning to all the delegates and the audience present here. It's a wonderful session we're going to have. I'm going to be the master of ceremonies for the day. I'm Dr. Shyam Krishnan. I work in Calcutta as a clinical and interventional pulmonologist. So, we're going to have an extremely fantastic day with insightful sessions and impactful discussions. I would encourage all the audience to please switch off your mobile networks and get your neural networks on. Ask questions. There's nothing called as a dumb question. Make most of the wonderful faculty lineup we have. And obviously, everybody stick to time. Interact with each other. Thank you, Professor Salvi and Dr. Dar and the faculty from the ERS to come over here and participate and make this a wonderful event. I would kickstart the day by announcing the first presidential lecture. This is on obstructive sleep apnea, challenges and future directions. I would invite Professor Mark Vitalis and our subject expert, Dr. K.P. Venugopal, to come on stage, please. So, Dr. Mark is a consultant and senior researcher at the Vall d'Hebron University from Barcelona, Spain. Dr. Venugopal is one of the senior faculties in Kerala. He is the professor and head of the Government Medical College, Ernakulam. So, over to you, Dr. Mark and Dr. Venugopal.
Thank you very much, and good morning all of you. I'm Marc Miravitlles from Vall d'Hebron Hospital in Barcelona, and it is my pleasure to introduce this presidential lecture. Professor Silke Ryan from University College Dublin in Ireland, and she will speak about obstructive sleep apnea, challenges and future directions. Silke?
Yeah, thank you, Mark, for the nice introduction. So, in my talk, I'm going to elaborate on some aspects in relation to obstructive sleep apnea, and I will particularly focus on some of the current challenges and controversies in the field. This doesn't work. Oops. These are my disclosures, non-relevant to this talk. So, obstructive sleep apnea is a condition which has rapidly and dramatically evolved into a substantial global public health burden. And this is certainly on one hand due to the very high and steadily rising prevalence of the condition. And according to this landmark paper published in 2019, we can estimate that worldwide about 1 billion middle-aged subjects fit the current diagnostic criteria of obstructive sleep apnea with an apnea-hypopnea index of at least 5 events per hour. And even if we use a more stringent criteria, which is at least moderately severe disease with an AHI of above 15, we are still talking about 425 million. In India, this correlates to expected national prevalences of 51.6 or 28.8 million respectively. So we are dealing with very high numbers, emphasizing that the condition still remains heavily underdiagnosed. However, on the other hand, many of those subjects who have sleep disordered breathing, so an elevated AHI, are not or only minimally symptomatic. And that raises these questions, do the nocturnal respiratory disturbances actually really matter? Well, in the majority of subjects they probably do, as obstructive sleep apnea has been identified as an independent, significant contributor to the development and insufficient control of numerous cardiovascular and metabolic conditions as listed here. And this confers substantial morbidity, mortality, healthcare utilization, and an enormous cost burden. However, treatment with continuous positive airway pressure, the treatment of choice for the majority of our subjects, which is highly effective in improving symptoms and improving quality of life, CPAP alone is not universally effective as treatment for cardiometabolic complications. And its role in cardiovascular diseases has particularly come into questions by these 3 randomized control trials. All these trials were secondary prevention trials in subjects with established cardiovascular disease. They had similar design, comparing CPAP to usual or standard care on the primary composite endpoint, which was reduction in mortality or reduction in major cardiovascular or cerebrovascular events. And as you can see, in intention to treat analysis, all these 3 trials were negative. So there was no benefit seen with CPAP therapy. And this has culminated in one of the most important questions in our field. Should asymptomatic or minimally symptomatic subjects with obstructive sleep apnea be treated? Does it make sense to treat them? Will it have an influence if you treat them? And if so, what should be targeted and how should we treat? Well, before dismissing CPAP therapy as a potentially important treatment strategy, it is important to note that all these 3 randomized control trials had significant and inevitable limitations. And this included, among others, the exclusion of the most sleepy subjects, and I will get back to that in a little while, and also the focus on established cardiovascular disease, whereby there is increasing evidence that obstructive sleep apnea is particularly even more harmful in the early cardiovascular disease stages, and hence treatment strategies in primary prevention may even be more effective. However, one of the most important limitations of these randomized control trials was the rather suboptimal compliance with CPAP therapy, which overall in the 3 randomized control trials was only 3.1 hours per night. and emphasizing the importance of this limitation in a subsequent important post-hoc analysis using an individual participant data meta-analysis was recently published in JAMA. Good CPAP therapy was actually associated with a significantly reduced risk for major adverse cardiovascular or cerebrovascular events with a hazard ratio of 0.69. Also corroborated by numerous data from large real-world cohorts, we can conclude that CPAP therapy for sure and certainly has an important role to play in mitigating cardiometabolic complications, but it has to be used to be effective, which of course makes a lot of sense. Certainly a better understanding of the mechanisms underlying cardiometabolic complications is going to be paramount to detect further on effective treatment strategies. And although we have made significant progress in this over the last few years, mainly due to preclinical and translational studies, the pathophysiology still remains incompletely understood. This slide summarizes in a still rather crude fashion our current understanding of the pathogenesis, and as you can see, it's a complex, multifactorial process, and obstructive sleep apnea comprises various potential triggering factors for adverse disease processes. But certainly and for sure, intermittent hypoxia, the hallmark feature of the condition, plays a crucial role. And as we and others have extensively shown, intermittent hypoxia is a potent activator of pro-inflammatory pathways mediated mainly through to the transcription factor, nuclear factor kappa B, and these pathways are preferentially activated over adaptive, hypoxia-responsive, potentially protective pathways. And that's very different to chronic sustained hypoxia, where these adaptive pathways predominate. And as a consequence, this imbalance leads in intermittent hypoxia to a low-grade systemic pro-inflammatory of CPAP therapy emerged in the latter group. So we are likely using the wrong diagnostic marker in our sleep diagnostics, and this is currently the focus of intense research. Furthermore, the clinical phenotype is very important, and particularly the presence of daytime sleepiness, which in various studies now has emerged as an independent contributor to adverse outcomes. is, for instance, highlighted here by this cluster analysis from the Sleep Heart Health Study, a large US-based population study which showed that the highest risk of incident cardiovascular disease was seen in the group of the most excessively sleepy subjects. So the clinical phenotype is important. So obstructive sleep apnea is a highly heterogeneous condition with many different phenotypes, and hence there simply cannot be a one-size-fits-all treatment approach. And that needs really personalized medicine. We need personalized treatment approaches. As I mentioned already, it's important that we better understand the pathophysiology, and although intermittent hypoxia is clearly one of the key or the key pathophysiological triggering factor, it's for sure not the only one. And this complex relationship with all these potential othering triggering factors needs to be better understood. Furthermore, there are many modifying factors in sleep apnea cohorts. The demographics, comorbidities, genetics, lifestyle, and they of course will influence the individual susceptibility to cardiometabolic outcomes. So hence, treatment strategies not only need to be personalized, they need to be holistic, taking this complexity into account. Of particular importance in this regard is to target obesity. Obesity, which is intimately linked with obstructive sleep apnea, with about 2/3 of obstructive sleep apnea subjects having a body mass index of 30 or more. And it's literally inconceivable of how much sleep apnea could be prevented if obesity would be adequately addressed in primary prevention. But certainly as a treatment strategy, we know that weight loss is effective in reducing the AHI, so reducing sleep disordered breathing. And this has recently shifted an immense focus on pharmacologically mediated weight loss, particularly due to the evolvement of glucagon-like peptide analogues. And these are the results of the recently published SURMOUNT-OSA trial, which compared the effects of the dual receptor agonist tirzepatide versus placebo in subjects with obstructive sleep apnea and obesity. And they were looked at in two different groups. In one, the CPAP naive patients, and in the second group, which were patients who were already on CPAP. And tirzepatide led to an expected weight loss of 20% over 1 year. And this was associated with a substantial reduction in the AHI. The trial also noted a reduction in blood pressure, particularly in patients who were naive to CPAP. And there was also a small reduction in C-reactive protein as marker of systemic inflammation. So certainly quite promising data, but nonetheless, we do need further data, and particularly we need further long-term data, particularly as we know that the weight loss effect will quickly be reversed once these medications are discontinued. Furthermore, there is still considerable differences, regional differences in the availability, accessibility, and reimbursement of these drugs. I believe it's still not available in India. In Ireland, where I work, it is available, but outside diabetes, for the majority of patients, it's not reimbursable. And this is a big problem and a big concern which certainly needs to be addressed. In terms of sleep apnea, we also need more patient-centered outcomes. Daytime sleepiness, quality of life, neurocognitive performance. It was quite bizarre that none of these informations were included in this paper. From a cardiovascular end side of view, we also need really long-term data. Outcomes, cardiovascular outcomes. That was the benchmark CPAP was compared with. So, and we don't have any data on that yet. And certainly a bit of a word of caution in this respect. We recently published these data from a proof of concept randomized control trials where we compared the effects of CPAP therapy to a glucagon-like peptide mediated weight loss on early cardiovascular disease. So we looked at early vascular inflammation, which was detected by highly sensitive 18-FDG PET-CT scanning. Now, small trial, as I said, it was a proof of concept study, but nonetheless we saw a significant reduction in vascular inflammation with CPAP therapy, and this was also associated with an improvement in endothelial function, and we did not see these responses with liraglutide, although a significant and effective treatment, weight loss was achieved. So, still a word of caution, we are not ready for prime time yet, but nonetheless the data of the SOMA and OSA trial are encouraging to give us a bit of a flavor of what could potentially be achieved if weight loss is targeted. So, in conclusion, obstructive sleep apnea is a highly heterogeneous condition, and a better phenotyping incorporating clinical, pathophysiological and sleep diagnostic characteristics is paramount to determine effective treatment strategies. As I mentioned, intermittent hypoxia is the key pathophysiological driver, so it needs to be targeted in any treatment strategies, but nonetheless any of those strategies need to be holistic, taking the complexity of obstructive sleep apnea into account. I thank you for your attention, and I'm looking forward to further discussion.
Thank you, Professor Ryan. That is a splendid presentation. And you have given an introduction, though very concise but very clear. And that leads to our next session. Let's see how sleep disorder breathing is connected with other chronic lung diseases. And for that, I would invite Dr. C. Vijaykumar, who is the moderator of the next session. And he is a consultant interventional pulmonologist and sleep disorder specialist from Apollo Hospitals, Hyderabad. Welcome, Dr. C. Vijaykumar. And also we have on the dais Dr. Arub Haldar, consultant pulmonologist, C.K. Birla Hospital, Calcutta. Welcome, sir. And Dr. Hiranappa B. Udnur, senior consultant pulmonary critical care and sleep medicine, Manipal Hospital and Baptist Hospital, Bangalore. And also Dr. Sandeep H.S., consultant pulmonologist, Sagar Group Hospitals, Bangalore. And over to you, Dr. Vijaykumar.
Thank you, Venugopal sir. A warm welcome to all the wonderful pulmonologists who have gathered across the subcontinent, more from the southern India. I am truly honored to moderate this session on interplay between chronic respiratory disease and sleep disordered breathing. I must and we must congratulate from the bottom of the heart for ICS and CIPLA for bringing in such a wonderful initiative to our doorstep and cutting the distance between Europe and India. And thank you, Rajabai, Salvi sir, Subhadeep and team for having me here. The next 15 minutes, we'll be dealing with a lot of interesting clinical scenarios where the inputs from the esteemed panelists will guide us and take us to a lot of practical take-home bullets so that we can manage our patients differently. We all know millions of people suffer from COPD and also from sleep disordered breathing. As Professor Ryan rightly said, so when the burden of sleep disordered breathing is close to around 936 million and COPD burden is close to around 300 million, with people suffering from COPD alone, they die close to around 3.2 million annually. These two diseases, when they overlap, they become more critical, and we know poor sleep quality can lead to respiratory exacerbations in COPD patients, and untreated respiratory diseases can worsen the sleep apnea. This is definitely a vicious cycle, and without wasting much time, I would love to call upon the opinion of Sandeepa to, what are the various diagnostic tools that are used for evaluation of sleep disordered breathing and COPD patients and chronic respiratory disease patients?
Yeah, the diagnostic tools, whatever we use for general sleep evaluation are the ones which we use in chronic respiratory disorders also. I think nocturnal oximetry is there, nocturnal capnography is there, and our standard level 3 and level 1 polysomnographies are there. But capnography is not readily available, it is very costly. I think we don't generally practice using capnography in our clinical setup. So what we are using is standard either level 3, if the preclinical probability of sleep apnea is very high, or level 1. Gold standard is level 1 polysomnography is what we are using to diagnose the sleep disorders.
Thank you, Sandeepa. So, to Arup, why is polysomnography is called as a gold standard, and can we, because the cost is involved and availability of level 1 sleep studies across India is also a challenging factor, what do you think, can level 2 be replaced with level 1?
Very good morning. So the first question first. So chronic respiratory disease and obstructive sleep apnea has a very complex interactions. So it is not only the obstructive apneas, sometimes there may be central apneas, sometimes there may be sleep disorder, there may be nocturnal hypoxemia, nocturnal hypoventilation, there may be flow limitations leading to arousals. So there are a lot of things which can happen when the two diseases overlap. So definitely a level 1 polysomnography is the gold standard. Level 2, no evidence, but still you can use, and this is always better than the level 3 and level 4.
Thank you. And to Professor Ram, so what is with the established diagnosis of sleep disordered breathing in chronic respiratory patient, what is the role of therapy across the spectrum of chronic respiratory diseases? Can you please brief it, ma'am?
Yeah, I mean, in terms of the overlap syndrome, which, as you mentioned, is very common, it depends really on the clinical presentation, and that's really important. So particularly if a patient has predominant obstructive sleep apnea and also has typical clinical symptoms, you definitely want to treat them with CPAP therapy. Certainly that should be your first goal, regardless of the overnight oxygenation and the severity of respiratory failure. If you have a reasonably asymptomatic patient, then it becomes a bit more challenging, and really then the severity of the nocturnal oxygenation is really important, and particularly with REM-related hyperventilation, which can be really severe in overlap patients, then you may want to initiate positive airway pressure to avoid progressive chronic type 2 respiratory failure. So it depends on the clinical scenario of the severity of the two conditions, and then you need to take a approach which takes this holistic way into account.
Thank you, Raya. Dr. Udnur, anything you want to add here?
Yeah, it all depends whether they are in acute exacerbations and COPD respiratory conditions. Then the role of NIV starts there. There we don't make a long-term assessment for what type of therapy is required. We try to get them, there might be some infection, fluid, or some other infection that we treat with a simple bi-level machines and with the backup ventilation.
You say that probably there is a type 2 retention starts, then probably roll of NIV
NIV if it is there, and then we make their condition improve, get them more stable, reverse the precipitating conditions, then look at what is the exact disease is there. If it is a COPD and OSA overlap, we just don't need pneumatic splint like CPAP. We just need something which causes ventilation based on their CO2 and all. Then we are roll off bi-level PAP, and
we'll come there. We'll discuss about the role of CPAP and BiPAP as well. So coming to Dr. Arup, is there any role of just nasal high flow therapy in this overlap syndrome?
So, in one word, we do not have any evidence. We have evidence for HFNO in COPD, HFNO in OSS separately, but when combined together, there is no evidence. But the question is why you want to use HFNO.
Right.
So, HFNO produces a little amount of PEEP. So, that is available on CPAP. So, there is actually no rationale for using HFNO unless there is some specific indication, patient is intolerant to CPAP or any other therapy, you can try, but no evidence till now.
That's a wonderful point. Those patients who doesn't tolerate CPAP or NIV or BiPAP, probably, we can jump and initiate, at least to add that additional PEEP and then maintain the oxygenations, avoiding the nocturnal hypoxemia. Next slide. Next slide, please. So let's discuss a case scenario here briefly. This is about a 69-year-old male presented to outpatient department with complaints of worsening shortness of breath over the past few months. Past medical history suggestive of ALS, which is a neuromuscular disease we all know, and diagnosed almost 10 years back. He is becoming more breathless, though he is conscious, coherent on examination. There was mild tachypnea with normal saturations and pulse rate of around 102, blood pressure of 130/80, raised JVP, bilateral pitting edema. Next slide. Can you please change the slide? Yeah, this is the PFT showing a restrictive defect, and then ABG showing a pH of 7.34, PCO2 of 57, 52, PO2 of 57, bicarb of 35, which says it is chronic retention, chronic respiratory acidosis. Next slide. So, to Professor Ram, so what is the pathophysiology of sleep-related hypoventilation? Can you please summarize as quick as possible?
Yeah, so in general, sleep has a negative effect on ventilation, even in normal subjects. So we all reduce our ventilation, but in normal subjects, that's not going to have any pathophysiological consequences. But you generally have, if you have patients who have an underlying respiratory condition, and particularly obstructive defects, you generally, even without an overlap syndrome, going to have a reduction in respiratory drive, you have a reduction in muscle function, and that leads, particularly during sleep and also during exercise, to profound hyperventilations. In sleep, that is worse in REM situations, and that slide actually summarizes this very well. So the upper airway is important, muscle function, the central drive. So it's a complex relationship. The case you describe here with the ALS, obviously the muscle function has a profound impact here. You see the reduced or the highly or severe restrictive defect. So lung volumes are small. You missed kind of the boat already. I probably come to pass it on to the panel.
Thank you. To Udnur, how to initiate NIV in these patients and when to initiate, and to Professor Arup, how to sustain this and how to maintain this, initiation of NIV and then maintenance of your comments, Udnur and Arup.
Eventually the ALS, if it is a progressive disease.
Can you please louder?
ALS is a progressive disease and he has sustained for 10 years like that, and when you see this ABGs, there is a more than 10 mm increase in CO2. That's the diagnosis of hypoventilations. So during the night when there is a REM sleep and where all the systems of muscle tone will decrease, that will increase the CO2 in the morning.
Right.
Ultimately in the night time, they might end up having some kind of ventilation strategy for a long term. So if it is progressive disease, it needs, the timing has to be correct. When the ABGs are 7.34, 7.3 and the CO2 is going up, they initially start with a nocturnal ventilation in terms of PAP therapy.
Right. Arup?
So there are clinical symptoms which suggest patient is having nocturnal hypoventilation like restless sleep, morning headache, confusion in the next morning or daytime sleepiness. There are some ABG-wise finding like daytime hypoxemia suggests nocturnal hypoventilation. So in those patients you have to check the morning ABG or you can do transcutaneous CO2 during your PSG. And there are spirometric criteria. In Duchenne's it is, in ALS it is said that if the FVC falls less than 80% even, so you have to check for the nocturnal hypoventilation and hypoxemia and you can start treatment at that stage itself. But it varies with different neuromuscular diseases.
Thank you, Arup. So, to Udnur again, any relation between sleep disordered breathing and then recurrent respiratory infections?
Yeah, sleep fragmentation is one of the things which causes immune dysregulation also. They are more prone to viral infections. They are more prone to infections as such. And as you said, the previous slide, Madam has mentioned, pro-inflammatory markers and recurrent hypoxia. They're all, it's a pro-inflammatory setting. So if there is something which is going on, even a small amount of infection can have a profound effect on patients who have already compromised because they are not using a CPAP and all. They are OSA patients, they are undiagnosed. If they get infection, their effect will be large compared to a normal counterpart. They may get for hypoxia much earlier. That's why obese patients are more prone to hypoxia, acute respiratory failures and infections. So that's how they are more prone to infections.
Thank you. To Professor Ryan, how does COPD and OSA result in complex cardiovascular outcomes? Can you please summarize?
Yeah, a lot of uncertainty in this area, so I can't give a proper answer. I mean, this is a paper which is from our group. So you have the two diseases which themselves contribute to complex cardiovascular complications. I mentioned in my talk the relationship with obstructive sleep apnea and systemic inflammation, and then the COPD. We are not yet there that we understand if summative effect from both conditions, but we need still to know more data on that.
Thank you, Raya. And to Sandeepa, how effective is CPAP therapy in the overlap syndrome?
Definitely it is effective. The literature has been very well proven that the initiation of somebody who is having a COPD with OSA overlap on CPAP therapy is known to reduce the number of exacerbations, and there are some mortality benefits also. Right. So there is no doubt that if at all somebody is suffering from COPD OSA overlap, there should not be any hesitation in starting them on CPAP therapy as early as possible.
And to Arup first, so it is very common for us to see the patients with severe emphysema and some may be having bulle as well. How to initiate a CPAP therapy in such patients?
So here I will actually differentiate between severe emphysema and bulla. So if the patient having severe emphysema, definitely there is higher chance of for the patients. So you have to be a little bit cautious.
Right. Thank you, Arup. And coming to very, very interesting area, that is pulmonary hypertension in sleep disordered breathing and sleep disordered breathing in PH patients. Quickly, in 30 seconds, can I have the opinion of Udnur and Sandeepa?
Yeah, so normally when we see a sleep apnea, it's other way. PH is secondary pulmonary hypertension because of OSA also. When you have a sleep disorder, patients already diagnosed. So if they are diagnosed and they have a PH at first instance, the most important cause will be OSA related PH. So we need to treat the OSA appropriately, see for 3 or 4 months, see the response and repeat a echo. If the pH comes down, the OSA itself is a cause for pH because of recurrent hypoxia. So it is reversible. It's one of the reversible cause of pH. So if it keeps persistent, we have to look for other causes of pH in this setting.
Right. Sandeepa?
Yeah, I totally agree with Dr. Hiranyappa. Basically, see, majority of the times OSA patients will present with some amount of pulmonary hypertension. There is no doubt. Otherwise, it is vice versa also. First, we diagnose pulmonary hypertension on echo, and then they refer to us for the sleep thing. If at all OSA is proven, and starting them immediately on CPAP therapy and monitoring them closely will definitely give us an indication whether it is really due to OSA alone or whether there is anything additional along with the
Both of them very clearly mentioned identification and then treatment, initiation of treatment of both the things together plays a very significant role. And can I have any audience questions before the conclusion? And I'll just conclude and then we'll take the audience questions quickly. See, overnight oximetry alone should not be used to diagnose sleep disordered breathing in patients with chronic pulmonary disease. Overnight capnography as a standalone diagnostic tool should only be used in patients with neuromuscular disease, and overnight polysomnography level 1 should be the first line diagnostic test in patients with severe respiratory disease when sleep disordered breathing is suspected. Always recommend to manage hypoxemia and hypercarbia together, and no to minimal role of high flow nasal therapy in management of overlap syndrome. Early identification and initiation of PAP plays a key role in management of hypoventilation. SDB plays a key role in chronic respiratory infection diseases via mutually exclusive and combined pathways of systemic inflammation, and overlap of pH and SDP and vice versa is a common entity, always suspect and manage together. 1 minute for questions.
Audience, please be proactive. Yes.
Asmita ma'am.
Thank you for the discussion, Vijay. My question is very clinical question. I have recently, day before yesterday, one patient who had BMI of 24 and his AHI was 13 and his lowest saturation during sleep study was 73, and he is not comfortable with CPAP, and he is well-learned person, and he told, don't you think this falls into mild OSA? Do you think I have to use CPAP? And when I evaluated him further, his history said that he has epilepsy. His MRI brain showed that he had 2 episodes of stroke, and there are ischemic changes in his brain. And I could not find central sleep apnea in his sleep study report, but I am really concerned that he might have central sleep apnea. And suppose if he really have got central sleep apnea, what will be the treatment for him in this particular clinical case which I have put?
So, Professor Asmita is,
I couldn't quite hear the question. It's very difficult to hear actually what you say in the audience. I got glimpses of it.
One-line summary of your question.
Yeah, I have a patient with central sleep apnea, suspected central sleep apnea with AHI of 11, BMI of 24.
So
and
very low BMI, and then patient is having it's only moderate AHI
of 73% in sleep study.
Central sleep apnea due to?
I am not sure he has central sleep apnea, but I am suspecting, considering his stroke episode, he is hardly 45, he has 2 strokes and he has history of epilepsy, and now he is not willing to start CPAP because he feels that AHI is only mild. Why should I use CPAP? He is learned person. So, and my doubt is whether CPAP will cure him, because I have my own doubts about CPAP is the best treatment for such patient whom I am suspecting central sleep apnea.
Yeah, but you don't know what you're treating, and that's the big controversy in the field. No? I mean, we have 1 billion people with an AHI of over 5. A lot of them have probably no clinical syndrome. They don't have a clinical disease. And that's what we need to figure out. I mean, in this case, you obviously want to know what the origin is of the central sleep apnea. That's probably
No, I want to know the treatment part.
Yeah, but no, you need to know when you apply a treatment of what is the cause, because the treatment will be very different. Is it a hypocapnic or is it a hypocapnic central sleep apnea? So is it due to cardiac failure or is it due to a hyperventilation disorder? And if it's due to a hyperventilation disorder, obviously in your case it might be due to the strokes, no? But with an AHI of 11, probably very low oxygen desaturation may have no real clinical relevance. Important is to see the patient if he's symptomatic.
He has daytime sleepiness.
He has daytime sleepiness, and then you obviously want to know, is the central sleep apnea contributing to it? So you may give him a trial for CPAP therapy. Maybe you need ASV to manage the patients properly. And then give him 3 months and see if he clinically improves. That's for me much more important.
May I request Asmita, let's discuss, okay, together. Thank you, Professor Ryan. Thank you, Arup. Thank you, Udnur. Thank you, Sandeepa. Venugopal sir, thank you so much. Right. One picture, please.
We move on to the next session. So this is the first session of the day after the presidential lecture. So the next session I'm about to kickstart is exploring the frontiers in airways disease. So this particular session is going to shed light on the latest trends in the management of COPD, asthma and small airways disease. So brace yourself for this interesting session. So to chair this session I would invite Professor Carlos Robalo Cordeira. He's a pulmonologist at Coimbra University Hospital, Portugal. And I would invite our subject experts, Dr. George Justin and Dr. Palni Vale. So, Professor Carlos. Yeah, Dr. George is a consultant pulmonologist at Medical Trust Hospitals, Kochi, and Dr. Palni Vale is a professor and HOD of Mahatma Gandhi Medical College, Pondicherry. Over to you all, chairpersons.
Thank you. It's a great pleasure to share this session together with Dr. Pajanivel, Dr. Justin. This is a session on new frontiers in airways diseases. And my pleasure is to introduce you the first speaker, Dr. Mark Miravitels. He was already here. He is a senior scientist and a pulmonologist at Valdebron University in Barcelona, and he is the Vice President of the European Respiratory Society, and he will speak about personalized treatment goals in COPD. Please, Mark.
Thank you. Thank you very much, Carlos. Good morning. During the next 15 minutes, I will try to guide you through the treatment of COPD, and in particular to the treatment of the most severe patients with COPD, the most challenging patients with COPD, those with frequent or severe exacerbations. These are my conflicts of interest. And in fact, the aim of my talk is to show you the different profiles of patients with COPD, how can we use biomarkers to identify response to treatment, and discuss some of the algorithms for treatment of this disease. Well, basically the objectives we have with the treatment of COPD are two: to reduce symptoms, to reduce the impact of the disease in the patient, and to reduce future risk. Basically, risk of exacerbations and risk of death. This is what we're trying to achieve with our treatment. And for this, the GOLD strategy issued these recommendations in 2025, in which they classify the patients according to symptoms and risk of exacerbation, and recommended initial therapy basically with bronchodilation, long-acting bronchodilation, two or dual bronchodilation. There are two exceptions: patients who are very mild, in which one bronchodilator may be enough, and patients who are severe with frequent exacerbations, and an eosinophilic profile that may require adding an inhaled corticosteroid. But apart from these two exceptions, initial treatment of COPD consists of dual bronchodilation. And patients who, despite dual bronchodilation, still have symptoms or exacerbations, there are other strategies, and in these cases, we need to focus more on the characteristics, the individual characteristics of each individual. There are other options, and I want to share with you our Spanish national guideline, in which we classify patients initially into low and high risk. The reason is that patients considered at low risk can be managed in the community by general practitioners. They do not require extensive investigation, and these patients can be identified because they have low levels of symptoms, no exacerbations, and a relatively preserved lung function. These patients should be treated exclusively with bronchodilators. But patients at high risk, they may require different treatments according to the presence of exacerbations and the phenotype of these exacerbations. But again, LAMA, dual bronchodilation, will be the initial treatment for the majority of these patients with COPD. And why we choose LAMA or dual bronchodilation as initial therapy? Well, there are different evidences, there are different clinical trials that show how dual bronchodilation is superior to one bronchodilator, and also that dual bronchodilators are superior to LABA ICS in preventing exacerbations, such as the FLAME trial. Well, some people criticize this study because they said that most of these patients had just one exacerbation in the previous year, which is true. But in the community, in general, the majority of patients with COPD have either 0 or 1 exacerbation in the previous year. Therefore, these results, the results of the FLAME trial, apply to the majority of patients with COPD. But what about the patients who are more frequent exacerbators or more severe exacerbators? Here is where triple therapy may play a role. But in which patients and when to introduce triple therapy in the treatment of COPD? Well, we have two large trials, the IMPACT and the ETHOS trials, but the first observation is that these trials did not include naive patients. This is not initial therapy. All of these patients were already on treatment, and in fact, in more than 50%, they were already on triple therapy. And they were patients who had an FEV1 below 50% predicted and frequent or severe exacerbations despite inhalation therapy. In these studies, and in particular, these are results from the IMPACT trial, triple therapy was superior to LAMA. But the results showed a difference of 0.3 exacerbations per patient per year as a difference between LAMA and triple therapy. Does it justify triple therapy for everybody? Well, in order to answer this question, investigators from the group of Leuven in Belgium, they analyzed individual data of the IMPACT trial. So here you have the results of the global trial, in which triple therapy was better than dual bronchodilation. But if you look at individual patients, there are some patients in green who have a response that is better than the general response. So they respond a lot to ICS. In yellow, in the middle, there are patients who have an average response, like the mean or the median of the response of the trial. But more interestingly, on the right, you see patients in red who have a lower response, a worse response than the average. But it's not just that they have a lower response, but they may have side effects associated with the use of inhaled corticosteroids. And they try to investigate which were the biomarkers, the factors that identify patients who had a better response. And not surprisingly, the blood eosinophil counts was the best biomarker to identify this population of responders. And those patients who had more than 100 or 150 blood eosinophils, they had a better response to ICS. Or in other words, they had more exacerbation if they were not on ICS. In contrast, patients who had less than 100 eosinophils, they did not respond to ICS whatsoever. And in those patients, the use of ICS was not associated with better outcomes, but in contrast, they could be associated with increased side effects. We know that the use of inhaled corticosteroids may change the microbiome and may increase the concentration of bacteria that usually cause exacerbations of COPD and also bacterial pneumonia. And several trials have shown how there is an increase of pneumonia associated with the use of ICS in COPD. But not only pneumonia, not only bacterial exacerbations, also mycobacterial infections are associated with the use of inhaled corticosteroids. And this may be particularly important in areas in which there is a high incidence of mycobacterial infection. In this cartoon, it is summarized what we know about the use of inhaled corticosteroids in COPD. So on the right, patients who have higher blood eosinophil counts, they have a better response to ICS, and this is a marker for T2 inflammation. In contrast, on the left, patients with low blood eosinophil counts, they do not respond to ICS, and they have an increased risk of bacterial infection. We have evidence, we have clinical evidence for this, and this is a very interesting study on patients with COPD and associated bronchiectasis, patients who are more severe, patients who have frequent bacterial exacerbations, and you can see again on the right how patients in red who were on triple therapy, on ICS, they had significantly less exacerbation when they had more than 300 eosinophils. So there's no question. Patients who have more than 300 eosinophils must be on inhaled steroids. But on the contrary, if you look at the left, patients who had less than 100 eosinophils, those on ICS in red have higher number of exacerbations compared with patients treated with only long-acting bronchodilators. Therefore, triple therapy, ICS, is not for everybody, not even for all patients with frequent exacerbations in COPD. So here we try to summarize how you can use blood eosinophil counts to guide your treatment with ICS. In green, on the right, patients who have more than 300 eosinophils, again, they must be on inhaled corticosteroids. Then patients who had less than 100 eosinophils in red should not be on inhaled corticosteroids. And you have a group of patients in between 100 and 300, in which you need to make individual decisions based on other markers, on the frequency of exacerbations, the type of exacerbations, smoking habits, and other biomarkers, for example, such as XL-NO, that will help us to identify those patients who will respond to ICS. And how many patients have more than 300 eosinophils? So this is why we investigated this in a large population, more than 50,000 patients with COPD, looking at the electronic medical records, and we identified between 25 and 30% of the patients with more than 300 eosinophils. So these patients are those who must be on inhaled corticosteroids when they suffer from exacerbations. But what can we offer to patients who are already on inhaled steroids and they have low blood eosinophil counts and they don't respond to inhaled corticosteroids? Well, now we know that we can discontinue these patients from ICS safely. And this is the recommendation of a recent short ERS guideline on withdrawal of inhaled corticosteroids that I had the opportunity to co-chair with my friend James Chalmers, and we could establish a recommendation to discontinue ICS in patients who had less than 300 eosinophils and infrequent exacerbations. These patients should not continue treatment with ICS because they are not useful and they are associated with side effects. But what can we do for patients who don't respond to inhaled corticosteroids but still suffer from exacerbations? There are other strategies, other pharmacological and non-pharmacological strategies, and Judith will talk later about rehabilitation, physical activity, which is also useful for these patients. But in terms of pharmacological intervention, we have mucolytics, antioxidants. For example, N-acetylcysteine at high doses, 600 milligrams twice a day, is effective in reducing exacerbations of COPD and is a very safe treatment. Patients who have frequent bacterial exacerbations may also be treated with long-term macrolides. And in this study, the Columbus trial, these patients had at least 3 exacerbations treated with antibiotics the previous year. And when these patients received long-term azithromycin, there was a reduction of 40% in the prevalence of exacerbations. This is a very important effect. But you need to remember that this treatment is associated with side effects, and also you need to make sure that your patient does not have any mycobacterial infection before starting the treatment. So this must be reserved to reference centers. And for the future, we have the biologicals. There are several biologicals developed for asthma, and they are now investigated in COPD. We have dupilumab that has been accepted in Europe for the treatment of COPD based on trials that demonstrate a 30% reduction in exacerbations in patients with an eosinophilic phenotype again and chronic bronchitis. So in summary, this algorithm may summarize how can we manage patients with COPD, and in fact it has 2 different steps. The first step is for all patients with COPD. They should all be on optimal bronchodilation, in the majority of cases with a dual bronchodilator, but in some cases perhaps with just one bronchodilator. Patients who, despite LAMA, 2 bronchodilators, still exacerbate, then they need a second step, a more specialized approach. And then we need to treat these individuals according to their phenotype. If they have an eosinophilic phenotype, ICS are mandatory, and in the future perhaps biologics. But if these patients, on the contrary, they have bacterial exacerbations, low levels of eosinophils, we need to use mucolytics or long-term macrolides. So in summary, COPD is a very heterogeneous disease. The exacerbators are the most challenging patients with COPD. Treatment for these patients must be personalized according to the phenotypes and biomarkers. Unfortunately, the control of COPD is an achievable goal of therapy even in these more challenging patients. Thank you for your attention.
Thank you, Mark. Please join us for the final discussion in the respiratory medicine in Paris and the head of the pulmonary department at the Hospital Cochin in Paris. And he is the Science Council Chair of the European Respiratory Society. He will speak about personalized treatment goals in asthma and the new concept of remission. Nicola.
Thank you very much. Actually the topic of my talk is remission for asthma, and the specific question which is asked is remission the right target? And my answer will be that remission is a right target, one of the right targets that we should have for asthma, maybe not the right target in that maybe it's not achievable for all patients, but this is what we are going to discuss. These are my disclosures. And basically what I would like to take you through is first to define what remission means for asthmatic patients and what the implications of this concept of remission are for our management, because the ultimate goal of having this in our minds is to improve the management and the outcomes of our patients. And of course, there are still several research questions that we need to address. So, first, if you go through the goals of asthma management, and this is what Gina tells us, what Gina tells us is that we need to try to achieve no symptoms, no exacerbations, no intake of corticosteroids, and as normal as possible lung function on a long time basis. So this is quite obvious. If you achieve all of these goals, this is when you can speak of remission. And this has been done in other inflammatory diseases, chronic inflammatory diseases, especially in the rheumatologist field or in the inflammatory bowel disease field. One question in each of these fields is, for talking about remission, are you talking about this for patients who are still on treatment, or will you require them to be off treatment? And actually these are two different types of remission. And as you can see from what I'm saying, this is a lot about definitions. So here is a kind of a history of the terms that we've been using for our patients to illustrate our goals. And we went from control in the early 2000 to total control mid-2000, mid to end 2000. Then we mentioned the term super response, which arose when the biologics came to us and to our patients. And now we are talking about remission. And it's not only one type of remission, it's several types of remission. You see here, clinical remission, no symptom, no exacerbation, no intake of oral steroid. Biological remission, FeNO down, EOS down, and maybe the pathological features in our bronchi also down. Complete remission when you get everything, clinical and biological remission, and sustained remission, and some are even talking about deep remission, whatever it means. What this shows is that there is really a paradigm shift from symptoms control, disease control, to disease modification. And that's what's under the term remission. It implies that you have been able to really deeply modify the course of the disease from both a clinical and a pathological perspective. And the first message I want to take through to you is that what it means is that we need to raise our ambition, and our patients and ourselves need to raise their expectations. And that's very important. We should not basically tolerate symptoms on a daily basis or even on a weekly basis. We should not tolerate exacerbations. We should not tolerate oral corticosteroid intake. And why shouldn't we tolerate these? Just because we can achieve our goals. And that's very important. We have now treatments that allow us and allow our patients to reach these goals. Going back to the definitions, and again it's a bit of history. Concept of super responders, which arrived with the biologics, as I said before, you can see that two major criteria needed to be achieved. 2 of 3. And you see these 3, which is exacerbation elimination, asthma control from a symptomatic perspective, and cessation of oral corticosteroids. You needed 2, which means that you could tolerate 1, which is wrong in a way if you are really ambitious. And this is why we went to remission. This is a bit busy, but basically the message is that to talk about remission, we need to achieve all our goals, and we will not tolerate one of the goals not being achieved. And again, we are talking about remission because we know we can make it, at least for a high proportion of patients. How can we achieve this? Before, on the left part of the slide, the typical way of adapting the treatment was that you had these goals in mind, you tested one treatment, not sufficient, you increased the treatment, you increased the treatment, and you had this step-by-step increase of treatment. Now, you go to the right of the slide, the paradigm again has shifted to really individualizing care for our patients. We are in the era of precision medicine, P4 medicine, whatever you call it. We need to individualize treatment, which means that we need to phenotype our asthmatic patients, as for COPD. We need to phenotype them, we need to identify the clinical traits, the biological traits, all the treatable traits at large that we want to treat. And if we are able to identify all these traits and manage them, we might be able to achieve remission. And maybe, if you have this ultimate goal in your mind, maybe we will achieve cure. Everything in what I'm saying is referring in a way to disease modification. That's what you can see on the left part of this graph. The idea is that if you put the patient on a disease-modifying agent, on a disease modifier, you will be able to decrease the classical ICS-based maintenance treatment and obtain the remission, maybe the cure. What I'm going to tell you is that at present, when we are talking about disease-modifying agents, we are mostly referring to biologics. But ICS may also, in a way, in some patients, help us achieving remission. So one of the messages is that it's not only a question of biologics. Of course, biologics changed a lot the situation and helped our patients a lot, at least some of our patients, and probably more in the future. But it's not only a question of biologics. Definition, and just to show you that in almost all the guidelines on asthma now, the term of remission is present, although with slightly different definitions, which is of course problematic, because if we have a target, we need to be able to define it and to know what we are really talking about. I will show you two slides with the proportion of patients achieving remission, depending on the definition of remission. These are severe asthmatics treated with biologics, several types of biologics, which is globally a lot, but the range means that it's not very well defined. So, we need to have a better definition. If you go now, maybe I can switch to the other microphone. If you go now to this four-component definition, which is the same as the previous one, but with one function added.
Nicola, sorry, can you go to the podium microphones, because we are not listening very well.
Yes, maybe. Okay, I will continue like this. So, you have this four-component definition, and now the range of remission is from 20 to 70%. Again, there are two messages here. One is that it's a lot, so it's achievable, and the second is we need to standardize the definition in a better way. So, another message I already got through to you was that it's not only a question of biologics. This is a study which was done which was released in the early 2020, but the data came from 10 years before, 2012. And what you can see is that the proportion of patients in this study from the general population, the proportion of asthmatics achieving remission was almost 50%, which is enormous. And these patients were not all on biologics. The only one which was available at this time was omalizumab, and it was only for a very tiny minority of allergic patients. So we don't need biologics for all patients to achieve remission, and this is exactly the same that we can see here on this slide. If you go to the right, patients on inhaled therapy, you have 60% achieving partial or complete remission, which is a lot without any biologic. So a message here is that we need to individualize not only the choice of a biologic in the most severe patient, but also the choice of the strategy of maintenance therapy. You know these two tracks of GINA, track 1, which is the preferred one, and track 2. We need to choose the best one for each individual patient, and all patients are not the same in that respect. Another very illustrative example which I like is this study of a biologic, whatever it is, it doesn't matter. And what you see is the proportion of patients again achieving remission on the biologic in green or on placebo in black. And you see that it's a significant proportion on placebo. So again, we need to do our best, and doing our best is not only a question of adding medications to maintenance treatment. It's also a question of supporting the patient, ensuring that the patient has the proper education to use the inhaler, has the proper adherence, that all the aggravating factors that we know, smoking, obesity, are managed, and that we do our best to help the patient with these and with all the exposures of the patient. So it's a lot of work, but it's really worth it. Another thing that is absolutely mandatory is that we improve the way we taper down the oral corticosteroids. This is not very well standardized. Actually, it has been standardized in randomized clinical trials, which was very nice, but we also need to standardize it in our clinical practice. Otherwise, sometimes we can't really obtain the withdrawal of oral steroids just because we didn't do it the right way. So it needs to be standardized. There are other drugs such as azithromycin, other than biologics and other than the classical ICS-based maintenance treatment, that can help us, at least in some patients, achieving remission. And you see here the proportion of patients achieving remission from those on with an eosinophil type of inflammation, eosinophilic, and those with a neutrophilic type of inflammation. And it's working for both of them. So this is something we need to have in our bag of possible solutions. And finally, if we want to achieve remission, we believe that the drugs that help us doing so are disease modifiers. These drugs have an effect on the pathology of the disease. And actually, we can suspect this from the effect on mucus plugs, because mucus plugs come from goblet cell metaplasia or glandular metaplasia, so this is a pathological feature in asthmatic patients. And we also see some disease modification in terms of other components of the remodeling, namely the subepithelial collagen thickness, the smooth muscle thickness, or the epithelial damage, and this has been obtained with omalizumab and mepolizumab and can be with others. So to conclude, we have a better understanding on the pathophysiology of asthma. We have more and more treatment options, so we need to improve our ambition. We need to improve our management. There is room for new drugs, but not only for new drugs, we also need to improve the way we support the patient in all the aspects of the disease implications. And there are some questions, I won't go through all this list, that we still need to answer in terms of what are the predictors of the remodeling process and the success in controlling the remodeling process. Thank you for your attention.
Thank you, Nicola. Please join us. It's my pleasure now to call Professor Omar Osmani, Professor of Respiratory Medicine at Imperial College in London and also a senior physician in the Royal Brompton Hospital and St. Mary's Hospital in London. And Omar will try to convince us about the importance of small airways diseases.
Carlos, thank you very much for the introduction. Thank you, Raja and Sandeep, for the invitation to the Indian Chest Society. So, over the course of the next 15 minutes, I'm going to put to you that in our clinical practice, we need to think about small airways disease in our patients with asthma and in COPD. It's really quite important. But also, secondly, that small airways is a phenotype across all of respiratory disease, interstitial lung disease, sarcoidosis, obviously transplant medicine, and respiratory infections. So, this is a state-of-the-art review that we wrote in Chest a few years ago with Mei-Lan Han, Jim Hogg, who you know has been involved in 60 years of research in COPD, and I'll be picking on these 7 pillars of this Greek temple, which ranges from physiology, pathology, all the way through to pharmaceutics. So let's start. How do we define small airways? They're defined as a diameter of 2 millimeters. Why 2? Why not 7, 10, 13? Because balloon catheters that were put into dogs in the 1960s by physiologists to look at pressure flow measurements proximal and distal to a balloon that was blown up. It just so happened that the balloon was 2 millimeters in diameter. So that's where the definition comes from. The second point I want to say to you is when I talk about small airways, I'm not talking about airways that are really, really deep down. These airways are quite proximal. So when you and I do a bronchoscope, we can see generation 3 or 4. The small airways start at generation 7. So just 3 or 4 beyond what you and I can see in a bronchoscope. So key point, the small airways are quite proximal, and therefore we need to think about treating this area. Can I put it to you, this is the Weibel's model, who was the Swiss anatomist, this was his PhD in 1963. Can I put to you that if you add the surface area of the large airways, which you see in yellow, it's the size of a post-it note, yeah, 20 centimeters squared. If you put the small airways, which you see in purple, together, it's the size of a Monopoly board, 2,000 centimeters squared. So can I...
Sorry to disturb you, Homer, but I was asked that maybe it's better to be in the podium because there are some technical problems with our microphone. Thank you.
Of large airways versus a Monopoly board of small airways, the purple, really, can I put it to you that the immunopathology of the small airways actually contributes as well? So if we move on, what's the evidence then for this? So this is Qutayba Hamid's data, and I always show it from his seminal paper, where he took endobronchial biopsies, and you see that in blue, and transbronchial biopsies, and you see that in red. Now choose your cell of choice on the x-axis, and what you see is the blue bars are equivalent to the red bars. So what is that telling us? Inflammation is throughout the large and small airways. And I describe it as a mucosal carpet of inflammation. And actually this mucosal carpet starts here at the nose and goes all the way through the large airways to the small airways. And you need to treat the whole airway tree and before your patient actually improves. So if we look in COPD, we see the same thing. We see that here in Jim Hogg's data, airways, small airways defined less than 2 millimeters in diameter. Again, on the x-axis, look at your cell of choice, and what are the 3 key things you find? First, small airways inflammation is present even in mild disease. So we must think that even in mild COPD, mild asthma patients, small airways disease is prevalent. Second, inflammation worsens with worsening disease severity, and you can see that really, really clearly with respect to the way that the curves go up. And then for third, he showed this 20 years ago that eosinophilic inflammation is present at all stages, and you see that very clearly there, a third across this goal 0 all the way through. So the small airways are the major site of airflow limitation. We were all taught in medical school that it's the large airways that contributes to the physiology, and that's incorrect. It is in healthy subjects, but in disease subjects, when you look at the peripheral resistance and the total resistance in asthma and in COPD, it's the small airways that's the major site of airflow limitation that then leads in this red arrow that you see the trajectory of air trapping, lung hyperflation, physical deconditioning. So we understand the pathology, we understand the physiology, and now the concept that I think we need to re-explore and has been lost over the last few years is ventilation heterogeneity. So you see this pathology, or the differences in the pathology. We've heard of fibrosis and airway inflammation and remodeling and airway smooth muscle and mucus plugs. Well, this pathology is heterogeneously distributed in the airway tree. So what we need to understand is the ventilation heterogeneity, the irregularities of airflow throughout the whole lung in order for us to understand how the pathophysiology of the lung contributes to the patient's clinical symptoms.
So over the course of a few years, we've actually now expanded our ability to address small airways dysfunction. So these are two articles that we wrote about 10 years apart. The first one, which is now actually in the European Clinical Respiratory Journal from 2014, one of the most highly cited papers on tests for small airways. And you can see now the trajectory on the right-hand side to the paper that we wrote 2 years ago. And I'm going to pick up on some of these tests. So, in a research environment, to give us confidence of small airways being a phenotypic entity, parametric response mapping, which you see here, which looks at 3 indices. So first of all, how do you do the test? You take CT scans, you superimpose software, and then during your pixelated assessment, you can look for 3 indices. First, normal lung tissue. Second, emphysematous lung tissue. And third, a concept or an index called FSAD, functional small airways disease. So this has been used in the COPD gene study, and here's a paper by Craig Galbane. He was one of the first authors in 2012 who published this work in Nature, and this has come quite far in the last 10 years. So imaging from a research perspective gives us confidence that small airways are a phenotype. Now, oscillometry, and you in India are quite versed now in oscillometry, and certainly Sandeep has, with Disha Gopadi, has set up the ERS network, which is involved in oscillometry assessment, and I've been You see the red line, which is the resistance line, the blue line, which is the resistance line, the red line, which is the reactance line. And what you can actually see is that they are curved. So think of it as a musical instrument. If you have a large French horn where the curves are quite wide, then that's abnormal. If you have a flute or a clarinet and the curves are quite narrow, above and below the median line of 0, then that's good, because it's within the dotted line, which is essentially the normality. So based on that, we can understand whether there's abnormal large and small airways based on this concept of the instruments that we use. And actually, that's not dumbing down what oscillograms are, that's actually putting it very much into context for us to understand resistance and reactance. So if we move on, you agree now that we have sensitive tests that are validated, you understand the pathology, we get the physiology, then let's say, what's the prevalence? So in this study that I did with Dave Singh, if you look at the red dotted line, 50% of your patients in clinic with asthma will have small airways. Every second patient that you see. And it's also in mild, so don't think it's just in severe. Let's move on to COPD. So using oscillometry, Crisafulli and colleagues published this data, and you can see every second patient with COPD, even mild, will have small airways disease. So again, I put it to you that we need to think about small airways in our clinical practice. Let's move on. We now recognize the small airway phenotype in the variety of asthma that you and I come across. Monica Kraft showed in nocturnal asthma in her seminal papers. There's exercise-induced asthma from the Karolinska Institute, allergic asthma, fatal asthma, severe asthma, and again, I reiterate the message, even in mild asthma, small airways dysfunction is present. So that's asthma phenotypes. Well, in the world now of PRISM, and in the world now of pre-COPD and early COPD, we're now phenotyping COPD. So this is Friedrich Trinkmann in Germany, who is actually over a 2-year course looking at various measures to understand the early onset of small airways disease. And you may remember Jim Hogg's paper, where he actually said the small airways disappear before the emphysema presents. And this is so nice in terms of recognizing the pathological concepts being linked to the physiology, for us to pick up the physiology before the presence of emphysema, because by that stage it's too late for our treatments to work, and it's too late for the patient. So you may say, fine, we get the prevalence, we get the fact that there are phenotypes. So how is small airways dysfunction truly related to patient outcome measures that I see in the clinic? So this is data in asthma now from the Atlantis study. And what they clearly showed, if you look at the x-axis, the gold standard for small airways, which is RVTLC from body plethysmography, but you also see the second red circle is R5 minus R20, an oscillogram measure of small airways. And you can clearly see that when you measure small airways in this Atlantis study, they were able to prospectively predict the risk of asthma attacks in the 12 months. So this is prospective data, not retrospective. So it gives real confidence now that something in the small airways may actually predict a patient's asthma attack. So now let's look to COPD. Again, R5 minus R20, a small airways oscillogrammic index. You can see that on the y-axis was clearly related to St. George's Respiratory Questionnaire patient outcome. And importantly, better than the FEV1. I put it to you again that the FEV1 is only a marker of large airways, and actually it doesn't tell the whole story with our patients. You and I always see the disconnect in our clinic between FEV1 and 6-minute walk distance, FEV1 and exercise tolerance, FEV1 and how many steps the patient can go up, FEV1 and the disconnect between how far they can walk. It's a very loose measure that's related to patients, but here we see the strength in small airways. So then finally, you and I are very good at treating the large airways with the standard inhaler we use, but can I put it to you, maybe the fact that we don't treat the whole mucosal carpet of inflammation, and that's the reason why our patients keep coming back to us. And they say, doctor, you've put me on this treatment, but it's not working. So we look for comorbidities. We think about the environment. We think about the nasal. We think about gastroesophageal reflux. We think about vocal cord dysfunction, but we don't think about the phenotype that is the small airways, which is proximal. It's generation 7. I'm not talking really far down, generation 20. So what we need to do is use a device that can actually just gently push that aerosol a little bit deeper into the small airways and give our patients that opportunity. So part of my PhD, I looked at the differences in particle size, and you can clearly see that from the visual images, when you have smaller particles, you achieve two things: better total lung deposition and better deposition throughout the airway tree. So it's not just about treating the small airways, it's not just about treating the large airways, it's this whole airway tree. And a clinical tip, I always get my patients to exhale via the nose and not via the mouth. Why? Because on the exhalation route, if they have an ICS, it'll cover allergic asthma, and allergic rhinitis, and I often find that my patients use less nasal corticosteroids. I do the same for my patients with COPD, because 20% of them have mucus in the nose that we don't really recognize, and we could use the SNOT SNOT questionnaire in clinical practice. So my penultimate slide shows you this. A lot of people say that we don't have this machine. We can't actually measure small airways. What can we do? Well, here, this was a Delphi consensus statement undertaken by Vicente Plaza in Spain, and look at that red circle. 85% of the physicians in the Delphi said, if small airways disease is suspected, give a potential therapeutic trial to your patient, because then you've sorted that out, just like we're sorting all the other comorbidities out. And then finally, very much, small airways is, as I said at the beginning, beyond asthma and COPD. It's now in interstitial lung disease, and we've got a paper that's in press at the moment in chest on sarcoidosis. It's in HIV patients. It's in, obviously, lung transplant, because that's the gold standard with bronchoblitis obliterans, and it's in toxic inhalation. So I come back to where I started, the 7 pillars.
We can consolidate them into the panel. May I request Dr. K. Venugopal to come to the dais. Dr. K. Venugopal is a senior consultant and head Department of Respiratory Medicine at Surya Hospitals, Chennai.
Good morning. I'm extremely thankful to the ERS India Summit to call me as a moderator for this session. And I have 10 minutes, I have 5 questions, and all the experts have given their opinion very well, and I don't have much thing to ask them. The 5 answers coupled with my a few suggestions, so I think we will be right in time. So can I have the first slide, please? So Dr. Mark, so this question is to you. What are the most important patient-related factors that should be considered when personalizing therapy for COPD management?
Another one? Yes. Thank you. Well, there are different factors, and during my talk, I went through some of them. First, I think that we need to identify which are the patients with high risk, basically those who have either high levels of symptoms, frequent exacerbations, very poor lung function, and these patients in particular are those who require a most personalized approach. And what we need to take into consideration is whether they have these frequent exacerbations have different profiles, and if they have more an infective profile or more an inflammatory profile. The best biomarkers we have so far are the blood eosinophil counts and the color of sputum. Patients who have more bacterial infections used to have dark sputum, and these patients should be treated with antibiotics during the exacerbations, and if they have very frequent exacerbations, they will probably respond to the long-term macrolides. In contrast, patients who have white sputum or no sputum and have more inflammatory exacerbations, they used to be more eosinophilic and they require a treatment with inhaled corticosteroids, and in the most severe cases, in the future, probably they will be the target for biological drugs.
Excellent. I have one more question to you. How do you devise an action plan for COPD patients recovering from ACOPD prior to discharge in order to prevent exacerbations and repeat hospitalization?
This is a very important point, because patients who are discharged, we know that they have a high risk of being readmitted, and in fact up to 30% of them may be readmitted in less than 3 months. So every action that we can take to try to prevent exacerbations in these patients is crucial. And before they are discharged from hospital, we need to establish a plan, an action plan, and this action plan should include a series of factors. Obviously, to stop smoking, adhere to medication, check the inhaler technique, check compliance with medication. Some of these patients may be discharged with some dose of oral steroids that they need to finish, a course of steroids or a course of antibiotics that need to be finished completely. And also other actions, for example, physical activity, clearance of mucus. All these actions should be checked with the patient, and if these patients adhere to this action plan, we know that we may be able to prevent some of these early readmissions.
Yeah, so this is the most important topic which we have. So I would like to bring your attention to one of the papers recently published in December. The lead author is none other than Dr. Sandeep Salvi. Dr. Rajadhar also is part of it, and I'm happy to be a co-author in this publication. So here we have clearly mentioned a 7-point evidence-based care discharge protocol for patients hospitalized for exacerbation of COPD. So here we have really reiterated the enhancing awareness of seriousness of ECOPD. So the thing is, in myocardial infarction, people call it as heart attack. So the attack name itself is scary. So the patients are more aware, the physicians are more aware, the public is more aware, the incidence of heart attacks are coming down. Whereas the 2-year mortality is very higher than acute MI, but only 2% of the COPD patients or the caregivers or the public know that this is a dreadful disease. So what is the new terminology? Maybe the British called them the COPD crisis or the COPD flare-up, and the Dutch called them lung attack. So we should have something like known as lung attack. So then only the awareness will go. So we have really reiterated that in this, plus the other 6 points. Now we are coming to the next question. Professor Nicholas, this is to you. According to you, how should remission be realistically defined? Do you think that this is achievable in asthma the same way as it is in rheumatoid arthritis?
Yeah, thank you for this question. It's important to know how we would translate what we observe in clinical trials to our clinical practice, and I think the definition should be the same. I mean, the meaning of remission is the same in clinical practice as in clinical trials. We want really to achieve perfect outcomes for our patients, otherwise it's not remission. It's control or whatever you call that, but not remission. Remission is no symptom, as normal as possible, best possible lung function, no exacerbation, no oral steroids, normal activities in the daytime. And this is applicable to our patients in routine practice. It's important to have this in mind, otherwise we will not be sufficiently ambitious for our patients and we will not adapt the treatment properly. Something which will be important though is to monitor this, meaning to have registries of patients in the real life to know whether this is achieved or not. And this could be also an indicator of the quality of what we provide our patients with.
So you mean to say that if you tell that there is a complete remission, you want the lung function also to be to become normal? Yes.
As normal as possible. I mean, some patients will have completely a component of completely fixed obstruction, but we want it to be the real best possible.
Thank you. Now, Professor Usmani, what would be the best diagnostic algorithm for small airways disease, particularly in low middle income group countries like India?
Thank you. Let's start with the history. So there was a small airways disease respiratory questionnaire published just 2 years ago in asthma patients, just to ask them, when you are sitting comfortably in a chair at rest, do you sometimes hear a very soft, silent wheeze? And that has actually been correlated to small airways disease. The second thing is the chest radiograph, shows you flat hemidiaphragms and it shows you an increased intercostal space, and that for sure is small airways disease. And then the third thing I would do is not to forget spirometry and not look at the FEF 2575, but look at the VC and the SVC, because the SVC has clearly been shown to be a much stronger indicator of small airways disease. Should you have oscillometry, then I would use that as a complement to spirometry, and therefore with physiology, a chest radiograph and a good history with an examination, you'll be able to be reasonably confident this patient has the suggestions of small airways disease.
I really like the way you mentioned the oscillometry and you compared it with the musical instrument. That was excellent. And then that will give us a real insight to the problem. By looking at the spirometry, you can see what is wrong and where is the problem. Now, oscillometry has taken up in a big way in India for the last couple of years. And moving forward, what would be your choice of drugs when it comes to small airways disease, particularly since extra fine formulations are not readily available with all molecules?
Yeah, so remember it's not just extra fine, but a high particle fraction, and also some devices that have a normal fraction but have a very slow inhalation flow. So flow with particle size both combined together will target the deep lung.
So, any questions from the audience? Be very short and crisp.
My question is to Professor Osmani. You alluded about small airways disease in asthma and COPD, but we often see that patients with bronchiectasis often have a component of bronchiolitis. It may be post-infective, it may be some autoimmune or something. So I wanted you to throw some light upon small airways disease and bronchiectasis and how should we treat it?
So it's definitely present. We've been doing work. I think the next question for us in the research environment is, of the 17 parameters you can find in oscillometry, which ones define small airways disease better? And what we're finding is that they're different in different diseases. So in sarcoid, we have found it's the X5 and the AX that's better than the R5 minus R20. But it's for sure there is a variety of pathologies in bronchiectasis, immunopathologies, that have a physiological phenotype that actually gives you granularity within bronchiectasis as well.
So, sir, the benefit of long-term azithromycin was mentioned both in COPD as well as the asthma. How long is the long-term?
Long-term in azithromycin. Well, the trials both in asthma and COPD have lasted 1 year, so we can say that the measured long-term in these trials was quite limited in a way. Beyond 1 year, we don't know by definition because we don't have trials, and the practice is very heterogeneous in how long do you continue the treatment. But if it works, I would definitely continue it on a longer term.
Thank you, chairpersons and experts. So this session comes to end with this. Thank you.
Thank you once again. Now we go on to the next session, the newer phenotypes in OAD. The moderator, before that we have a
So I invite Dr. Sujit Rajan to moderate the next session. He is a senior consultant at Bombay Hospital in Mumbai. He's very passionate about ILDs and obstructive airway disease, and is one of the erudite and learned faculty we have in our country as of now. Over to you, Dr. Sujit.
Thank you, and thank you to the faculty for being here today. We have a 15-minute session on phenotyping of obstructive airway disease, and I hope we have some interesting answers that we get to the questions I have. So Arjun is here. Can I invite Arjun up, please?
With your permission, we'll call the panelists onto the dais.
Yes.
Yeah.
Yes, please.
We'll invite Dr. P.K. Thomas, sir, Senior Consultant Pulmonologist at MGM Healthcare, Chennai. Dr. P. Arjun, Senior Consultant and Group Coordinator of Pulmonary Medicine, KIMS Health, Trivandrum. And Dr. Sheetu Singh, Director, ILD and COVID Pulmonary Rehabilitation Clinic, Jaipur.
So thank you, Mark, Nicola, and Arjun, Thomas, and Sheetu. So I won't waste much time because we have very little time, and I'll go straight to Arjun. Obstructive airway disease is becoming more and more precision-based, Arjun. And do you think we need phenotypes in our Indian population? What are your thoughts on that?
Thank you, Sujit. As we all know, phenotyping in asthma is very important, and the phenotypes that we commonly see are the inflammatory phenotypes that have been well described. We have the allergic phenotype characterized by an increased IgE levels, and the eosinophil phenotype as well. But from a clinical perspective, the phenotype which we find usually difficult to treat is the middle-aged obese phenotype, which predominantly occurs in females, and because they seldom respond to the conventional treatment. And with the advent of oscillometry, what we find is that most of them have well-defined small airway dysfunction. And if you target these patients with ultrafine particles that reach the small airways, they respond extremely well.
So you would look at the small airway disease phenotype, the eosinophil phenotype, and the phenotypes that we have heard of in the talks preceding this session. Mark, to you, GINA 5 we would definitely phenotype, right? And I'm fairly convinced I have to do that. But the way things are going, we have new drugs for COPD coming up now, ensifentrine, revifenacin. Do you think we'll have to phenotype milder asthma, stage 2, stage 3 as well?
Well, I think this is the first time that anybody asked me anything about asthma. But I will take the opportunity to say that I don't know. But if you ask me about phenotyping patients with milder stages of COPD, I will tell you that probably not. Because as I presented in my talk, when we have patients with a mild disease in COPD, patients who what we call low risk, these patients should be treated exclusively with bronchodilation, and there is no need to look for other types of treatment, basically anti-inflammatories or biologicals, unless in the near future we may identify a subpopulation who will progress rapidly. And in those patients, perhaps early intervention will be very effective. But we know from trajectories, I remember a seminal study by Barcelli and the Body Group, that many patients remain very stable. And therefore it would not be justified to intensify treatment for mild disease in those patients. In contrast, others may progress, but still we don't know how to identify them.
But what about milder asthma? You wouldn't?
I think I will pass that to Nicolas.
Nicolas.
Yeah, maybe I can answer. And I would, my answer would be yes, but it's two yes. The first yes is for people with severe disease. Of course, we will improve the management because we will have more drugs coming. So the phenotyping will be very important for these on biologics. But maybe also these biologics will come earlier in the course of the disease, and maybe in 5 or 10 years from now, we will initiate biologics right after the diagnosis of asthma, even if it's not severe, even in mild cases, and we will of course need phenotyping to do that with a disease modification perspective, with the aim of really curing the disease by intervening very early in the course of the disease. But this is future. Right now, we already have to phenotype mild asthma because we need to identify smoking, which is a phenotypic characteristics. We need to identify obesity, all the comorbidities of rhinosinusoid comorbidities, etc., and all the environment exposures, which are also part of the phenotype. So we need to do it right now.
Very interesting perspective. And I think even biologics coming earlier, Nicola, we don't have the data, but we do have a lot of patients now asking us, can I get onto a biologic and avoid inhaled steroid? How do you respond to those patients?
I would respond, we're not there yet.
We're not there yet.
But research is ongoing, and we will probably be there in 5, 10 years from now, I anticipate. We will see.
Great. Okay. Nicola, coming to a question to you. Now, we now have a MAB recommendation for COPD, Nicola, and we have been doing phenotyping, or what we would call treatable traits for COPD, for quite a while. do you think the arrival of a MAB recommendation for COPD is very exciting news, or do you think this could be just an asthma phenotype that is probably responding?
I think that, thank you very much, thanks to the ERS and the ICS for having invited here.
Sure.
CIPLA. I would think that this would be just like an asthma phenotyping. I don't really think it would be different at all.
Yes.
And I would think that you sort of cross-classify this MAP with COPD. It has a tendency to get overused tremendously. And no parameters and no indications will tell us that this is where it has to be used, this is where it cannot be used.
Right.
So I think the question of misuse and disuse, I think, will become terribly, terribly high. So I think we need to be very cautious, at least to begin with, until we become more familiar and more formal with these drugs as such. I think it will be very difficult to pass judgment on.
Sure, Dr. Thomas. Interesting. Nicola, would you agree with what Dr. Thomas says? How would you look at it?
Yeah, well, to answer this question on phenotyping, well, first, maybe I throw it to Mark, but before I will just give my point of view, which is that, of course, we will be even more phenotyping because we will have more biologics coming on for COPD, targeting the T2 and non-T2, probably inflammation at some point. But again, it's a bit like for asthma, and Mark illustrated this very well. We also need to phenotype the type of exacerbations that they have, whether it's infective or not infective. And maybe then, Mark, you want to add something on this?
No, not much really. I think I agree with both of you. I think you address it very well. But yes, I mean the availability of new biologics for COPD will require phenotyping because they will not be for everybody, of course.
Sure.
They will be directed to certain individuals that may have certain type of inflammation and may be different from one drug to another. So yes, we will need to strengthen that.
And others, is there a lot of research going on, Nicola, in MABs in COPD?
Well, I would say, I just wanted to add something. It's not only a question of medications, again, like for asthma. The phenotyping is also, we need to phenotype the patient in their behavioral also characteristics, because these are targets for rehabilitation, for instance, or education and patient support. This is crucial. And we also need to identify those patients who will benefit from lung volume reduction through endoscopic techniques. And of course, it's a niche, it's a very small minority of patients, but it's also very important to identify them. So, and there will be a lot of research on this in the future.
Sure, thank you. On post-tubercular COPD or post-infective COPD, any special consideration, Dr. Thomas, in this space?
Sujit, if you take away TB from India, it will be like taking Italy and sambar from Chennai, for example. That's the way that I would look at it. So I think you're sort of putting up the impossible question, is that we cannot separate tuberculosis in India. No question at all. I think that thing should not be there at all. So I think it's absolutely inconsiderate and inconceivable that one can even think of an India without TB and without TB-related COPD. And I think this is very, very important because this is the thing that's really growing in importance, giving rise to a host of problems, fungal infections, multi-drug resistant TB, severe restrictive lung disease, severe COPD. So I think it's just not one entity, but multiple entities that sort of gather itself into this.
And do you think the treatment is more in the direction of COPD or asthma? Because we've had different research on that showing that it behaves more like asthma. I would think that it behaves more like a COPD than like an asthma. Okay. Especially the sort of fossil fuel COPD that we're looking at. I think it certainly behaves more like a COPD than like an asthma. Post-infective with the severe amount of fibrosis that you have, especially in the upper lobes, the compensated emphysema that you have lower down. So all these things I think clearly point towards a COPD phenotype, yes. Sure. Since we had that Indian context question to you, Arjun, would you agree that they behave more like COPD or more like asthma?
Yeah, I think it's more than COPD than asthma.
More than COPD. Okay. I have seen these patients sometimes that respond pretty well to inhaled steroid post-TB. I don't know if they've just developed an asthma after developing TB, but yes, Sheetal?
So I would actually talk about in contrast that steroids you should be, I think, very cautious about, because many of these patients tend to develop a reinfection, and those fungal infections which we are going to talk about probably later in the day. We should be extremely cautious about using inhaled corticosteroid in this subsection of TOPD.
Sure, sure. So I'll come to you, Shitu. In terms of clinically utilizable phenotypes, because finally we have a practicing group in the audience, and everyone wants to know what they can do with the phenotype, not just know the phenotype, right? So do you see those utilizable phenotypes coming up in the horizon where we can actually do something? Like, for instance, small airway disease, we have an extra fine aerosol available, we have impulse oscillometry that can pick it up, but we have a drug to fit it in. So do you see those type of phenotypes?
So I think I just have limited time, and I just wanted to emphasize on one thing which has not been discussed since morning. India is a unique country. We have been discussing about, such fancy drugs, phenotyping, and these are exciting times. But there is one phenotype in India particularly, which is the undiagnosed and untreated obstructive airway disease. And before we actually chase these fancy molecules, which may be a distant dream for many Indians, I think we need to diagnose our OADs and treat them in a better manner. We have conducted two very important studies. The Global Asthma Network study, this was a questionnaire-based study on 40,000 children across India, 80,000 adults, and found that almost 80% of current wheezers are not being diagnosed, and 70% of wheezers with severe asthma were not being diagnosed. Only almost 2.5% of our patients of asthma are taking inhaled steroids, and this number drops to less than 1% if these patients have not been diagnosed. Now, if these patients are not being diagnosed, they will develop severe airway obstructions, airway remodeling, and that mounts to the higher number of patients, the higher number of mortality in India. The global burden of disease data has already highlighted that 46% of deaths due to asthma in the world are in Indians, which translates to almost a case fatality rate of 5 times higher risk of dying from asthma and 3 times higher risk of dying from COPD if you are an Indian.
Wow. No, that's it. I'll open it up to the audience as we come. Anyone with any questions on asthma, COPD, phenotyping that you have, because it's a burning topic today with newer drugs available. We couldn't have a better faculty for this. Yes, Sandeep, please.
So, one of the phenotypes of COPD that we must consider very seriously in India is the non-smoking COPD.
Yes.
And as of now, we do not have adequate information or data to suggest what would be an appropriate pharmacotherapy of these patients.
Correct.
Should we treat them like the way we treat traditional COPD?
Yes.
Or should we treat them in a different manner? I think it's important to find an answer for that. Perhaps some of the panelists may have some experience in treating these patients.
Sure.
Would be good to listen to.
Any thoughts? Yes, please. Indeed.
Yeah. I have one speculative question to Professor Nicholas. How far or how near are we in calling asthma a curable disease?
Not yet. It may become a curable disease in the future, but for now I would, there are cases of cure, which means very, very, very prolonged remission with no relapse. Is it really cure? I don't know.
I think Sandeep sir's question remained unanswered. I'll just answer that. Patients with biomass exposure, those obstructive airway disease present more like a small airway disease, and patients with smoking associated would present as an emphysema. So treating your biomass associated OADs with like a small airway disease would help you better.
Thank you, Shitu. To come to the last slide, we have that last slide to summarize, I think, what we discussed. Phenotyping is here to stay. For those of you, I think for the large mass, just the last one. Sorry. personalizing treatment is here to stay. One size doesn't fit all. Probably if you go into the smaller parts of the country where we don't have access to much of infrastructure to investigate these patients, we could probably say inhaled steroids for asthma and a LABA or a LABA-LAMA for COPD. But that won't do once you move to secondary care, tertiary care. Patients want more answers. They want their disease better managed. Unique Indian phenotypes exist. We have seen both the post-TB perspective, as Sandeep rightly mentioned, the non-smoking perspective. That is also becoming an increasing burden we are seeing now as those patients exposed to biomass fuels and wood smoke in childhood are growing older and older. Severe asthma should be phenotyped. We are pretty clear on that. Whether we should phenotype milder and moderate asthma is the question. And I think Nicola brought it out very well in saying that they could be obese. They could have only exercise-induced asthma. They could have reflux, sinusitis, and each of these patients, even with mild asthma, require a different approach. And finally, with new drugs like ensifentrine, dupilumab, revifenacin, we're going to have a lot of discussion on COPD, and it's certainly not one size fits all in COPD. We'll have to tailor our treatments, listen to our patients, what their priorities are. And as you can see, the GOLD guideline also divides the whole management into patients with predominantly dyspnea and predominantly exacerbation. So we'll have to relook at the way we actually listen to our patients and tailor the final management. Thank you all panelists very much today, and thank you to the audience as well. Thank you.
Thank you, Dr. Sujit, for those wonderful panels. Thank you all the panelists for joining us. We'll move to the next panel discussion.
Moving on to the next panel discussion that we have today regarding the emerging trends in inhaler devices and diagnostic. I wish to invite Dr. Nagarjuna Maturu, Senior Consultant, Clinical Interventional Pulmonologist at Yashoda Hospital, Hyderabad. Dr. Nagarjuna. Yeah, he's already here. So I also wish to invite Professor Omar Usmani as a panelist, and Dr. B. Vishweshwaran, who is a consultant interventional pulmonologist and sleep medicine specialist at Yashoda Hospital, Hyderabad. Dr. Paramesh, Senior Consultant and Head of the Department Pulmonary and Critical Care Medicine, Lizzie Hospital, Cochin. And Dr. Praveen Valsilan, Senior Consultant Pulmonologist at Aster Medicity in Cochin. Over to you, Dr. Nagarjuna.
Thank you so much, and good morning, everybody. I should thank the team ICS and team ERS for this academic initiative. So without wasting much time, we would start the panel on emerging trends in inhaler devices and diagnostics. This, I think, is a very valid panel discussion. So we have a couple of questions. So the first question I would request Professor Usmani to address. Again, this is on oscillometry. And the reason why I have chosen oscillometry as the first question is because of its increasing utilization in our country. In the last couple of years, across the length and breadth of our country, we have seen centers starting to adapt to use oscillometry. So, Professor, we have heard your lecture on small airway diseases and the role of oscillometry in diagnosing, picking up small airway disease. So, my question to you is, will it also guide treatment decisions?
I hope it will. So we've heard about pattern recognition, it's very important. I gave an algorithm if you don't have oscillometry. There's been a really nice question from the audience on sometimes the spirometry is abnormal, but the oscillometry is normal. What do you do then? And in that situation, actually, the spirometry is what you go with, yeah? So if there's severe obstruction on spirometry and the oscillometry is normal, and there was just a question just now while we were having the last talk. So we're looking at understanding the flow mechanics relationship of spirometry, of oscillometry in those patients, and physiologically what I feel is that the large airways are contributing greater. The other thing I wanted to say is that so I think we've addressed this. Sandeep, you always ask really great questions, and there's a group in Mexico who published in Cells that there is actually a difference immunopathologically between biomass and cigarette smoking, and actually biomass have less emphysema and more airways disease and more small airways disease. So this is a prime time group of patients to apply oscillometry to pick up those changes, because you'll get less interference of the emphysema.
So I have one extension to the question which I have put across. So in a person with an airway disease where the symptoms are not controlled, if you do an oscillometry or through any technique you diagnose small airway disease, so are we justified in switching from a normal inhaler to an extra fine inhaler? Absolutely. Will that actually make a difference? Absolutely. Do we have evidence for that?
Absolutely. And so again, I said in my talk extra fine and also flow. So I had a question that again was in the audience, so I'm bringing it out here because when you talk about flow, do you mean a spacer plus an MDI? And yes, a spacer plus an MDI or the Respimat inhaler device. I appreciate you don't have it in India. It's actually not being promoted now globally, but that's a classic device. So flow and size can guide your treatment to be targeted to different regions of the lung.
Excellent. So the last question I have on oscillometry is its role in monitoring the patient. So in spirometry, we use FE1 to monitor, FE2 to monitor. So do we have any data that similarly by doing serial oscillometry and monitoring R5 FRS, can we assess the improvement in the lung function of a particular person?
Yes, there is. There's data from Canada by Ron Dan-Duran's group who actually showed patients who were put on a large particle size therapy and those that were put on a small particle size therapy, and showed improvements in physiological measures of large and small. So it was proof of concept of oscillometry against particle size. And I go back to a study that was done on ciclesonide, which has a particle MMAD of 1.1 microns from 20 years ago by the group in Japan, where they looked at alveolar nitric oxide. So another measure of small airways is alveolar nitric oxide, and as of the last 4 months, we now know we have a commercial device that can assess alveolar. It was at the ERS and it was displayed. So what they showed was you can monitor using oscillometry, and they showed an improvement in small airways oscillometry with ciclesonide compared to fluticasone, large particle, and this was correlated with an improvement in the ACT. So there's a direct link between pathology, treatment, and what patient response outcomes.
Thank you so much. So we'll now move to Dr. Vishwesh. So in addition to spirometry and oscillometry, the other test which is increasingly being used is the assessment of FeNO, the fractional exhale nitric oxide. Your quick comments on the role of FeNO in managing a patient of asthma, the pros and cons.
The FeNO, we do it routinely in our clinical practice. First, at the time of index presentation, we get a FeNO because it helps us to support the diagnosis of an atopy. And if the FeNO is generally more than 50 parts per billion in adults, or if it is more than 35 parts per billion in children, it gives us more confidence, even though the spirometry might be normal, to put these patients on inhaled corticosteroids. Then the second part of the FeNO is in response to the monitoring. Let's say I start a patient of an asthmatic on an inhaler, and the patient is not responding. I still get a FeNO to see if the patient has been compliant on the inhalers or not. Let's say that the FeNO is not decreasing, then probably there is a compliance issue with respect to the inhalers. Another way of utilizing the FeNO is in predicting the exacerbations. If I find the FeNO to be disproportionately high, then these are the patients who may be at a higher risk of exacerbation. So probably I may have to step up the dose of an inhaled corticosteroids. And the last part is regarding the withdrawal of the inhaled corticosteroids. So I stop a patient on inhaled corticosteroids, then I still follow them with a pheno. If there is a rising trend of a pheno, then probably that is a point I believe that this patient should not be withdrawn from an inhaled corticosteroids because the inflammation is still on. So probably we may have to continue these inhaled corticosteroids in these patients. So both at the index presentation as well as for the monitoring as well as for the withdrawal of the steroids, I think pheno is a very good marker. Apart from that, with the emerging of these biologics, where we want to find out whether it is an atopic variant or it is an eosinophilic variant, then getting a pheno becomes a good tool if you are looking in terms of either omalizumab or looking in terms of a dupilumab or even for that matter in certain cases of tezepelumab. So I think pheno still has a lot of utility with the upcoming of the biologics.
Yeah, thank you so much, Vishesh. So he has beautifully summed up the various advantages of pheno in managing case of asthma, but we should also remember that there are certain false positive phenos. For example, an upper airway infection, viral infection, rhinitis, smoking can also lead to high pheno values. So quickly moving on to Dr. Paramesh. So we'll move from tests to devices. So we have spoken about molecules, we have spoken about combinations, but it's also important to understand that device has a role when prescribe inhalers. So every year we see that a lot of new devices are being launched in the Indian market. So in the last couple of years we have seen the launch of the Ellipta devices and very recently the Aerosphere technology. The molecules are the same, but the devices are different. So do you think that these new devices would make an impact in managing patients of obstructive airway diseases?
Thank you, Nagarjuna. Yes, definitely. But I would like to borrow the words Shidu has already mentioned. Basically, India being a heterogeneous country, and right now we are a heterogeneous country with more heterogeneity in the number of molecules and the devices that we use for the management of obstructive airway disease. So with the availability of the newer devices, definitely it's an advantage as far as this Ellipta device, as far as Aerosphere device is concerned. If you go through the studies of these devices and the drug, definitely there is always a positive impact as far as the outcome is concerned. And also if you see the Aerosphere, which is a co-suspension method which is being used, and in the studies, those studies, they haven't used any spacer for that PMDA, and despite that they have evidenced a positive impact in the outcome. So it actually improves the lower airway deposition of the drug, and if the deposition of the drug is improved, then definitely it is going to have a positive impact as far as the patient's outcome is concerned. That is one thing. But there is other side to it. Always the Indian population is concerned about the cost factor. So this is one thing that we always need to understand, but the cost benefit ratio has to be assessed for each and every individual before prescribing a particular device.
So points very well taken. So just like there is no one size fits all, there is no one device fits all. I think you have to choose the device based upon these socio-economic characteristics as well as the disease characteristics of the particular
One
person.
thing
Thank you
that
so
I
much
would like
for
to highlight is basically with the availability of SITT, now the confusion among the patients about multiple inhalers can be avoided.
Yes, so that's a different debate altogether. So we'll quickly move to Dr. Praveen. So we have entered the digital revolution. So there is digitization in everything we do. Same thing is true for inhalers also. So we already had digital inhalers or smart inhalers in our country. So what exactly are they for the audience, and what are the challenges in universal adoption of such digital inhalers?
Just like Nagarjuna said, we have digitalization in every aspect of our life. So we all know the primary problem with the inhalers among patients who are asthmatic is the compliance. So that's one thing, like it could be like not using it at all, thinking that their disease is controlled or that they don't have any symptom, or they try to use the inhalers till the end, the no puff comes out, like say looking at their economic they try to use the inhaler till the end, so that there will be economic efficiency they will look at, and multiple reasons. So that's where the use of digital inhalers comes in. There has been in India already some or the other type of digital things have come in the market. None has been sort of a universally adopted, in the sense that it has been very difficult to make the patient understand that and make them use it actually. That's the biggest challenge that we see. Primarily probably that the patient is not they think that okay, just utilizing the inhalers, they will be able to get it controlled. They don't need to get monitored. The second thing is, the question is, even if we have a digital inhaler, who will monitor it? We don't have a robust healthcare system, or as a doctor we are we can't, because we are too busy with other things. So there should be a ground level healthcare workers who should be able to monitor it, or in your hospital. So all these are a big challenge, especially in a place like India. And other thing is whether the cost factor, when we are digitalizing these things, probably the cost factor will go up. So that's again preclude a patient from buying a digital inhaler rather than a normal inhaler. So all these are a problem in our
Yes, I think very valid points, though it would be very helpful to have a device which monitors the adherence of the molecules and gives a feedback to the patient as well as the doctor. It does have some challenges in a country like India for getting universally accepted. So one quick last question, again back to Professor Usmani, is the role of CT scan. So we have discussed about a lot of phenotypes of airway diseases. So would doing a CT help us understand the phenotypes better, the emphysema, the small airways, the mucus plugging, so on and so forth? So how do you think it can be utilized in the clinical practice?
Yes, and certainly there's a lot of research in CT, but even in the UK, believe it or not, you have to consider access, but also importantly for patients globally is the radiation exposure. So we looked at our algorithms earlier on, and you gave a very elaborate use of pheno actually, and with the right cutoffs, because we put that in the ERS task force. So CT will add and complement, but its position will, I think, be after a good history, a good examination, basic chest radiograph, and good physiology.
So when would you order a CT scan in a patient of an obstructive airway disease?
So probably somebody who really isn't responding, somebody who I think in COPD has fibrosis, 15% do, and the body plethysmography doesn't tell me what's going on, coexisting bronchiectasis, aspects related to pattern of emphysema if I'm thinking about endobronchial valves. So its complement will be at that level, certainly in COPD. And asthma, there's 15 to 18% who have bronchiectasis with asthma that's under-recognized, who aren't responding to treatment.
Thank you so much. So we just have 1 minute left. We can have a couple of audience questions. So while I try to summarize the messages given by the audience. Okay, so just to sum up, as far as inhaler devices and diagnostics are concerned, oscillometry and pheno are the two things in addition to spirometry which are easily accessible across India. Oscillometry at this point of time would supplement spirometry. We have not come to a stage where it would replace spirometry, but definitely it would help us pick up small airway diseases much better. And regarding treatment, if you pick up a small airway disease, as Dr. Usmani has rightly said, changing to an extra fine particle, changing the pattern of breathing might improve the control in that particular person.
Just
pheno,
yes. Your flow. Oscillometry also tells you about large airways and also vocal cord dysfunction.
Yes.
So actually, it's got such versatility.
Picks up the spectrum across the diameter of the airways. And pheno, yes, Dr. Vishwas has briefly discussed about the benefits of pheno in diagnosis, monitoring, and de-escalation of therapy. And devices, a very good point. There is no one device fits all. You have a lot of devices in the Indian market. Each device has its own advantages. You should choose the device based upon your assessment of the patient and the disease. And lastly, digital inhalers, smart inhalers. I think it is to come. Artificial intelligence, digital monitoring is the way forward. We're all looking forward to such introductions in the Indian market. And I would like to thank all the panelists for being here with us, and thank you so much.
So thank you panelists and the faculty. So it was a very interesting session on obstructive airway diseases. We move ahead. We got an exciting session coming up. So this session is on infectious diseases of the respiratory system. I would invite Professor Nicolas Roche to chair the session. So Dr. Roche is a senior medical specialist, respiratory medical specialist from Paris, France. And I would like to invite a subject expert, Dr. C. Ravindran. So Dr. Ravindran is a senior consultant and the Chief of Medical Services, Baby Memorial Hospital, Calicut. So over to you, Professor Nicola and Dr. Ravindran.
Thank you very much. It's a great pleasure and honor to be here with you and to have the ability to chair this session. And it's a great pleasure to invite on stage Professor James Chalmers, good friend from the University of Dundee, leading expert in the field of bronchiectasis with the clinical research collaboration of the ERS called EMBARC, to which India participated a lot from what I understood, with especially Raja Dar. And so James is also the chief editor of the ERJ, the European Respiratory Journal. But here James is going to tell us everything about respiratory infections, and especially with the perspective of fighting against antimicrobial resistance. So James, the floor is yours.
Thank you so much, Nicholas, and thank you to all of you for being here. Huge thanks to the Indian Chess Society for what has been a fantastic event, really exciting exchange of ideas, and I've really enjoyed it. So over the next few minutes, I'm going to talk to you about the complexities and new developments in respiratory infection, including antimicrobial resistance. These are some of my disclosures. I do work with a number of pharmaceutical companies in this area, so important that you're aware of that. Of course, in 15 minutes, it's not possible for me to cover every aspect of respiratory infection. We need to think about pneumonia, we need to think about TB, non-tuberculous mycobacterial infections, fungal infections, bronchiectasis, and so I thought I would pick one important topic that often doesn't get a lot of airtime, which is the most common respiratory infection that we see and the leading cause of respiratory infectious death globally, and that's pneumonia. And so I'm going to spend the next 15 minutes talking about new developments in pneumonia. This has not been, over the years, the most dynamic field, but it's interesting to reflect that we published the European Respiratory Society guidelines for severe community-acquired pneumonia only 18 months ago. These were published in the European Respiratory Journal, and I give a plug at this point to the fact that the ERS, one of the great things that the ERS does is publishing clinical practice guidelines that can really help practicing clinicians, and these are freely available on the ERJ website. So this guideline went through a series of PICO questions about how we should manage people with pneumonia. And I'm going to focus on three important questions, one around diagnostics, one around empirical therapy, and one around corticosteroids, because we've seen new developments and new published data in each of these areas. So let's start with diagnostics. We have more and more better molecular diagnostics, and so our first question in the ERS guidelines was, should we use molecular diagnostics like the BioFire system, for example, to diagnose the cause of community-acquired pneumonia? And in this guideline, we recommended that we should, but pointed out that the data supporting this was very weak. It was a conditional recommendation with a very low quality of evidence. And that's because, although we have a lot of data showing that these systems pick up more pathogens, they tell us a bit more, the evidence that they change and improve clinical practice is more limited. They definitely pick up more pathogens. I've shown 2 studies here, but there are many that I could choose from. On the left-hand side is a study from Scotland, where I work, and we're used to maybe 30% of patients having an identifiable pathogen in pneumonia if you have only culture-based diagnostics. If we look at this table on the left-hand side from 323 pneumonia patients, 80% had a bacteria identified. So molecular diagnostics, PCR-based diagnostics, really pick up more pathogens. In this study, the most common pathogen, bacterial pathogen, was Haemophilus influenzae. Now that's not what we're used to seeing. We're used to seeing Streptococcus pneumoniae, of course. This is something peculiar, partly peculiar to the UK, where I work, where we see a lot of Haemophilus. But also when you use sputum samples, Haemophilus is very common in people with underlying lung disease who are more likely to provide a sputum sample. Molecular diagnostics are also very good at identifying viruses. In this case, 30% of patients had viral infections. This is important therapeutically because we have therapeutics for SARS-CoV-2 and influenza, and also for isolation procedures. And this study was performed pre-COVID-19, but illustrates that you can pick up even less common viruses that traditionally are not identified in these kinds of studies. On the other side of the slide, we have the CDC EPIC study, which is one of the most detailed molecular diagnostic studies from the United States, and this looked at the cause of community-acquired pneumonia in a milder, more community-based patient population. And here, virus is really predominant. You can see rhinovirus was the most common cause of pneumonia, followed by influenza, and followed by a number of other pathogens, including metapneumovirus, which has been in the news a lot recently, and RSV. So in milder patients, viruses are very important, and even in patients who are hospitalized and requiring oxygen, viruses are isolated very frequently. But the question is, does this change how we manage patients? And here I'm going to show you the first of a series of studies that I'm going to take you through. And this has just recently been published in August of last year. And this is a randomized clinical trial where patients were, it's from Spain, where patients were randomized to either management based on a BioFire molecular diagnosis or management based on culture-based diagnosis. And the primary outcome of the study was whether we could reduce the duration of antibiotic treatment based on the molecular diagnostic. So you can see on the left-hand side that the study was reasonably large. It randomized 119 patients to the molecular diagnostic and 123 to standard care. And on the bottom right here, you can see the primary outcome of the study, which is duration of antibiotic therapy. And it's very disappointing. Both arms received approximately the same duration of therapy. It's between 10 and 11 days, which is also relatively long for treatment of hospitalized community-acquired pneumonia. In the table at the top, you can see that there was also no effect on de-escalation of antibiotic therapy, which you may expect would be one of the major benefits of a molecular diagnostic system. And most of the other secondary endpoints were negative, despite the fact we got a diagnosis much more rapidly with the molecular system. So this is, I think, really important. We have better and better tools to diagnose the cause of pneumonia, but if this doesn't influence our prescribing practice, it's not going to have the impact that we want it to have on things like antimicrobial resistance, because one of the major selling points of these devices is the idea they'll reduce inappropriate antibiotic use and therefore prevent AMR. So moving on to empirical antibiotic prescribing, for many years, our primary first-line therapy for community-acquired pneumonia globally in ERS, ATS, BTS guidelines has been macrolide plus beta-lactam, and that's mostly based on observational studies showing mortality benefits associated with the addition of a macrolide. Macrolide is also given for atypical coverage, but there is evidence that the benefit extends beyond atypical coverage. And so in the guideline, we recommended beta-lactam plus macrolide rather than fluoroquinolones, and we recommended that the macrolide should be considered for between 3 and 5 days, and then should be de-escalated if the patient doesn't have an atypical pathogen. But this hasn't been supported by high-quality RCT data. And so again, since the publication of the guidelines, we've got better data because we now have a nice randomized controlled trial. This was performed in Greece. It's called the ACCESS trial. And this study randomized patients to either beta-lactam alone or beta-lactam plus macrolide. These are very difficult studies to do when something is already standard of care, and so the authors are to be applauded for managing to do this. And this is, again, it's a moderately sized study. It's not large enough to be powered on mortality, and so the primary outcome was a composite endpoint of clinical response, meaning that the patients had a clinical status that had improved, biomarkers had improved, etc. The study randomized 139 patients to the beta-lactam plus macrolide and 139 patients to beta-lactam and placebo. And you can see this was a really striking result. 68% in the macrolide-containing arm had a clinical response at day 4, whereas 38% in the standard care arm had a clinical response. So this is really the most robust randomized trial data to date that shows that the addition of a macrolide makes a difference in this patient population. And the important thing to say here is that the vast majority of patients did not have an atypical pathogen. So this was not during an epidemic of Legionella or Mycoplasma. The majority of these patients are our conventional CAP. And so this would support what has been hypothesized for a long time, which is that macrolides are principally having an anti-inflammatory effect, and that's what's driving the benefit. So this supports the ERS guideline recommendations to use macrolide as part of the empirical regime. And I know in India there are other reasons to not use fluoroquinolones. Unfortunately, we still do have a lot of unanswered questions when it comes to primary and subsequent antibiotic therapy for pneumonia. Our research priorities section of the guideline was almost longer than the recommendation section of the guideline because there are so many unanswered questions. And so we really do need to do further studies to understand if the addition of fluoroquinolone rather than macrolide would make a difference. At what stage should we be de-escalating therapy? And how long is the optimal duration of these antibiotics, both in terms of clinical response, but also in terms of driving antimicrobial resistance. So a lot more work to be done, given that this is such a common infection, we should be doing better. So the final clinical question I want to address is in regard to corticosteroids. This has been a really controversial area in pneumonia research for many, many years now. Steroids have not been recommended historically in guidelines. There have been some small studies that have shown benefit. There have been some small studies that have shown no benefit. Most of these used composite endpoints like improvements in the radiological appearance rather than hard endpoints like mortality. And so when we reviewed the data for the ERS and Combined Society guidelines that was published in 2023, we did not recommend corticosteroids for severe pneumonia except in patients with shock, and using steroids in shock has been established for a long time. And this was controversial at the time, but since we issued these recommendations, we've also had more trial data. And I'm going to show you one of the most influential trials here. This is a randomized clinical trial of hydrocortisone that was conducted in France. The first author is Dequan. It was published in the New England Journal of Medicine in 2023 and actually was presented at the European Respiratory Society Congress. And this was a properly powered mortality study in patients with severe community-acquired pneumonia. 400 roughly patients were randomized to each arm, either hydrocortisone or placebo. Hydrocortisone was given at a dose of 200 milligrams for a minimum of 4 days, and then a variable length of to complete the course depending on the patient's clinical response. And as I mentioned, the primary outcome was 28-day mortality. And this is the result. So if we look at the primary outcome, a striking effect, 6.2% mortality in the hydrocortisone group, 11.9% in the placebo group. So a massive mortality benefit with hydrocortisone in this study. Important to say this was a severe pneumonia group. About 40% of patients were mechanically ventilated in the ICU, about 40% were on high-flow nasal oxygen, so they were a very severe group, and that's reflected in the mortality rates. You can see that all of the secondary endpoints were also in favor of hydrocortisone, including death by day 90, and things like time to get off mechanical ventilation, length of stay, etc. It also seemed to be very safe. There is some hyperglycemia, but not other major changes in adverse events. This is the Kaplan-Meier curve for discharge from ICU, and you can see that that's also significantly better in the group that received hydrocortisone. So this is potentially important, and it has in fact changed practice in many places, and recently in critical care medicine, critical care guidelines have issued a strong recommendation for the use of hydrocortisone in patients with severe community-acquired pneumonia. But this remains extremely controversial because we've also had trials of similar size that are negative. And so it's unclear whether the benefit of steroids applies to all patients with pneumonia, or whether in fact, as we've just heard in the airways section, we need to think about precision medicine for community-acquired pneumonia. And so the last study that I'm going to show you tries to get at that question. Are there biomarkers that we can use to identify patients likely to benefit? And this is, I like this study because it answers an important question, but also it gives us a clue to the future of where we're going with a lot of research in terms of machine learning. So the authors of this study took the individual patient data from a large number of clinical trials on community-acquired pneumonia and steroids, and they divided the studies into two. They took a training set and a validation set, and they used machine learning to ask the computer which patients are having a mortality benefit from corticosteroids. And there are important limitations to this, of course. We're mixing here studies where patients receive prednisolone, hydrocortisone, methylprednisolone, so there are potential confounders in this analysis, but the authors tried to account for this as much as possible. So putting all of these studies into the machine learning algorithm, they identified the markers most likely to predict a benefit, and then they validated that in the test cohort, which are the two largest studies by Maduri and Dequan. And importantly, one of those studies was negative, and one, the Dequan study I showed you, was positive. And the outcome of this is very interesting. So the overall effect, which is shown at the top here, anything to the right indicates mortality benefit. So the overall conclusion from a meta-analysis of all of these studies is there is a mortality benefit in patients with severe community-acquired pneumonia. But the most interesting part, I think, I've now highlighted in a red box, is the strongest predictor of whether patients would benefit or not was the baseline CRP. So if the CRP was less than 200, there was absolutely no benefit. If the CRP was greater than 200, there was a more than 6% reduction in mortality. And this makes a certain amount of sense. Anti-inflammatory treatment works in patients who have more inflammation. And so I think it's biologically plausible and potentially very useful for our future practice. So we come back to the guidelines and say this is a rapidly developing field, and as I've illustrated to you, even in 18 months, a number of what we recommended has been influenced by new publications, and that's really nice to see. So to summarize, we have new molecular diagnostics that can really pick up new pathogens, but we do need to learn how to use them most effectively and how to influence people's prescribing practice. We now have better data for combination beta-lactam plus macrolide as empirical therapy for pneumonia, and steroids now have much stronger evidence, but I do think based on the inconsistency between trials, precision medicine and identifying the patients most likely to respond is really important. Thank you very much.
Thank you, Dr. James, for the excellent presentation. Please take your seat. Next topic of discussion is post-TB infection and evolving trend. The speaker is none other than Dr. Raja Dar. I need not introduce Dr. Raja to this audience. He is the Secretary of Indian Chest Society and Head of the Department and Director of Pulmonology in BCAP, Birla Institute, Kolkata. Dr. Raja, please.
Thank you very much, Dr. Ravindran. I'll talk about a topic which actually straddles Symposia 1 and Symposia 2. So I'm going to talk about TB, but I will talk about TB in the perspective of what sort of chronic lung damage, what sort of long-term damage it causes. So for many people, tuberculosis ends when there is microbiological cure. That's what the National Tuberculosis Elimination Program now talks about. However, I'm going to show you through the course of this discussion today, this topic today, that it's not the end, but the beginning of a different illness, a chronic illness, which has got a lot of repercussions in the long term. So post-TB lung disease is an interplay between the direct damage caused by TB bacteria to the lower respiratory tract, caused by the immune response, and also to the lung parenchyma. And there are various compartments which get affected due to post-TB lung disease. So there's the large and the small airways, so there's bronchiectasis, there's obstructive lung disease, and these are two areas which I will focus on. However, areas which I'll not focus on today for the lack of time are lung parenchyma, lung vasculature, the pleura. So the most amount of data generated, especially in our country, is in the area of TOPD and post-TB bronchiectasis. So I'll cover those two topics today. You heard about airways disease in great detail through the course of this morning, but just to say that the overall prevalence of COPD globally is to the tune of 12% in men and 8.5% in women, and there's a lot of mortality which is associated with it. If you look at Indian data, the numbers of cases of COPD in India are rising, 55 million cases in India, and this 9.5% of total deaths, which makes it the second most common cause of death in our country and globally, and our contribution to mortality in COPD is immense. So that's about the obstructive airways disease arm, that's about the COPD arm. What about TB? So globally, TB is the leading infectious cause, and 10 million new cases even now, so this is 2023 data, and 1.5 million deaths. Look at Indian numbers again. You saw the Indian numbers in COPD. Look at Indian numbers in TB. 25% of the TB burden is from India, and the incidence, estimated TB incidence, is 2.77 million in 2022. So on both areas, we are talking about phenomenal numbers, very large numbers. When I trained in respiratory medicine, I was taught that smoking is the only cause of COPD. And the fact that if you continue to smoke, your mortality and morbidity increased. If you quit smoking, your risk of both morbidity and mortality in the long term reduced over a period of time. You heard about non-smoking COPD, even if briefly through questions and answers. We know non-smoking COPD is a huge problem in India, thanks to the phenomenal work by Dr. Sandeep Salvi. Post-TB obstructive airways disease is a phenotype within this group. So if you look at exacerbation rates in non-smoking COPD, the numbers of exacerbation in non-smoking COPD is actually greater as compared to what it is in smoking COPD. So the number of hospitalized exacerbations, one or more exacerbations, is greater in the non-smoking category as compared to smoking. However, if you look at lung function worsening, the lung function seems to be lower in the smoking category of patients as compared to the non-smoking category of patients. So worse lung function in the smoking category, greater hospitalizations due to exacerbation in the smoking category of patients. So that's a very brief touch on non-smoking COPD. Let me speak in slightly greater detail about this acronym, which is TB-associated obstructive pulmonary disease under the umbrella of non-smoking COPD. This is a meta-analysis which dates back to a couple of years, which looks at the category of patients of TOPD. And similar to what James showed you a little while ago, you can see the diamond at the bottom here. So the forest plot shows that the odds ratio for getting COPD in patients with a previous history of TB is greater. A lot of you would argue these are patients who are exposed to air pollution, patients who are exposed to biomass, traffic exhaust, etc. So the meta-analysis also looked at correcting factors, confounding factors like smoking, for instance, and to see whether the post-TB risk of obstructive airways disease remains or not. And you can see on the forest plot there, the diamond is still on the right, which shows that there's a greater relative risk of developing obstructive airways disease in the background of TB, even when you take these risk factors away. So under the umbrella of the Respiratory Research Network, we carried out a study to look at severity of airflow obstruction in treated post-TB COPD patients in India. I'll show you the results. We have presented the results in various platforms before this. We haven't published the results as yet, but hopefully that will happen in the not so distant future. I was lucky to lead this study, which happened in patients between the age of 18 to 65 years. They would have had to take a full course of completed antitubercular drugs, and they would have to have a sputum AFB, which was negative at the time. What is it that we were trying to find out? So the endpoints of the study was to study the phenotype of post-TB COPD and to study the treatment patterns in clinical practice for post-TB COPD. We also wanted to look at the severity of airflow obstruction and the relationship between time and the severity of obstruction in these sputum negative patients. So study was carried out between January 2018 to February 2023. 25 centers. The total number of patients recruited was close to 1,000, but the analysis data set that I'm showing you is of 858 patients. And without taking you into detail, you can see the blue circles. So centers throughout the country, and that's the list of centers that I've quickly shown you. So let's look at the bottom line here. I've summarized the data for all of you for the want of time. So we said about 850 patients from 25 centers. The mean age was about 52 years, 63% were men, and 22% had a smoking history. The age that you see seems to be classical in India for all chronic lung diseases. We have seen that in the ILD India registry. We have seen that in the EMBARK India dataset. So about somewhere between 50 to 55, which is about 10 years younger to the global population of patients with chronic respiratory disease. If you look at the history of TB, the average treatment duration for these patients was 8 months. So patients adequately treated. About 71.5% of patients were declared as TB free based on an AFB negative, and 8% of patients had a relapse of TB. In the remaining group of patients, you had radiological and symptomatic improvement of disease, which was how they were declared as being TB negative. So what about the nature of disease? And this is the interesting part. About 50%, so a bit more than 50% of patients had fixed airflow obstruction, so had a spirometry defined COPD. About 30% of patients had PRISM. A lot of these patients had small airways disease when we speak about PRISM, so preserved ratio impaired spirometry. A lot of these patients were found to have small airways disease, and 8% of patients had bronchial hyperresponsiveness, which is how we define these patients as having an asthma phenotype of disease, and about 11% of patients have normal spirometry. So think of it, about 90% or near 90% of patients in the post-TB category of patients, so the 850 odd patients we spoke about, had an abnormal spirometry. It was only about 11% of patients who had a normal spirometry. You heard Professor Osmani speak a little bit a while ago about small airways affection in patients who were in the non-smoking category of patients. So even this category of non-smoking obstructive airways disease patients falls in that category. Fixed airflow obstruction and also a lot of small airways affection is what we saw in these patients. We spoke about 8% of patients having a lot of bronchial hyperresponsiveness. When we looked at pre and post spirometry values, bronchodilator reversibility of 17% and 22% respectively were found for FEV1 and FVC. So FEV1 increased by 17% and 22% in a small proportion, about 1 out of 5 patients in the cohort of patients that we examined. We've spoken about the nature of the spirometry. This is how the symptoms presented. So majority of patients, as you would expect, presented with dyspnea and cough. These were the commonest symptoms by far. 60% of patients had at least one exacerbation. So 59% to be precise had one exacerbations. 40% of patients did not have an exacerbation, and 10% of these patients had 3 or more exacerbations. So significant exacerbation in the category of patients with post-TB obstructive airways disease. We looked at the MMRC score and we looked at the CAT score to look at burden of disease severity, the burden of symptoms in these patients, and a significant number, 3 out of 4 patients had prominent symptoms based on an MMRC and a CAT score categorization. So 66 to 77% of patients had an MMRC of 2 or greater, and the CAT score was greater than 10 in 77% of patients. This was an interesting bit of the study. We looked at the extent of involvement of the lung and the degree of obstructive airways disease. And to cut a long story short, radiological scoring on chest X-ray, which was done on 2 different ways based on the various regions of the lung, and had very little impact on the presence of COPD. And presence of fibrosis was found in about 50% of patients. However, if you found fibrosis in the lung, significant multilobar fibrosis, your chances of getting airways obstruction increased by a factor of 2.5. So presence of fibrosis in the lung increased your risk of getting obstructive airways disease in these patients. And very briefly, when you looked at medication details, 85% of patients received inhaled medication, which still meant that about 4% were on oral medications and 11% were getting a combination of oral and inhaled medications. So I've told you about the key findings. Actually, I'll skip this slide and go on to the other area which I want to discuss, which I'll speak of in much lesser detail, which is post-TB bronchiectasis. This is our seminal paper, the EMBARK paper, which Professor Nicolas Roche was alluding to at the beginning of the talk, where we looked at more than 2,000 patients, and we found that in our cohort of patients, more than 35% of these patients had post-TB bronchiectasis. It was by far the commonest cause of bronchiectasis. In the Indian cohort of patients, you had equal affection of different lobes, and you had a large number of patients who had cystic bronchiectasis. So cystic bronchiectasis and equal lobar predilection. It was not the upper lobar disease that you would expect to find in patients with TB. The other important factor was that these patients in spirometry had a predominant restrictive spirometry. They had a low FVC phenotype, which classed the 26% of patients in EMBARK India who had a restrictive spirometry. The other interesting part was that a lot of these patients, in fact about 60% of patients in EMBARK India had no daily sputum, and a lot of this was driven by the post-TB bronchiectasis population. So another carry-home message for all of you, the fact that post-TB bronchiectasis produces less sputum than the other categories. I'll finish off talking about the global data on post-TB bronchiectasis. This is something which got presented by myself at the ERS this year. So this was looking at the entire EMBARK cohort, about 19,000 odd patients, and we looked at the total number who had a history of pulmonary tuberculosis, that's about 12%, and then the physicians reporting TB as being the cause of bronchiectasis in a slightly lesser number, which was 8.3%. So out of the 19,000 odd patients, 8% globally were thought to have post-TB bronchiectasis. A majority of these patients, that you would expect, is from Asia, and then significant numbers from Eastern, Southern, and Central Europe, less from Western Europe and UK, as you would expect. So what did we find? In the entire data set, we found that these patients were older in age, had a higher risk of Pseudomonas, a lower risk of H. influenzae. The FEV1 in these patients was markedly lower. Asthma was less common in this population of patients, similar to what the data I presented in the obstructive airways disease category. They had a greater radiological bronchiectasis with cystic disease, and unlike the Indian data, looking at the global data showed that there was more of upper lobar disease, which is something you would expect. So greatest amount of right upper lobe disease, to a lesser extent left upper lobe disease, and very low numbers of lower lobe disease in this cohort of patients. So in conclusion, we've discussed about two different categories under the umbrella of post-TB lung disease. Non-smoking COPD is under-recognized. TOPD in that category has the lowest recognition, not just in India, but probably globally. The distinctive features, we spoke about the distinctive radiology, lower incidence of the classic obstructive spirometry, more exacerbations, greater involvement of small airways. I haven't spoken about vascular involvement. That's something which happens in some of these TB patients. And the inhaled steroids, as Dr. Sheetu Singh was saying a little while ago, should be used with greater caution in this cohort of patients. And then very briefly about post-TB bronchiectasis, we've said that's the commonest form. We have defined the nature of the disease, but very important carry-home message, the fact that the National Tuberculosis Elimination Program is doing yeoman work in the country in reducing the prevalence of TB. But microbiological recovery, as we have shown, is not recovery from TB. The chronic form of disease that we have continues long-term. It's something that needs to be thought about with greater detail, and to try and diagnose this disease early, follow up, regular lung function, and maybe a CT later on would be what is required to define the bulk of post-TB lung disease. Thank you very much for listening.
Thank you, Dr. Raja, for your excellent presentation. Please seated. Now we will go to the panel discussion on infectious disease of the respiratory system. And the panel discussion is moderated by Dr. R.M.P.L. Ramanathan. Ramanathan, please. Dr. Ramanathan is a consultant chest physician and lung transplant physician, Kovai Medical Center, Coimbatore, Tamil Nadu. And I also invite the other panelists, Dr. K.K. Mujibur Rahman, consultant and interventional pulmonologist, EPS Lakeshore Hospital Research Center, Kochi. Mujib, please. Please, Dr. Rahman.
Good afternoon, everybody. I thank Raja and team for this invitation. Excellent sessions. Now, I'll just straight to the point. Now, I'll ask a couple of questions to James. So, he is a man of bronchiectasis. We all know that when we talk about bronchiectasis, it is always infection what it comes in our mind. And these patients of bronchiectasis, they come with recurrent infective exacerbations. And they are exposed to so many antibiotics at various point of time, may not be the adequate dose, may not be the right choice, but when they come to you, you may have a bug which is drug resistant, antibiotic resistance. James, how do you suspect who are the candidates? We do get sent for cultures, we don't grow anything, it says normal respiratory flora. We are clueless what to give. They have taken tons of amoxicillin or clavulanic acid. So when to suspect drug resistance, how to pick up that bug which is not coming in the culture.
Yeah, this is incredibly difficult. So there are about 30% of patients will recurrently not grow pathogens. In that situation, I think it's important to think about reasons for false negative cultures. One is the transportation of the samples to the laboratory in a prompt fashion. Many pathogens will die within a few hours of being expectorated, and so a discussion with your microbiologist about whether the samples that they're getting are good quality. I frequently have to do bronchoscopy on my patients in order to get good quality samples if they don't expectorate good sputum, and you heard from Raja and the EMBARK India data that a lot of patients, particularly in this part of the world, don't produce good quality sputum samples. But if you do get recurrent negatives, also think about non-infective drivers of exacerbation. An exacerbation of ABPA, which will not respond to antibiotics, can present very similarly to an infective exacerbation with difficult to expectorate sputum. So don't fall into the trap with bronchiectasis patients of thinking everything is infection. A lot of the time, the treatment of a deteriorating patient is, in fact, they've got an exacerbation of ABPA or non-tuberculous mycobacterial infection or another complication that doesn't show up on a traditional culture.
Yeah, there's a lot of take-home messages, the practical points when you handle such patients. And in this setting, what is the role of this biofire in your patients?
Yeah, excellent question. So at the moment, the primary indication for these diagnostics is in patients with pneumonia. So the BioFire pneumonia panel is validated for use in patients with acute respiratory infection. We use these molecular diagnostics for some of our patients, mostly severe CAP, either in the ICU or in our high dependency setting. As I showed you, the big challenge we have with this is that if the BioFire is positive and shows a resistant pathogen, we broaden antibiotic therapy. If it shows Pseudomonas, we broaden antibiotic therapy. When it doesn't show a significant pathogen or it doesn't show an atypical, we're very bad at de-escalating. Physicians think, oh, I'll be safe and I will not de-escalate. And this is the thing that we need to change, because broad spectrum antibiotic therapy is not safe. Often it's associated with increased mortality. So I think the BioFire systems are very, very helpful, but we need to get better at using them appropriately, and tackling antimicrobial resistance involves also using less antibiotics, not always increasing the spectrum of antibiotics.
So at present in the market, in Indian market, we do have this options. We have to be clear what we ask for. There are different upper respiratory panel, BioFire and Pneumonia Plus, I think, so that because upper respiratory focus more on viral aspect, and the lower respiratory gives a drug resistance also pattern.
So that's correct. So the upper respiratory panel is not going to help you very much with a bacterial pneumonia, because it's almost exclusively viruses with a few atypical pathogens. So the pneumonia panel, which is a sputum or BAL validated panel, gives you, I think it's 26 targets, and it's most of the bacteria that cause severe community-acquired pneumonia. So very useful from an antibiotic stewardship point of view, if we can become confident in using it appropriately.
So one last question to you I'll complete the airway infection with you, drug resistance. Nebulized antibiotics and our responsibility in drug resistance. What is your thoughts, Shah?
Yeah, so this is very important. Sometimes with patients with bronchiectasis, but also cystic fibrosis, severe COPD, we see pathogens that are highly antibiotic resistant, Pseudomonas, for example, resistant to everything. Inhaled antibiotics can be incredibly useful in this situation, because the concentration of antibiotic you can give through inhalation is way higher than the MIC, the minimum inhibitory concentration that defines resistance. So sometimes in vitro you will see this is resistant to whatever the antibiotic is, resistant to tobramycin, but you give inhaled tobramycin and the patient responds beautifully, because you're giving 100 times the antibiotic concentration compared to what the lab regards as resistance. So inhaled antibiotics can be a very important way of dealing with antibiotic-resistant pathogens.
Very relevant to colistin and in an ICU.
Correct.
Yeah.
Relevant.
Thank you, James. Now, I just go to Raja about post-TB lung disease. I'm sure that when somebody has been treated with tuberculosis, extensive tuberculosis, most of the time it is all sequelae of, already they come very late, there is a structural damage is more, and these are the people, they have a lot of sequelae and they have morbidities. One very important thing we talked about is the airway disease. You have a standard diagnostic tool, like you do a spirometry when they are symptomatic. Other thing is, which probably, like when we see a patient from a GP, they would have been giving repeatedly, again, anti-tubercular drugs without proving the recurrence. And we do see some of us make a diagnosis of chronic pulmonary aspergillosis. So this is actually, it's not uncommon, aspergillus colonization of our patients with the post-TB lung disease. So I want, Raja, just your, although you did not have time to touch about this, so I want you to just tell about when do you suspect CCPA or chronic pulmonary aspergillosis, a patient of post-TB lung disease?
So I think I'm very pleased you asked that question, RMPL, because like you said, I did not have a chance to actually address this.
There was a session actually.
Correct.
in
Correct.
the
Correct. So So chronic pulmonary aspergillosis you would suspect in people who got recurrent exacerbations in the post-TB period or in any chronic lung disease. And in these patients, if you end up doing a aspergillus IgG and the aspergillus IgG comes back as being significantly positive, the aspergillus sensitivity would actually predict further exacerbations of the disease and would need specific treatment. So as a carry-home message for the audience, in patients in the post-TB period, in the perspective of today's talk, but in any chronic lung disease, if you're getting recurrent exacerbations, if you have a refractory cough, you do your aspergillus serology panel, and if your aspergillus IgG comes back as being positive, these patients are aspergillus sensitive and need treatment to control the symptoms associated with their chronic lung disease.
One more thing is these patients have definite constitutional symptoms. They tend to worse. They have recurrent hemoptysis, they have recurrent episodes of fever, and then they have a change in radiologic findings, and definitely we need to just look for this entity because it is not uncommon in our patients. So next is that already morning, one of the sessions we had talked about treatment. Are you going to be treated differently, COPD due to smoking and post-tubercular? Sure. Lung disease?
So I think if we think of this in three different sections RMPL, so if you think about smoking associated COPD, which we heard in the morning, was more an emphysema predominant disease, right? In that category of patients, you have more of neutrophils in the airway. It's probably going to be bronchodilation with a LABA-LAMA, which forms the backbone of treatment. In the obstructive airways, non-smoking obstructive airways disease category, I think Umar in the morning spoke about the fact that they have small airways disease. We know these patients have a chronic bronchitic phenotype. We know that they have more of eosinophilic airway disease. And here, in a majority, adding an inhaled corticosteroid to the bronchodilators probably makes greater sense. In the TB category of patients, because these patients are post-TB, because this is a more neutrophilic phenotype of disease, you would probably avoid the steroids as far as possible, unless you had a predominance of airway or peripheral blood eosinophils, which is a very small minority of patients with post-TB obstructive airways disease.
Yeah, that's great. So just last question for all the panelists, anything, or any one of you can answer. Semi-invasive pulmonary aspergillosis or a chronic pulmonary aspergillosis in a patient of chronic airway disease. How common it is, the literature says it is definitely there, the long-standing airway disease due to asthma or COPD. One of the risk factor for semi-invasive aspergillosis. Any thoughts? And
semi-invasive is slightly different from the chronic.
But they are immunocompetent. Basically, they are not very overtly immunocompromised.
This is slightly different from the chronic cavitary pulmonary aspergillosis. These patients used to be commonly immunocompromised. They used to be diabetic or on steroid or on HIV patients or other organ transplant patients. And their progression of the symptoms usually will be a little fast compared to the chronic pulmonary aspergillosis. It will be within the 3 months as per the duration. In CPAV, it tends more than 3 months, but here they progress even faster. And if you look at the biopsy also, there will be definitely a fungal hyphae which is infiltrating the parenchyma. And of course, there will be positive culture of aspergillus also. So these two other parameters will also add to consider semi-invasive form of pulmonary aspergillosis. The duration, the risk factors, immunocompromised individual, rapid progression, and pathological evidence of parenchymal infiltration, plus the culture positivity will add a diagnosis of semi-invasive pulmonary aspergillosis.
Dr. Klo? So the biopsy is what the difficult part here. It's not like they don't have a overt lesions where you do a biopsy. It is basically they have a very tiny acinar nodules, multiple nodules, and they are airway disease patients.
Yeah, thank you. Anybody wants to add something to this?
Yeah.
No? Maybe we need to close, or you have other questions?
Yeah. I think that any other questions from the audience?
Yeah.
1 or 2 questions in this session. So like it's a very broad topic, infections of the respiratory tract or system.
Question to Dr. Chamas. Thank you for your talk.
You mentioned that even if Pseudomonas is resistant on the culture sensitivity report, because the levels of tobramycin which are achieved in the alveolar fluid are very high, it will be sensitive. Is there any data to suggest what are the levels of concentrations which are achieved in alveolar fluid? And if you have data, is it a good idea to ask the lab to report sensitivity or resistance to tobramycin at that level which is achieved in the alveolar fluid?
Yeah, so there is published data for these antibiotics. So most of it comes from cystic fibrosis, and it's approximately 100 times above the MIC. So it is useful in these situations to ask the lab to report the actual MIC, because I think, so I'm not a microbiologist, but I think the MIC for tobramycin is something like 4 micrograms per mil. So if the organism is dying at 20 micrograms per mil, it will be reported as resistant, but the antibiotic given by inhalation is going to kill that organism very effectively. So in those situations, I certainly do ask the lab to give me the exact MICs rather than just the SNR that we usually get, and that's useful.
Yeah, thank you so much.
Yeah, Christopher, one last question. Christopher, you want to talk?
In the interest of time, I'll talk to Raja personally. Thank you.
Yeah, that's nice. That's done.
Thank you, Dr.
Yeah,
Ramanathan.
thank you, the panelists, for a wonderful session, and it is a very insight about community-acquired pneumonia and post-TB lung disease. Those are great sessions.
Thank you all panelists. Before we break for lunch, there is a special announcement from the chair of ERS, Madam Silke, please come over.
So thank you. And so before we break up for lunch, we have heard already many times during the inauguration that this event would not have been possible with a lot of people being involved from both the Indian Chest Society and the ERS. And as a consequence of developing the program, the organization, the collaboration of the two societies was truly outstanding, and I'm really grateful for the Indian Chest Society and everyone who was involved from the ERS side for this event. But there is one person who has been more than others instrumental in making this event happen, and this is Dr. Raja. I mean, I haven't been involved from all the beginning from organizing this event, but I have been very well aware of how much work has gone in to the organization, to the program, to every single part in the 3 event locations. And even when you were in hospital, you have been joining meetings with us, have been organizing the event from your hospital bed, and we are deeply grateful for everything what you have done. And on behalf of the ERS, I would like to honor you with providing you with a shawl. Following the Indian tradition.
So one announcement, so before you all break up for lunch, make sure that this is just the halfway mark. We have more interesting and exciting sessions. There are going to be better and more thought-provoking sessions and discussions after lunch. So recharge, refuel, network with your peers. And if you're thinking about sneaking out early, please don't do that. We give you permission only to leave after the session, of the whole program is over. Thank you. Please be back, I would say, in under 45.
Rajadhar. Can I request the audience to please give him a standing ovation? I mean, he thoroughly deserves it. Tremendous spirit, tremendous courage, and your passion and your dedication to this event. Thank you, Raja, for making this happen.
So I think this was a team effort, Sandeep, and you know that. All of us work together, and the greatest reward is seeing all of us together today, all the delegates who have come, the faculty who's come and attended. So very, very grateful to the ERS and all of India for turning up in support and participating in academics. Thank you very, very much.
check, 1, 2, 2. Hey, 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 check, check. 1, 2, 2, 2. Hey, 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 check. 1, 2, 2, check, check. Hey, 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 check, check. 1, 2, 1, 2, 1, 2, 2, 2. Hey, 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 check, check, check. 1, 2, 2, 2, 2, 2, 2. Hey, 1, 2, check, check. Hey, hey, check, check, check. 1, 2, 2. Check. Check. 1, 2.
Check.
Hey,
Hey. Check. Hey. Check. Hey. Hey. Check. Check. Hey. Hey. 1. Check. Check. Hey. 1. Check. Check. Hey. Hey. Check. Hey. 1. Check. Hey. Hey. 1. Check. Hey. 1. Hey. 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 Check. Check. Hey. 1. Hey. Hey.
रहा है कि वो बंद रखा हुआ है, इसके लिए वो फीडबैक है।
चेक चेक है,
उसका जाके वापस आ रहा है, तो उसको डबल आ रहा है, लेकिन
check, 1, 2, 1, 2, hey, hey, check, check, 1, 2, 1, 2, 2, hey, hey, check, hey, hey, check, 1, 2, 1, 2, hey, hey. Check, check, 1, 2, 1, 2, hey, hey. Check, 1, 2, 2, 2.
Check, check. Hey, sound check. Hey, hey. उधर से ऑफ है वो. Check, check, check. Check, check. इस बाजू तो एक मॉनिटर घुमा सकते हैं, उस बाजू को देखना पड़ेगा.
ये सही किया.
Hello. Can I request people in the back to come to the front? You've got empty seats here. I'm sure there'll be people coming.
This would be the session session 3. So this would be the clinical grand rounds. It would be a case-based discussions on infections, mostly on the Indian context. So to chair the session, I would like to invite Professor Chalmers. And I would like to invite our subject expert, Dr. Satish. So Dr. Satish is a senior pulmonologist at Fortis Hospitals, Bengaluru. One of the godfather figures in the Bangalore chess group. So over to you, Dr. Satish and Chalmers.
Hi. Good afternoon, everyone, and I'm sure you've had a good lunch and some rest and some networking. Welcome you to the afternoon session. We had a great morning session and it went off on time. So without wasting much time, let me call upon Dr. Rajadhar, who needs no introduction, for the clinical grand rounds case-guided discussion on other infections in the Indian context. Let me also quickly call upon Sheetu Singh, who also needs no introduction. She's the Director, ILD and COVID Pulmonary Rehab Clinic at RHL Jaipur. Also, the second case presenter, Dr. Avinash Nair. Avinash Nair is here. Yeah, hi Avinash, consultant pulmonologist, CSI, Kalyani Multi-Speciality Hospital, Chennai. Let me also call upon the panelists, Dr. Kushbu Pilania. Kushbu here, founder, consultant, radiologist, Eisen Imaging and Interventions, Noida. Nanda Gopal V. Nanda Gopal V is here, consultant pulmonologist, Institute of Lung Care and Research, Hindustan Hospital, Coimbatore. Yuvarajan is here. Yuvarajan, Professor, Head, Department Respiratory Medicine at Manakula Medical College Hospital, Pondicherry, and Professor Asmita Mehta, who's here. Come over. Thank you. Professor and Head of the Department, Respiratory Medicine, Amrita Institute of Medical Science, Kochi. Okay, over to you, Raja.
Thank you so much, Satish. Welcome back, people, after lunch. So we had a very nice lunch. I'll try and make sure we'll all together try and make sure that you don't have a postprandial nap. So that's the aim. We'll start off with the first case, which is going to be presented to us by Dr. Sheetu Singh. Sheetu, come over, please. The way we do this is for Sheetu to present the case over 5 minutes, and then we'll have a discussion on various facets this case brings forth post the presentation of the case, and then we go over to Avinash for the next one.
Very good afternoon to all of you, and at the outset I would like to thank Raja sir, Sandeep Salvi sir for inviting me here. It is my honor and privilege. So here we have a case of a 42-year-old non-smoker, no comorbidities, presented in May 2021. The patient had fever, low grade since a month, dry cough, difficulty in breathing since 1 month, had COVID 1 month back with a score of 8/25, recovered within a week. He did not get admitted and took some symptomatic treatment without steroids. Patient had an interesting history of chronic kidney disease in 2 of his siblings. On examination, the vitals were within normal limits except for the saturation, which was 81% on room air, a rate that was 30 per minute, and some signs of respiratory distress, no clubbing. Apart from that, accessory muscles of respiration were active, and there were some coarse crepitations on auscultation. When we looked into the investigation, the X-ray here showed a right paracardiac lesion or an opacity in the right lower zone. The ABG showed type 1 respiratory failure with a PF ratio of 120. Creatinine was 1.5 and the D dimer was raised. Other than that, the 2D echo showed mild tricuspid regurgitation, mild pulmonary hypertension, and RVSP of 25 to 30. This was the CT scan for the patient. The axial sections, the lung window here shows areas of cavitation with internal soft tissue window showing hyperdensity along the soft tissue. And the mediastinal sections here also show some areas of cavitation.
Shall we just stop for a moment, Sheetu? So we'll get our radiology expert, Dr. Khushbu Pilania here. Let's go back to the X-ray once, Sheetu, if you don't mind. Just go to the previous slide once. So Khushbu, the X-ray here, tell the audience what it is that sort of hits you. I know it's not the best of X-rays that we can have, but what is your thought process on seeing that X-ray, and does that get corroborated with the CT that you saw after that?
Yes, it indeed. Yes, so the X-ray indeed corroborate with the chest CT scan that we did. We are seeing a very obvious right paracardiac opacity, and it's showing the internal cavitation or necrosis as well. So, I mean, this is quite a positive radiograph, unlikely that we get in most of the cases.
And the CT after?
And exactly at the same location where we were expecting, we are getting this cavitatory lesion. And as Dr. Sheetu very clearly pointed, there are some hyper-attenuating as well as hypo-attenuating areas. So there is air, fluid, and hyperdensity, 3 things happening all together within this cavitation.
So Khushbu, I'll push you a little bit further before Sheetu gives away what exactly it is. When you write impression here at the bottom, once you've described this, what impression would you put on the report for the audience?
In this case, there is a cavitating lesion with necrosis, air, as well as hyperdensity, and towards the periphery, there is some infiltration of the lung. We see some ground glass, some septal thickening also around that side. So we'll say that it's a cavitating lesion, and at the age of the patient, especially in a non-smoker, infection is a strong possibility, but it requires biopsy.
And we've stopped, so I'll ask you another question before we go forward, and maybe a comment maybe from Dr. Nandgopal. So seeing the X-ray and the CT, we saw that this patient is distressed, doesn't have a previous history, saturations of 81%, respiratory rate of 30 per minute, moving accessory muscles of breathing. Would you think what you see on the CT is enough to explain the degree of hypoxia that this patient has, or you're thinking there must be something else wrong with this person to give us the diagnosis?
No, definitely there is a clinical radiological dissociation. So this CT and X-ray does not explain the clinical condition and the oxygen desaturation of 81%. There should be something else.
Okay.
So we don't know what it is, probably with the COVID history, but COVID is not very severe COVID, so still we have to just wait out and see.
So I've eaten up a few minutes of yours, Shitu, so go forward and we'll...
So given the clinico-radiological dissociation here and the raised D dimer, we also went ahead and did the CT pulmonary angiography, which showed a thrombosis of the laterobasal subsegmental branch of the right lower lobe pulmonary artery with an abrupt cutoff of the contrast vessel, and there is a normal contrast in the anterior vessel. But since, as Dr. Khushbu just mentioned, we needed a biopsy to find out what was the underlying cause, we went ahead, did a bronchoscopy, and from the right lower lobe superior segment, a lavage was taken, and along with that, the biopsy was taken from this endobronchial lesion, which was seen a polypoidal-like lesion. And I move ahead. So we send the sample for multiple, because many times you get a negative result, so we sent the cytology, which showed some granulation tissue with necrosis and non-septate hyphae with 90-degree angle branching, non-parallel walls suggestive of mucormycosis. We also went ahead with a fungal stain which showed the same, and the biopsy again showed broad septate hyphae with right angled branching and non-parallel walls. A fungal MIC by broth dilution was done to see for the sensitivity, and it showed that the mucor was sensitive to voriconazole, amphotericin and itraconazole. So our final diagnosis here was pulmonary mucormycosis with pulmonary thromboembolism or angioinvasion with a background of familial chronic kidney disease. Patient refused for surgery, immediately started on induction therapy with liposomal amphotericin for 30 days. Enoxaparin was also given. Patient clinically improved, oxygen was weaned off, and clinically better in terms of the fever, the cough and the breathlessness. This was the follow-up CT scan done after a month period, where you see that it has resolved in terms of the necrosis, the cavitation, and it is turning more of a fibrotic. Patient completed the therapy and then was put on posaconazole for 6 months. He was much better. Unfortunately, I don't have the follow-up scan, but I just spoke to the patient a couple of days back, and 4 years down the line, patient is currently stable, not having any symptoms, not taking any treatment per se for his respiratory ailment. And with this, I summarize that mucormycosis can occur in previously healthy individual post-COVID. Thrombosis in post-COVID patient, think of fungal angioinvasion. Early fungal stains and biopsy are crucial for timely diagnosis. More the merrier. Send multiple samples whenever you are doing a bronchoscopy, which includes the lavage for all the fungal stains, cytology, biopsies. And on histopathology, if you find necrosis without the presence of granulomas or tumor, suspect fungus, and then apply the fungal stains such as PAS or gomori-methamine silver stain. Surgery plus antifungals have shown superiority over antifungals alone, and surgery is indicated in progressive disease despite antifungals, massive hemoptysis, localized or resectable disease.
Grand Chitu, thank you. Lovely case and very nicely demonstrated. Let me, before I ask you to go and join the panel, can you bring up the CT which showed the embolus? Anything that you wanted to add to that particular CT, Khushbu? I think Shitu described it beautifully, but anything else you wanted to add about this pulmonary
So
angiography?
just one thing that these are more of angioinvasion and considered a very specific sign for any fungal infection. So considered a very specific sign, especially mucormycosis and angioinvasive fungal infection. They are different from the routine thromboembolism because in this case we are not expecting the thrombus to go to the proximal vessels as much. So the thrombus will continue, I mean it's not thrombus but it's just a cutoff of the vessel at around this side. So we are seeing that this side the vessel is just cut off because the fungus has invaded the vessel. And it's highly unlikely that we'll see a thrombus going all along the rest of the pulmonary vasculature. And yes, and currently a lot of people have also started advocating that doing a CT-PA rather than a routine HR-CT helps us increase our diagnostic confidence for it being some fungal. Because obviously sampling and all with these immunocompromised patients is always a challenge. So the closer we are on a diagnosis with HR-CT, it's the better.
Sure. So important message. Shitu, have a seat. So important message, the message that this is angioinvasion, different from what you would get in someone who's got a pulmonary embolism that we are used to see on a day-to-day basis. Let me start off with you, James. So James, this case presents a conundrum in that you have someone who presents very unwell, breathless, tachypnic, desaturating. You find a cause which is apparent. Would you in clinical practice go on to do a CT pulmonary angiogram, or would you have gone and bronch the guy? What would be your clinical course working in a tertiary care center in the UK?
Yeah, I think the investigation in this case is very appropriate. We heard earlier, and I agree, there was a dissociation in terms of the oxygenation and the radiological appearance. So it was very important in this case to investigate for a secondary issue beyond just the presence of the pulmonary infection. I think that's a useful message to remember, that if the clinical picture doesn't fit, even if you've got a diagnosis, look for the explanation for severe hypoxemia, which in this case was the invasion. It's a really interesting case. We don't see very much mucormycosis in the UK, and we have the impression that a lot of it is caused, in most patients, it's severe immunosuppression, and that the post-COVID was primarily related to dexamethasone use. This patient's young, no apparent immunosuppression, and didn't receive steroids. So it's a nice indication that COVID itself is sufficient to suppress the immune system to the extent that you can get mucormycosis.
Yeah, no, absolutely. Let me come to you, Yuvraj. So, we are more used to seeing mucor in the perspective of diabetes, and then, as James said, in the perspective of COVID, right? So, have you seen a lot of mucor outside these conditions, so outside diabetes, and do you think the chronic kidney disease, which Shitu said was familial, do you think that's relevant to the case?
Sir, you already pointed out, on my personal experience, most of the cases of mucor I have seen in diabetes patients. If you just worked up the patient, they will have a poorly controlled diabetes, and they present with ketoacidosis. This is the commonest presentation when you get a mucor. And post-COVID, we have seen a lot of cases, COVID-associated mucor is a separate entity. And even though literature is telling post-transplant and all these things, I am not working in a transplant unit, but still it is very higher side. CKD patients, according to me, maybe out of 100%, if I want to give a ranking, maybe less than 10% I have seen. It's not so common, sir. Sir, regarding one more point, I just want to add in the CT.
Sure, please.
Sir, this is a vascular occlusion sign. This is the sign what you are getting, that vessel occlusion is there. You may get in any angioinvasive fungal disease, but according to literature, it is more common with invasive aspergillosis. Because mucor actually, when I have 2 cases in my ward, if you get a mass-like appearance along with necrosis of the cavity, if you suspect mucor, I always do a CT pulmonary angio, because most of the times mucor is associated with the pulmonary artery pseudoaneurysm, sir. I have presented this 2 times in ERS last meeting also, because when it will be looking like a normal mass or consolidation. When you do a contrast, you will see a big pulmonary artery sitting in the center. Basically, mucor will cause a damage to the wall and cause dilatation. Without knowing the idea, without knowing the contrast, if you do a biopsy, it will be terrible. So that's why my take-home point is that if you see any mass, think of mucor is there, always try to do a contrast.
Can I have the pointer, please? I think Yuvrajan makes a wonderful point, and it's worth reiterating. He says if you saw this on the CT, you would see this as a mass. A lot of us would think this is the mass which needs a biopsy. However, if you did the biopsy without doing a CT pulmonary angiogram, I don't need to tell this audience that the results will be catastrophic. So this mass-like occlusion of the proximal pulmonary artery, along with what you see as a bit of cavitation there. This is classical, the occlusion is classical, it looks like a mass, but under these circumstances, it's important to pick this up within the pulmonary artery, and it often indicates mucor. And you say happened in aspergillus also, this angioinvasive?
Yes, sir. Sir, actually, this vessel occlusion, as per literature, it is common in both the fungi, but it's more with aspergillus. In mucor, most of the literature has shown that the mass which shows center, you will have a dilated pulmonary artery.
Sure.
So I have 2 cases present right now in my ward.
Amazing, wonderful. Let me come to Ashmita. Ashmita, all of us saw this. The country ran out of both amphotericin B and liposomal amphotericin B during the COVID time. So hopefully we are done and dusted with COVID, but we do get a lot of severe influenza pneumonias, we get other viral pneumonias. Do you think a similar mechanism happens? Have you ever in your clinical practice, you or anyone else on the panel, seen patients with a severe viral pneumonia present with mucor at a later stage because of the immunomodulation that James spoke about a little while ago?
So after COVID came, then only we started thinking of invasive aspergillosis associated with influenza or IAPA. And if you are asking my clinical experience, no, I didn't come across any mucormycosis. I have come across plenty of aspergillus. But when I searched the literature, I found that it is the same mechanism which causes aspergillus, so it can happen.
Sure. Okay. Grand Ashmita, I'll come to you, Nandagopal. A couple of things about the management. The first thing was, Shitu pointed out that the patient was offered surgery first, which he refused, and then went on to get the antifungals that she pointed out. So is that standard practice? And I'll have a quick comment from Shitu after, to offer surgery first up, or is it antifungals to start with, you load them up, treat them and then go for surgery if surgery is at all indicated or agreed on?
Early surgery would be the best option. So for the same reasons what Dr. Yorajan was talking, that aneurysm could burst anytime, the vascular invasion could worsen, you can end up with a catastrophic hemoptysis. So it will be early surgery followed by antifungals would be the best.
Okay, so early surgery followed by antifungal therapy. Shitu, anything to add?
Just to summarize that there are studies which have shown that a combination of surgery plus the antifungals have better results in terms of mortality as compared to antifungals alone.
Okay, okay, grand. And one last question about the treatment. So, is there a benefit of starting off and continuing with voriconazole versus giving them liposomal amphotericin B for a period of a month like Shitu did? What would you normally do in your clinical practice?
We don't have much of an experience, many cases that much to compare both options, but I would give liposomal amphotericin B to be the first option.
Yeah. So Ashmita first and then Yuvrajan and then we'll move to the next case. Yes, Ashmita.
I would differ because voriconazole or mucormycosis is particularly inherently resistant to voriconazole, and voriconazole is not given for mucormycosis. It does not work for that. So drug of choice, we have got only 3 drugs, liposomal, different ABC and other complexes. We have got isavuconazole, which is oral and it can be used, however expensive, and posaconazole. That's it.
So I actually meant posaconazole, but I slip of tongue, I said voriconazole. So quick comment, Shitu, about sort of what the evidence shows for the audience. I mean, is it usual to start off with liposomal amphotericin B for a month and then go on to give posaconazole, or could you just give the oral for long term?
The first drug of choice is amphotericin, given for 4 to 6 weeks. And subsequently then patient can be switched over to posaconazole or isovuconazole.
Okay, wonderful. So I think that's great. Can we have the previous presentation, the summary points that Shitu put up? Can we put those up again? Yeah. Just put up the summary points from the previous case and then we'll move forward to Avinash's case. Avinash, in the meantime, please come over to the podium. Yeah, so very important points can occur in previously healthy individuals. We need to be conscious about it. It's happened pre and post COVID, I would guess. Thrombosis and fungal angioinvasion, I think that message came through very nicely. Early fungal stains and biopsy crucial. More biopsy specimens. necrosis without granuloma, apply fungal stains, and then you heard about the treatment, the management that we spoke about. I think that's a lovely case, Chitu, with lots of learning points, and we'll move over to you, Dr. Avinash Nair. Avinash, can we have the next presentation, please?
Thank you, sir, and good afternoon, everyone. It's a pleasure to be here today for the ERS ICS Summit. I would like to thank the organizers, my teachers and mentors for this opportunity. Without further ado, after that wonderful case we had, we are going to a different spectrum of infectious disease with my case. We have Mr. S. He is an 80-year-old gentleman who is a retired government employee, who is a reformed smoker with significant pack years, 15 pack years, who had quit smoking for the last 10 years. He presented with complaints of fever with chills, cough, and worsening shortness of breath for the past 1 week. In the background, he had severe obstructive sleep apnea, and he was on auto continuous positive airway pressure therapy for 2 years. He had multiple exacerbations in the past 1 year for probable COPD or an airway disease exacerbation, which required multiple course of steroids. And recently, he was managed in another institution where he was given a tapering dose of methylprednisolone 16 milligrams twice daily. With this history and background, he came to us. On examination, he appeared tachypneic and tachycardic. He required a low flow oxygen to maintain a saturation of 90%, and the respiratory system examination showed that he had right infraclavicular mammary and bilateral basal crackles with ending expiratory wheeze. The other system examination was within normal limits. Our baseline investigation showed that his ABG showed a type 1 respiratory failure with a PF ratio of 280. The total counts were actually raised with a left shift, and his CRP, which is an inflammatory marker, was also raised. He had mild transaminitis, the OTPT, and there was acute kidney injury as well. His screening echocardiogram showed no regional wall motion abnormality with an EF of 60%, and there was mild pulmonary hypertension. This was his screening X-ray. As we can identify,
let's have a quick look at, you're going to show us the CT next, aren't you, Avinash?
Yes.
So let's have a look at the CT, and then we'll get Khushbu to give us some comments about the X-ray and CT together.
Okay, sir.
Yeah.
So I'll just rush through the sputum as well.
Sure.
So the patient had a sputum examination done, which showed that the CB-NAT was negative. Gram stain showed some GPCs in pairs. The fungal smear was inconclusive, and the AFB was negative. We later proceeded to a CT, which showed a right upper lobe cavity with pericavitary consolidation.
So again, the same question, Khushbu. We'll go back to the X-ray, Avinash, if that's okay. Any comments?
So yes, even in this case, the X-rays are good enough to depict that there is a need for CT scan. There is a cavitatory lesion in the right upper lobe. We don't know what it is, and it needs a CT scan to be sure.
And then the CT, I guess, just shows what the X-ray showed,
yes,
right?
It exactly shows what the X-rays are showing. It's showing a consolidation with cavitation, and we are seeing some periconsolidation, ground glass opacification all around. So it does tell us that it's not something very good. It's something which is invading into the vessels, into the lung parenchyma. It's an invasive disease.
Sure. So invasive disease, cavitary disease. So in our country, would you sort of, in the impression bit again, Khushbu, would you put in TB first? What would you put in the impressions bit?
Not really TB, because TB does not show such angio-invasion as commonly. So when we're seeing angio-invasion, fungal does come top of our cards. Apart from that, at 82 years, I will raise a suspicion of malignancy, a reformed smoker, 82 years. So malignancy and fungal infections will be two things that we'll be strongly thinking.
Okay, that's very interesting. Avinash, go forward.
Sir, we have other coronal imaging showing similar finding which Madam has just discussed now. And this is a sagittal plane. We can clearly see a intracavitary lesion inside jutting out. So we went ahead and did a bronchoscopy. As we have discussed earlier, we discussed with the patient. The patients and the family were not willing for a biopsy. So we had to convince them for a BAL alone, in which the routine culture was negative. The gene expert again, as in the sputum, came as no MTB detected. The AFB smear was negative. The fungal direct microscopy showed us a septated hyphae with dichotomous acute branching at 45 degrees. And a galactomannan study from the BAL showed OD ratio 1.3, which is positive. And subsequently, the fungal culture grew Aspergillus fumigatus, with which we went ahead, even though we did not have a biopsy, based on the clinical radiological profile, we went ahead and diagnosed the patient as invasive pulmonary aspergillosis and started the patient on therapy, initially with intravenous voriconazole along with broad spectrum antibiotics and supportive measures. The patient had a pre-renal AKI to begin with, but with hydration he improved. He showed gradual clinical improvement, and later he was changed on from the IV to oral voriconazole, and then he was discharged on maintenance antifungal therapy. He is a recent patient. This is his X-ray done in 4 weeks. He has yet to get a CT done, so which we can see that the cavity has actually changed. The perilesional consolidation has reduced. So the final learning points I would like to conclude is, like that sir said, this patient actually was referred. One point which I did not mention here was referred for an empirical anti-tubercular therapy. Even though there were findings of these, this patient was referred to us for initiating therapy, but we went ahead and evaluated further. So in a high TB burden country like ours, it is important to look at other causes for lung cavity other than tuberculosis. And invasive pulmonary aspergillosis is an important differential for cavitating pneumonias. Older age, COPD, systemic steroids are risk factors for invasive pulmonary aspergillosis, because traditionally we used to be discussed in neutropenic patient, hematological malignancies and organ transplant, but evolving use of steroids in airway disease, especially elder people, it definitely is a risk factor. And clinical suspicion, characteristics in radiology along with BAL is crucial, because technically, like in our case, a lot of times biopsy may not be feasible or possible in all cases.
Wonderful, Avinash. Lovely case. Lots of good messages. Just put up your last slide for us, and please have a seat with the panel. Have a seat. So I'll address the first question to you, Avinash, actually. You said that this patient presented with what you described as multiple exacerbations. So did this patient have a history of chronic lung disease, been ever treated for airways disease? What was the background?
So sir, the patient, this was first presentation to our institution. So what we found was there is a background history of COPD from the history itself, but never really treated with any kind of inhalers, only getting symptomatic treatment with recurrent bursts of steroids. And whenever he gets tapered off the steroids, he gets a flare again. So they never really managed to diagnose him as COPD in the beginning.
Sure. So you tick the box, the third box there, isn't it? The older age, the COPD, the multiple courses of steroids are risk factors for invasive pulmonary aspergillosis, which you tick with this patient. All the boxes, all the points probably get ticked as a result. Let me ask James. James, this patient had a lavage because they refused a biopsy. You think, is it fair to call this invasive pulmonary aspergillosis? Would it be more of the semi-invasive aspergillosis that was spoken of in the last session?
Yeah, I think it's entirely fair to call this an invasive aspergillosis. As you say, on the CT there's clear evidence of invasion. It's a positive BAL galactomannan and a positive culture for aspergillus. So I think this patient was appropriately managed as invasive aspergillosis. It's an interesting case in that we do indeed think of most invasive aspergillosis, a disease that affects people who are immunosuppressed, but this illustrates that relatively modest levels of immunosuppression can also be associated with invasive aspergillosis. There's a nice symmetry between the two cases, because it's the same message that you need to be aware of these potential diagnoses even in patients that don't have the classic hematological malignancy or severe uncontrolled diabetes, for example.
So two important messages, I think, from the panel there. The first, that you don't always need a biopsy. It's the clinical condition. It's what you see on the CT. The lavage showed aspergillus, so I don't think you need tissue diagnosis in all cases to define things as invasive pulmonary aspergillosis. You could well define that on the basis as Avinash did. The second important message is, even with low burden of steroids, multiple short courses, if you have other risk factors, like in this case, old age, untreated airways disease, you could still have risk factors for invasive pulmonary aspergillosis. Let me come to you, Ashmita. What is the significance of the galactomannan here? So the galactomannan, you remember, was 1.3. Do you think that adds anything
Do you think it would have added anything if the Aspergillus test had come back as negative? How would you position galactomannan here?
So mostly the Aspergillus diagnosis is defined by EORTC MST criteria, and there are 3 factors: host factors, microbiological factors, and clinical factors. Now coming directly to the microbiological factor in the interest of time. So they have given one microbiological criteria which is must is like if you have got a culture positivity in the biopsy. If you do not have that, then you can have Bal galactomannan which is greater than 1, or you can have serum galactomannan which is greater than 1. Now if you do not have greater than 1, but you have got Bal galactomannan greater than 0.8 or serum galactomannan greater than 0.7, or you have got serum CSF in case of you are having invasive aspergillosis of brain, greater than 1 galactomannan of CSF is sufficient. Any one of this with a clinical criteria or a radiological criteria of a cavity, you have got a probable diagnosis of aspergillosis.
Correct. Wonderful. So we are talking about where there's no microbiology, there's negative microbiology, but with a serum or a Bal galactomannan which is positive, you are most likely to have a diagnosis of aspergillosis even in those circumstances, and it would warrant treatment is the carry home message there. Let me come to you, Yuvrajan. How important is, we know the circumstances why biopsy was not taken here, but do you think biopsy is essential? So unlike Shitu's case, where there was an endobronchial lesion to visualize, this patient probably had nothing to see endobronchially, maybe other than inflamed tissue. Would you actually do a biopsy in these cases, or with everything else you have, you think a positive BAL would be enough to treat the patient the way Avinash treated the patient?
Sir, aspergillosis, this is a tricky one, sir, because aspergillosis is a common fungi everywhere in the environment we see. So, with the background of the common fungi, we are using inhaled corticosteroids for patients in a COPD. Getting aspergillus in even the BAL specimen also, that's a tricky one. It is very difficult. No test can differentiate between a colonization and the true disease, whatever it is there. As the name indicates, if you want to prove invasion, there should be some evidence for invasion, either at the form of host factor for severe immunosuppression. Whereas Avinash was telling the patient was using some steroids, but it doesn't mention that how long the patient's steroid was used, how far the patient is used, what dose the patient is on. So nothing was there actually. So based on that, we have to decide. And simply older age in COPD, I think we need to see, sir, because even the Western guidelines, whatever they have given, they have not included, because if that is the case, they have given a lot of all the risk factors.
Sure.
That is one point. And second point is that, like, if you want to prove the invasion, biopsy is mandatory.
Sure.
This is still, the guidelines is very clear that proven case of IPA, biopsy is mandatory. But when you have a clinical acumen, definitely the patient has a grown aspergillus culture, and then the Bal galactomannan. So, other than serum galactomannan, Bal galactomannan carries more weightage than serum galactomannan here. So with the background of all these things, we can put this patient as probable IPA only, and then we can go ahead if the patient not willing for biopsy.
Sure.
May I add, sir? So,
yes, Ashmita.
Correct me if I am wrong. Bal cytology showing aspergillus, will it be okay? One. And second, Bal aspergillus more than 2 specimen, then also we are okay. So aspergillus in the Bal, but you cannot confirm with 1 sample, and Bal cytology coming positive for aspergillus is equally good as invasive.
Yeah, so I think you're absolutely right about diagnosis of aspergillus. I don't think finding 2 BALs actually clinches the diagnosis of IPA. You know, it does clinch the diagnosis of aspergillus infection as such. James, can I ask you, this patient was started on IV voriconazole and then converted to oral. So 2 bits to the question. First, do you think starting intravenous is in someone who's got a reasonable digestive tract is important? And second, would you have anything to choose between vori and itraconazole?
So it's easier to answer the second question because there is some evidence. So there is evidence that mortality is improved in IPA with voriconazole compared to other options. So if the fungus is susceptible to voriconazole, it's the first line therapy recommended by guidelines. Liposomal amphotericin is an option in people who have resistant aspergillus. The first question is more difficult to answer because there is very, very little evidence, and so it's very much guided by the patient in front of you, their ability to take oral therapy, how severely ill the patient is, and therefore how rapidly you need the onset of the therapy. So that, I think, varies a lot between different clinicians, but certainly voriconazole is the treatment of choice for these patients.
And to you, Gopal, short question. This patient got sent home on oral voriconazole. How long would you continue that for? And what would you do for follow-up in this patient? I mean, would you do serial CTs, chest X-rays, lung function? What would you end up doing?
Probably CTs. The duration, big question, we don't know. So it is based on the radiological resolution.
Sure.
And if the underlying immunosuppression condition comes down, then it's better. But here the difference is the patient is just a COPD in old age, which is not going to change.
Sure.
Probably systemic steroids we are not going to use.
Yeah.
So we'll wait for radiological resolution first. Till that time we have to continue. Then take the next.
Sure. Yeah. So last 1 minute. Avinash, what did you do? What did you do for your case?
So the patient is currently on 4 weeks, sir. I am planning to give it for 6 weeks because as per the guidelines, extended therapy is only warranted for patients who are on prolonged immunosuppression. I think the airway disease proper treatment might bring out is maintenance steroids as well.
Yeah. Okay. And sort of extrapolating, James, from my post-TB obstructive airways disease talk, do you think these patients need sort of serological tests for aspergillus later? Do you think these patients have a risk of developing airflow obstruction later on? Do they need long-term follow-up even after partial or complete radiological resolution?
Yeah, I mean, certainly in our setting, my experience is a lot of patients with invasive aspergillosis, as in this case, either already have underlying lung disease, meaning that they have previous tuberculosis or severe COPD, or they develop significant risk of other complications because they may get a lot better, but they may be left with a significant cavity, which in our setting, we see a lot of these patients are subsequently infected with non-tuberculous mycobacteria, for example. So I think it's important, like with TB, to consider that these patients are not likely to be completely cured at the end of treatment, and they will require some follow-up.
So that's another important. So even with the fungal domain, like the TB domain, post-fungal domain, these patients need long-term follow-up even after microbiological cure. So last words maybe from Satish. Satish, any sort of wise words in conclusion, learning points? We've got some up, which Avinash has put up, but anything that you want to stress for our audience today, learnings from the two cases that we've heard today?
I think, Raja, mainly the fungal infections are very common, and be on the lookout for fungal infection. And as mentioned here by both the presenters, that biopsy is a must to know what is invasive or non-invasive, and also to know whether it is mucor or aspergillus. But some patients who refuse, you can always depend on your clinical acumen and other biomarkers like galactomannan to make a diagnosis. But always be on the lookout for fungal diseases, especially in immunocompromised individuals. Also bringing out the fact in Avinash's case that even short courses of steroids, many a time, given by general practitioners, physicians, us, and also self-taken by patient, can be a risk factor for various other complications of steroids. Need not be a prolonged course of steroids. That's what I want to, convey here.
Grand.
And finishing the proper course is very important. As you said, follow-up is also important, like in tuberculosis.
Yeah. Thank you very much. Thank you to the panelists. I'm sorry we didn't have time for questions, but we'll call this quits and we'll move on to the next session. Thank you very, very much.
So we come to the end of the infectious diseases session. It was pretty insightful, the discussions and the variety of cases they presented. We would go on to the next session, the fourth session of the day. That's on pulmonary rehabilitation for chronic lung diseases. I would invite the chairperson, Professor Monica Gappa, and Dr. Praveen Valsalan to come to the dais. So Professor Monica is she's the pediatric respiratory specialist based in Germany, and Dr. Praveen Valsalan is a consultant pulmonologist at Asthma Remission, Kochi. Over to you, Chairs.
Well, good afternoon from my side as well, and welcome you to the session on pulmonary rehabilitation. And we will start straight away with Professor Judith Garcia-Eimerich, the current General Secretary of the ERS. She is a respiratory epidemiologist, and she will tell us about the state of the art for pulmonary rehabilitation. Judith, please.
Yeah, that's better. Good afternoon. Yeah, it's working well, I think. Good afternoon, and thank you for inviting me to be here. I'm very happy to present you this update on where we are at with pulmonary rehabilitation. I have no conflicts of interest. My aim for today is that after this talk, you have clear what is and what is not pulmonary rehabilitation, the key components, the content of this intervention, what are its benefits, also to discuss a bit about the challenges, particularly the challenges that you face here in India to implement it, and to discuss alternatives. And this is something that actually the next speaker will deepen into. Pulmonary rehabilitation is defined as a comprehensive intervention, comprehensive meaning that it has many components, based on a thorough patient assessment, that is key, that allows patient-tailored therapies, including, as I said, several components, and among them the most important being exercise training, education, and behavioral change, designed to improve the physical and psychological condition of the patients and promoting long-term adherence to healthy behaviors. Pulmonary rehabilitation needs to be distinguished from chest therapy. Actually, when we talk about chest therapy, we are talking about the physiotherapy we do to remove the mucus, right? So to clear secretions, improve breathing efficiency. While in pulmonary rehabilitation, we basically aim to improve the exercise capacity and tolerance, reduce symptoms, improve quality of life, and also promote, as I said, long-term healthy behaviors. Pulmonary rehabilitation is nowadays recommended strongly with evidence-based support for patients with COPD, both stable and exacerbated, adults with interstitial lung disease, pulmonary hypertension, and also for other chronic respiratory diseases. The key elements for a successful rehabilitation program are these four. We need to start with a detailed patient assessment that allows select the best components that are needed for this patient needs and also preferences. The delivery method needs to be adapted to the patient, to their needs, where they live, and also we need to make sure that the health professionals that are involved, and it may be different depending on the components, are very well trained in delivering this intervention. And we need to have the four of them for success in the intervention. I'm going to be a bit in detail into the first two elements. So we need to start with a thorough patient assessment. At least we should ask the patient about their, well, we should assess patients' exercise capacity, quality of life, dyspnea, nutritional status, and psychological status. Actually, it's quite frequent that they have anxiety, depression, and this allows us to design an intervention that is adapted to the areas where the patient needs more the improvement. Then during the intervention, it's important to keep a regular monitoring so that we know how the patient is, but we also can adjust accordingly to how the patient evolves and feels during the treatment. And after the intervention, obviously we want to measure the effects. We want to repeat the same assessments that we did at baseline to assess whether the intervention worked or not, identify if possible areas for improvement, and see how we can achieve these long-term benefits. In terms of the content of the programs, as I said, is very diverse. It includes behavioral changing techniques, self-management tools, respiratory physiotherapy, so the mucus secretion is here, inspiratory muscle training, smoking cessation, relaxation, nutritional support, education, but most importantly, exercise training. Exercise training is actually the cornerstone of pulmonary rehabilitation in its two modalities that needs to be combined, strength training and endurance training. So that's the cardiovascular training. I'm sharing with you this paper. You can find here the reference. This was a consensus guideline on how to implement and adjust the exercise training during pulmonary rehabilitation program. And this is an expert-based statement, as I said, with experts from all over the world, so really people from very different settings. In terms of strength training, the sessions should be from 2 to 3 days per week if the patient is stable, and up to 5 to 7 if the patient is admitted at hospital. The equipment can be diverse depending on what you have more available, but it can be from more sophisticated machines to using only patient's weight. We can work different muscle groups, but at least the knee extensors are crucial for walking. The exercises are usually in sets of 3, groups of 3 sets of 8 to 15 repetitions per exercise, aiming at its exercise for momentary muscular failure. Then, depending on how the patient responds, we can adapt. Let's say if the patient doesn't feel well, cannot continue with this exercise, we can either decrease the load or decrease the number of repetitions. If the patient is doing well and improving, we can increase the load to achieve the training effect or increase the number of repetitions. And similar way for cardiovascular training. Depending on the characteristics of the patient and also their preferences or their tolerance to discomfort, we can go for continuous training in a treadmill or in a bicycle, or for interval training. The frequency would be the same that for strength training, and the duration is also the same, if continuous and intervals from 10 to 20 minutes, with the difference that in the continuous training they are exercising all the time at an intensity of 4 to 6 in Borg scale, Dyspnea-Borg scale, and in the interval training they exercise during sets, shorter sets, let's say 30 seconds exercise, 30 seconds rest, and so on, during the duration of the session, and at a higher intensity, much higher intensity, 80 to 100% of the peak rate. Then again, we can adapt this depending on how the patient is tolerating in terms of dyspnea or peripheral muscle failure, or also depending on saturation. And I encourage you to check these guidelines because they are really very useful. After the interventions, they are generally effective in that patients have benefits because they are multi-component. The work on the skeletal muscles brings an increase in skeletal muscle strength. The intervention reduces also fatigability and the symptoms of fatigue, and patient capacity to engage in activities of daily level is increasing. There is a desensitization to dyspnea, so not only the patient has less dyspnea, but also they have less fear of dyspnea-related exercise. And because all the changes in muscles and movement efficiency, the patients have less dynamic hyperinflation. So at the end, the patient feels that they have less dyspnea, better quality of life, better exercise capacity, and also less risk of hospital admission due to exacerbations of their chronic disease. Despite all these benefits, the rehabilitation in its traditional way, let's say in its traditional delivery mode, so center-based, it's underused and under-resourced. It has been estimated that less than 5% of COPD patients actually receive this treatment. And it's not known whether this happens for other chronic respiratory diseases. Some of the barriers to this intervention are poor referral. The doctors are not aware of the programs that are around their area, or there is an inadequate number of programs, or the resources are not sufficient in terms of staff, equipment, or space, or there is no funding. Sometimes the payer do not know the benefits of it and therefore they do not fund it. Sometimes the patients live abroad, they live far from the setting, and in all of this there is obviously socioeconomic inequalities. And this is actually in contrast with the fact that rehabilitation is among the most cost-effective interventions in chronic respiratory diseases, only on top of flu vaccination and anti-smoking policies, and much more cost-effective than the treatments, the drug treatments that we usually use. So we need to find, let's say, novel ways of delivering this intervention to the patients that need it. One way is using, let's say, telerehabilitation or other ways that do not require the patient attending to the center several times per week. So if, for example, the patient does not have internet access, we can start with a face-to-face session, following by patient at home during their exercises, and then supervision by phone or in person, but with a lower frequency or not supervision at all. If the patient has internet access, then we can use telerehabilitation, which can be administered using website or apps, or directly using video conference, and then again there can be supervision or not, it can be in person or virtual. It's important to notice that these ways of delivering rehabilitation result in better adherence. So the telerehabilitation has more than 90% completion compared to 70% in center care based rehabilitation. They have no safety concerns as compared to the traditional rehab, but we still have limited evidence, and this is what the next speaker will be talking about. Finally, I wanted to talk about long-term effects. I said at the beginning that the rehabilitation includes education and behavioral change, and one of the aims is to promote long-lasting changes in health behavior. And this is not achieved with exercise training. This requires a completely different set of abilities. So we would need to use behavioral changing strategies. They generally come from people trained in this area, mostly psychologists. We need to test, let's say, patient states of change and their motivation, intrinsic, extrinsic, their self-efficacy at the short and mid and long term. And with all this knowledge that we often do not have, but in multidisciplinary teams we can get, then is when we can really achieve a change in their behavior that is not only immediate after the rehab, but also at the long term. So to finalize, these are my take-home messages. First, that pulmonary rehabilitation is strongly recommended for patients with chronic respiratory diseases because it is extremely beneficial and cost-effective. The components are multiple, and the delivery method can vary, but they should be based on a comprehensive assessment of the patient at baseline. The training also should be tailored to patient specific limitations and also to their preferences. Clinicians should have knowledge on what are the programs available in their geographical area. We need to be aware that the access is suboptimal, and this happens worldwide. And to achieve proper delivery of all the components needed for each patient requires considering local resources, health system organization, and also the individual patient needs. Thank you.
Thank you very much, Judith, for this comprehensive overview of pulmonary rehabilitation. What should it be like? And I would now like to call Professor Hilary Pinnock to stage. Hilary Pinnock is coming from the GP side of the respiratory care, and she's based in Edinburgh, and she's our current Education Council Chair. Hilary, you will tell us more about how to implement rehabilitation in the local setting.
Thanks very much. It's wonderful to be here, and I'm looking forward to telling you a bit about some of the work that we've been doing, and very much the work that's been coming from India in this part of the world. Okay, these are my conflicts of interest, none of which have any relevance to this talk, apart from the fact that I have a lot of research grants and I'm very interested in this area. So what I want to do is talk about improving access to pulmonary rehabilitation, but actually very much around how we implement pulmonary rehabilitation in our own settings with the diversity of geography and social context that we have. And I also want to touch on how we can generate some high quality evidence on how to achieve this. So I'm picking up from all that Judith has said. The evidence for pulmonary rehabilitation is really very substantial, particularly in COPD. These comments come from the recent Cochrane reviews, but also increasingly in other chronic respiratory diseases. And recently we've seen some work in post-TB, which is beginning to show similar evidence. But, and this is the first of the caveats, the evidence in these reviews is almost all from high-income settings and typically in specific diseases, most commonly COPD. So that raises questions for all of us about how we can apply what we read in this evidence, what we hear from this evidence. It's a complex intervention. How does that apply in my clinical practice? How can I make this work in my setting? And that's what I want to address. So what is the evidence from lower middle income settings, from low resource settings? This is a systematic review that one of my ex-PhD students did. He's based in Bangladesh, and he was interested in exactly this question. He found 13 studies in his systematic review. Now, these studies were very diverse. There was no way that they were going to be able to be included in a meta-analysis. So this that you see here is called a harvest plot. What you've got here are 3 different outcomes. The first one is functional exercise capacity, the second row is quality of life, and the third one is breathlessness. And if each of those lines in each of those segments are representing one study. So each bar is one study. And what you can see here is really important where they're placed. So all the studies that are in that green box, they were positive. They showed a benefit. If they were in the yellow box in the middle, they were neutral, there was no impact. And I'm delighted to point out that there were none that showed any sense of detriment. But there is a caveat. This is the second big caveat. Almost all these studies were at high risk of bias. If you look at the little red dots on top of the lines, they're the studies at high risk of bias. There are 2 at moderate risk of bias, and one of them was positive and one of them showed no effect. Many of them were actually quite small pilot studies, which again would have added to the difficulty of achieving an effect. So Mansour's conclusion was that the evidence from low resource settings is encouraging, but almost all the studies are at high risk of bias, and they were almost all in COPD. So he also looked at the type of interventions that were included in the pulmonary rehabilitation, and Judith has highlighted the importance of endurance training and resistance training, but also education. Endurance training was in all of them, but resistance training only in just over half. Education was in a good number of them, 10 of them, but some things were missing. If you just look down that list, there are several things there that you might have wanted to see. The one that I spotted was smoking cessation advice, which was actually only present explicitly in 2 of the studies, which seems inappropriate given the importance of smoking, though I appreciate that in different contexts there may well be other causes that are important. This is another study that published very, very recently that looked at the delivery of pulmonary rehabilitation in Asia. 137 studies. It was a scoping review. It did not include, it wasn't just for randomized trials, so there were qualitative studies in here, observational studies in here. What they were interested in, what was the components that were being delivered. And this graph illustrates it across a number of different countries, but the point they were making was that only 22% included all 3 of those key components: the endurance test, the endurance exercise training, the resistance training, and education. Now, more of them included one or other, but only 22% included all 3. And this was, suggested that there was a lack of fidelity to the guidelines that we're given. But more positively, nearly 80% included a cultural or local adaptation. Here are 2 examples that were given. So adaptation was common to the local culture, which seems entirely appropriate. But it does raise this interesting issue, interesting to me because my interest is implementation research, interesting because there is this balance between fidelity to what we know works and what we need to include, but also the need to adapt to the local context. And the way that maybe we should see that is that you start by defining what it is that's really important, the 3 components that Judith mentioned, and you expect that all those 3 will be included. But then you want to encourage, not just allow, encourage local adaptation as to how those components are delivered. So what are the barriers? Well, this is a list of them. They're pretty universal actually, but I have taken them here from papers that were published from this part of the world. Many of them are for India, Bangladesh, Malaysia. So you probably recognize some of the challenges. You likely have a different profile of disease than perhaps we would see in the UK, and indeed that is seen in many of the studies that are published. And they may be poorly differentiated if a patient can't afford the investigations or has poor access to them. Poor awareness of respiratory disease seems to be a problem that's widely cited, and limited health literacy doesn't make that easier to overcome. Maybe unaffordable. There's a cost to pulmonary rehabilitation. Is it going to be an affordable intervention for people? And there may be few local services to add to the problem of geography and transport. What about referral pathways? Patients have to be referred to these services, and if the pulmonologists may know about the service, but do the other physicians know about the service? Do the primary care physicians know about the service? Do any of the the frontline workers, the community health workers know about the service? So referral pathways need to be clear. And there may be insufficient pulmonary rehabilitation trained staff. There may be enough in a tertiary care hospital or in a main hospital within a city like Kochi, but it may not be possible in more remote areas. And one of the other problems that we've seen, and Judith alluded to this, is the confusion with chest physiotherapy. As pulmonologists, everybody in this audience will distinguish between chest physiotherapy and drainage and pulmonary rehabilitation, but that might not be true of all our colleagues, and it certainly isn't likely to be true of managers who may think they're providing a service when they're not yet. and locally appropriate evidence may also be a key important. So how do we overcome these misconceptions? I'm suffering with breathlessness, not a disease, says this patient. This is qualitative work that we did. I haven't got a disease like blood pressure or diabetes. I've just got a cough. Part of the problem here was that they had not got a word in their dialect for COPD, which is what they had, so they couldn't describe it. And why does that matter? Because we know that people with diabetes are asked to walk and do exercise, but I haven't got a disease. And I've only got breathlessness, and you're wanting me to do some exercise that makes me breathless? The common sense logic isn't encouraging. How do we overcome that? These are some pictures from my colleagues at CMC Vellore in the rural Rusa campus, where they've been doing some work about innovative ways to raise awareness within the community. But it's not only within the community, it is also within our professional colleagues. We need to think about the stakeholders who need to be aware of respiratory disease. We need to think about our clinical colleagues. We need to think about the frontline workers. This is a meeting of ASHA workers at King Edward Memorial Hospital near Pune, where the ASHA workers were involved in delivering some of the awareness messages. We need to overcome barriers, and I'm not going to labour the point. It's really obvious, the challenge if you have to spend all day getting to a pulmonary rehabilitation session, unlikely to continue to do it. Home delivery, of course, may well improve that, and there's been a lot of work on this. This is the work that we did, where it was home delivery within the home, not in a local centre, but within a home. And these forest plots, I'll just talk you through them. This is exercise endurance tests, and it was quite clear this is comparing home-based pulmonary rehabilitation with usual care, and home-based was definitely more effective, and similarly for quality of life. So our conclusion was that home-based PR still clinically and statistically significant benefits. If you compare home-based with centre-based, there was no statistical difference between the two groups. Telerehabilitation is more specific in that it actually involves using some form of digital technology. This is a Cochrane review published not so long ago, which suggests again that telerehabilitation is a useful medium. And there were different ways of doing this. You could have a central hub, and then you could communicate with a peripheral hub, so the patients were still coming together in perhaps a small group with somebody to oversee them and supervise them, or you could do this directly communicating with the patient. And you have to obviously consider the local infrastructure and the IT availability and which patients are likely to prefer. Because there are challenges. This is another quote from some of the work that we've done in this area, or my colleagues have done in this area. The intention was to use a smartphone and to communicate with some sort of tele-rehabilitation, but that proved to be impossible with the internet signal, and it was back to the old telephone. And of course there are issues. People may have, each family household may have a smartphone, but the person who's actually got it with them is likely to be the young male wage earner, not the senior person who needs the pulmonary rehabilitation. So we need to tailor the pulmonary rehabilitation to available resources, the equipment that we've got, and if we haven't got all the equipment, we can improvise. The important thing is that we get the core component, the amount of exercise that's required. It's important that that's delivered, but how we deliver it, we can use what resources that we have, and that could be as simple as stepping up and down, and we can improvise the weights needed. The distance for shuttle walking tests can be quite a challenge. You may or may not have that distance, but there may also be a balcony or an outside area that can be used for these types of tests. So finally, I wanted just to talk a bit about the importance of determining locally applicable evidence and a trial that is actually going to be happening here in India. We've got 4 partners, 2 in India, in Pune and Vellore, colleagues in Bangladesh and colleagues in Malaysia. And this is a large randomized controlled trial where we're going to evaluate pulmonary rehabilitation delivered in low resource settings, adapted for low resource settings for people with chronic respiratory disease, whatever disease they've got. We have 3 arms, a centre-based arm, a home-based pulmonary rehabilitation arm, and a usual care group. And we are evaluating that as one usually would with pulmonary rehabilitation, with an endurance shuttle walking test, a quality of life. And of course, we're looking at the health economics, really important. We don't implement anything if we don't understand how much it's going to cost. So we've got a health economic evaluation, a really extensive process evaluation to understand how the process works, and a program of stakeholder engagement. So thank you for listening. I'd love to have some discussion to hear how this seems to you, because until we understand how we're going to implement pulmonary rehabilitation, we won't be able to roll it out for the benefit of everybody with chronic respiratory disease. Thank you.
So we had 2 fabulous such talks on the rehab. So to further discuss the pulmonary rehabilitation digital intervention in Indian context, I call upon Dr. DJ Christopher, sir, onto the... And I also call upon Dr. PK Thomas and Dr. Shyam Krishnan.
Right, so we have a really low-tech intervention. You would have thought that this would just spread through the country like wildfire, but PR is used very little in India. So let's hope as this panel and the discussion that we are going to have, we may be able to unravel some of the difficulties that the population may have in accessing, and see if we can come up with some solutions. To start with, we'll have the first question. You know, in COPD, who are the patients that undergo rehab? Most of us know that it is the patients who are symptomatic. So it is the patients that come in the group B and group E. These are the ones that would be referred for rehabilitation. Now, when it comes to interstitial lung disease, there's a lot of interest in having patients with interstitial lung disease who come and see the physicians often to have them undergo rehab. Now, how do we select patients for rehab? I'll ask Judith to do this. Can you tell us, some kind of a selection process for patients with interstitial disease?
Thank you. So I'm going to be a bit provocative. So regardless of the disease, we are treating the problem, right? And the problem is exercise limitation, is symptoms, intolerance to exercise because of these symptoms. So to some extent, it doesn't matter if the patient has COPD or ILD. You need, so for a patient to be responding to rehabilitation, you need the patient motivated, feeling self-efficacious of doing it, having a proper environment, having a proper treatment, and then adapting the treatment to the needs of this patient. And regardless of COPD, ILD, asthma, bronchiectasis, whatever, in some patient you will need to focus on muscular strength, in another patient you will need to focus on dyspnea, and in another one maybe in smoking cessation, right? So I would say the best responder is the patient that is motivated to do it.
Okay. I think that's a good response. It's not been you've not given us a solution, but you've given us the direction to go. I think we'll move on with that to the next question. So you've already explained the rehab schedule, the standard schedule. You said 1 to 3 episodes per week, spread over anywhere between 7 to maybe 12 weeks, right? So now, what is the shortest duration? Again to you, Judith, what's the shortest duration that has been shown to be reasonably effective? And what is an extended duration which may augment the benefit, but obviously at some point it will plateau? Can you explain that to us?
I would say that at minimum 12 weeks, but not all the health services cover this. So even one session is better than nothing, and the more the best. Then in terms of how long, in an ideal situation, the patient should be doing supervised exercise training until he's able to continue doing it by himself, herself, or with a family or in the community. So this is what we all would aim, not to have extended periods, super expensive, with complex equipment. We would like, as Hilary said, that the patients continue doing it at home, because actually both for endurance training and for muscle training, you only need your shoes, a table, a chair, and a wall, and you can do absolutely everything on your own, with your own weight, right? So I think it's not needed to stick to minimum number of sessions, maximum number of sessions. It's better to understand what are the needs of each patient, what this patient needs to do to feel better and to feel able to continue doing it on himself, right? And then let's leave the patient the trust to do it.
Okay. So I'll ask Hilary to take the next one. So beyond complete rehab, that is beyond completing a rehab program, people talk about an extended kind of a program to keep patients on the groove. So can you explain that to us?
Well, whenever we try to change our behaviour, there's always a bit of a slippage. I mean, we've all done it, haven't we? Think we'll take up some exercise and we do it for a few weeks. Some of us probably only do it for a few days, and then we stop. So there is an attrition, there is a fall off, and that's where, of course, this idea has come from. Should we top this up? I mean, if we had all the resources in the world and the patients wanted to do that, I'm sure that would be great. But of course, there's a practicality here. It's not feasible for health services anywhere in the world to keep topping things up, and it's not feasible for patients who have to really invest in this. They need to take this on for themselves. I've not seen any really good evidence of extended programs that are really beneficial and practical for being implemented.
Right. So there was a study that looked at, I think it was monthly. They kind of engaged with the people, and I think they went on to 3 years. And they found, I think, that up to 2 years there was sustained benefit, which didn't really sustain beyond that.
Yeah, exactly. There is a limit, and there's a practical limit. How many health services can afford to do that? How many patients are going to go on attending sessions? So there has to be a practical approach to this. Can I just come back and endorse the point that Judith made about, you know, you're talking about selection of patients. We will have the evidence from the PURE trial, because we are recruiting patients with chronic respiratory disease, even if they haven't had all the investigations we know that we could do. We are going to be recruiting them with chronic respiratory disease without any further selection. They just have to have chronic respiratory disease and not another cause for their breathlessness, and they have to be willing to take part in the trial. So we will be able to give some evidence to support the point that you were making.
Yeah. So you raise an important issue. If they have concomitant cardiovascular problems, challenges, limitation, would they still fit within a regular pulmonary rehab, or would they have to go to a cardiopulmonary rehab?
Exactly. The two are often combined in many settings. So yes, from the point of view of our trial, we are saying people with stable cardiovascular problems are able to come to the pulmonary rehabilitation. But obviously if they're in uncontrolled atrial fibrillation or they've just had angina problems or whatever, then clearly that's not going to be appropriate at that stage in their time, in their life, until they're stabilized.
Right. Thank you. Now,
I would, I'll just add a point over here. So they've mentioned that so most chronic respiratory conditions, they would benefit. IPF is one condition where the sustained benefit is not seen beyond 6 to 12 months. But irrespective of that, there's a conditional recommendation that you still go ahead and give them benefits of rehab. It's in the patients with the pulmonary hypertension group where they found that the recommendation is pretty low there, because the undesired effects seem to creep in more often when they tend to do rehab. So that's on the latest ATS.
I have seen that evidence, but the practicality here is how many of the patients with pulmonary hypertension are actually diagnosed.
Right. Thank you, Shyam. So now we'll move on to tele-rehabilitation. Right. So, people now have internet facilities. I mean, a vast majority of Indian households have internet. So it appears to be an attractive concept. So I will first ask Dr. Prasanna to weigh in, and then we'll look at what the Western model has been, how successful they have been in using it.
Thank you. COVID, I think, has really changed the way we live. The way we live, the way we think, the way we act. I think everything has been revolutionized by COVID. And I think the whole question of tele-rehab, I think it started with the COVID. And I think we should ride this wave of this COVID awareness to try and see if we can transfer this to pulmonary rehab. 10 years ago, we said pulmonary rehab, go for a walk in the park. But the question is, are you fit for a walk in the park? That's the question. And that's the question that I think I will answer. And as far as tele-rehab is concerned, you can have single rehabilitation with a single person over the net. You can have multiple sources where one person talks to multiple people in a platform. You could have multiple resources available, like pulse oximeters, like BP apparatus, like all sorts of doing a 6-minute walk test and supervising exercises, upper limb exercises and things like that, as she very rightly said. You could have all these things that are built into spirometry. But in all these things, I think what you need is consistency over a period of time. And I think that's really what is important. That's the one that we need to transmit to our patients and get our patients to understand that consistency is the key. Unless you are being consistent with what you're doing and you're continuing to do what you want to do and what you have to do, you're never going to succeed. Whatever it is, I think it's a question of everything starts up here. And I think once you get that going, the other things will follow. There's no doubt about it.
Yeah, so technology has been in our favor. That's
exactly,
what you're saying.
Exactly.
Okay.
So,
Shyam, you wanted to say something?
I just wanted to say, so there was this interesting study done, I think so in Pune, where post-CABG patients were surveyed and they wanted to see what behavioral changes or changes in their eating habits were there post-CABG. And they found that only 1 in 10 actually changed their eating habits. So it actually proves that we Indians are an incorrigible group where behavioral changes, it's tough, but then not impossible because, so that's where this whole realm of digital therapeutics come into play. We'll go ahead, I'm sure there are more questions.
Yeah. So coming back to Judith and to Hillary, so how has out-of-center and home-based rehab been, and how has this technology of connectivity, how has that helped and how has that changed things?
Well, there have been several, let's say, developments, so intervention, this idea of telerehabilitation, delivering via website, via app, there have been in the last decade many papers published, right? I would say, in general, if the project is well designed, it works. As Hilary said, it works, and we all have seen it working if it's well designed. So I think something that we should not forget is that the components, or we need to make it the virtual relation as close as possible to the face-to-face, right? Because sometimes there is this interpersonal, it's difficult to substitute. So, and this incorporating, again, knowledge coming from psychology can help a lot in getting this. But having said that, I also would like to point that telerehabilitation, again, needs to be adapted to the local context and the culture. So I can say, for example, we designed a telerehabilitation program. We implemented it in several countries. In Belgium, that's Northern Europe, very humid, raining all the time and cold, it worked very well. In our patients in Barcelona, Mediterranean area, it didn't work at all. They didn't like it, right? Because culturally, we do something different. So this issue that Hilary mentioned of cultural adaptation is key, also for telerehabilitation.
Yeah. So what you're saying is that that it works in certain cultures, it depends on the people.
No. It works. I think it can work everywhere if you design all the components adapted to this.
To the culture.
To this culture.
Right.
To the culture and to the individual. So what works for one individual will not work for another. Some people value the group work of a centre-based, or the model of telerehabilitation where there are small groups and a central unit. So some people value that, others are more happy to be by themselves and do the exercise in their own home. So it comes down to individuals. Yes, cultural factors will be part of it, but it's got to be tailored and adapted. As long as we get the components in there, it's a question of tailoring and adapting it.
So I'm going to ask the last question. Now, everything today is app-based, right? So people have their phones, they have their apps. So surely somebody has exploited this technology and has done app-based. So can you quickly summarize what you know of that and what the scope of that is for use in the future?
Yeah, and there are apps out there, exactly that, to encourage exercise. But again, it comes to the individual. Some people will love what's on an app and will work with that, and that'll be all they need. Most people need some encouragement from a human being, and there is a need there to ensure that that is also. Some people will want the encouragement and then perhaps use the app as part of it, a sort of hybrid approach. It's a question of what's right for people. Most people download apps and use them for 24 hours or less. So most people need some motivation and support to make it work.
Yeah. Well, thank you very much. You've been a fascinating panel and you've brought some very useful insights. Thank you very much. Let's give them a round of applause. Thank you.
We will move on to the next session. So this is going to be an interesting session on prevention and early diagnosis in pulmonary diseases. So I would invite the chairpersons, Professor Usmani, Dr. Akhilesh, and Dr. Subin. Dr. Akhilesh is a professor of Amrita Institute of Medical College in Pulmonary Medicine. Dr. Subin is a senior consultant at Renai Medicity. So over to you, Chairs.
So super. I'm delighted to chair session 5. Session 5 is prevention and early diagnosis in pulmonary diseases and follows really nicely from what we've heard in the previous session. Delighted to meet my co-chairs, Dr. Akhilesh and Dr. Sabir. So let's crack on without further ado, and I'm going to ask Dr. Judith, to come to the stage, and Dr. Judith is going to give us a presentation on emerging risk factors in airways disease.
Well, thank you. Good afternoon again. I'm going to change the topic and I will talk about new risk factors for chronic respiratory diseases. I still have no conflict of interest. I have focused the presentation on chronic respiratory diseases, leaving aside the acute and infectious ones, because these are really the most important. They are the ones with disproportionate burden. They represent the third leading cause of mortality worldwide, and the highest age-standardized mortality rate actually happens here in South Asia and in some countries of Oceania. I will talk about some risk factors that are well known, let's say old risk factors, but in the last years have taken new forms and we have learned new data about them. And then some risk factors that are new, that have emerged in the literature in the recent years. There will be 3 here, and for each of the 6, I will highlight 2 key messages. So first, starting by risk factor number 1, tobacco. In the last years, in the last decades actually, we have done an immense progress in tobacco control. However, it is still highly prevalent, and 80% of all tobacco users live in low and middle income countries. One of the important messages of tobacco is that recently it has adopted many different ways of presentation. And some people do not even recognize that this is actually smoking. They would only consider this is smoking tobacco. The uptake of these new modalities has been fast and high. And for example, nowadays in the US, 27% of adolescents and young adults use e-cigarettes regularly. In Asia, this number is smaller. It ranges from 1 to 12%, depending on the country, but is on the rise. So that's something to be aware of. E-cigarettes are increasing, and who knows if they will be like tobacco was in the past. Then, e-cigarettes have also been related to increased risk of asthma and COPD, and that's what you can see in these 2 meta-analyses. The consumption of e-cigarettes increased consistently asthma risk and also COPD risk. So there are new forms, they are not recognized, and they all relate to disease. The second message about tobacco is about initiation age. This data comes from a European study, but similar data has been observed in a study in Oceanian countries. It shows how initiation rates have changed over time in males and females. In the red line, you can see that the age group from 16 to 20 are the ones that have higher initiation rates, and that makes sense. This is what we all see. And the initiation rate so the number of people that engage in smoking per inhabitant has been decreasing in the last years. It has also been decreasing for the group 21 to 35 years. But this is the bad news. The initiation rate has been growing since the 90s in the group of 11 to 16 years, both in male and female. So we may have the impression that there are less smokers, and this is true, but there are more people who start smoking at younger ages. The second old risk factor, and this is a big one, and you in India know a lot about it, is air pollution. Air pollution can come both from indoor and outdoor exposures. It's present everywhere in high, middle, and low-income countries. And the point is that everybody is exposed to it, like it or not. If you go out to the street, you breathe that air. That's it. It does not depend on your behavior. One of the last developments in air pollution research has been this finding, and this is data from a collaborative study involving many countries from around the world, where they found that there is no safe threshold. This figure shows mortality according to CO concentration, and it shows clearly that there is no level below which there is no increased risk of mortality. And this happens also for asthma, for COPD, and so on. And I know that these values may be low in comparison to some of the values you face in India, but still the message is the same. There is no safe level. Air pollution should be decreased, and once decreased, decreased more. There is no safe level. The second highlight about air pollution is that there is a lot of inequality in the world, in the levels and in the impact it has on health. Most of the burden falls on low and middle income countries. This figure shows the concentration of PM2.5 in 2000, 2010, and 2019. And here shows the changes in PM2.5. In blue, countries that have decreased the levels, and in red, countries that have increased. So not only the levels are different depending on the area, but also the changes are different. And you particularly in India have been facing, and you know this better than me, that the levels are still increasing. The third of the old known risk factors are the occupational ones. These are important because they represent the third cause globally of chronic respiratory diseases, and the second cause of these diseases in Asia and Latin America. And the important message here is that they are preventable. No single occupational disease should exist, actually. We could eliminate the sources or substitute them, or at least use preventive measures. In the last years, with new technologies, new chemicals, we have faced new exposures that affect respiratory health. This review by an Indian colleague actually summarizes the evidence about these new occupational exposures. They are both silica-based or non-silica-based, and both chemicals and dusts. And they range from, let's say, sandblasting, that depends on what we wear, right? The clothes, artificial stone, this is very much used in some parts of the World Trade Center dust, some new chemicals for hairdressing, the fracking, the extraction of gas. So these all have been related to increased respiratory diseases. And this table just shows some data for ex-workers of sandblasting. The presence of symptoms was as high as more than 80%. And these are ex-workers. This data comes from Turkey. And the most important symptoms were dyspnea and chest pain. Now moving to the novel risk factors, the first one I will talk is temperature. Climate change is actually increasing the occurrence of extreme temperature events, both cold and heat. And the years with the highest temperatures of all the recordings we have in the Earth have been the last 10 years. So this is really becoming a problem. One of the key messages here is that temperature is bad for respiratory diseases, both if it's too cold and if it's too hot. This data comes from South Korea, the emergency department, and it shows for different respiratory diseases and for all of them overall that with low temperatures and with high temperatures, there is an increased risk of admissions to emergency. And this is for all causes, but also for COPD, for, I can't read this. I'm sorry, I cannot read it from here. Anyway, for several of the diseases, of the respiratory diseases, it's both cold and hot weather. The second message is that temperature acts in synergy with air pollution. This table, coming from the same study, that multi-country study that I mentioned before, shows that the increase in mortality that we see related with temperature is higher if it coexists with higher air pollution levels. And this happens for different pollutants. That's actually worrying for areas like India and other parts of the world where there is air pollution and frequently heat time, also in Barcelona, where I come from. The second of the novel risk factors is obesity. And that's important because obesity has increased everywhere. Since 1990, it has doubled the prevalence of obesity in adults, and it has quadrupled in adolescents. And in the past, it was only a problem of high-income countries, but it has actually become a problem of all parts of the world. Obesity has been related to lung function growth and decline. This figure shows, and this comes from a British study, that higher levels of obesity measured by fat mass related to lower growth of FEV1 in boys. And this one, focused on adults, showed that in comparison with, or using as reference group, people with no weight change since 20 to 70 years, those who increased weight, and this is the yellow line, had accelerated lung function decline, and those who decreased weight, this is the red line, had an attenuation of lung function decline. The second message about obesity is that it's very important to distinguish between fat and muscle mass. This data from the British study I mentioned before shows that if you use only body mass index, you would say that high body mass index relates to better or higher FEV1 levels and growth, both in boys and in girls. But when you actually split this in fat and muscle mass, fat mass relates to decreased lung function growth and muscle mass to increased lung function growth. And the point is that no matter the weight of a person, you do not know if this weight is due to fat or muscle, and they have opposite effects on the lung. So it's very important that we understand this. Finally, physical inactivity is another risk factor that has appeared in the last years, and again it's important because of its high prevalence around the world. It has been estimated that 1/3 of the adults are physically inactive, and again there are important geographical variations. Physical activity levels have been related to the risk of lung function to the level of lung function decline and the risk of COPD development. And this figure shows that among current smokers, those who engaged in moderate or high physical activity levels had around 30% reduced risk of developing COPD during a follow-up of 10 years. Also, among children, physical activity has been related to lung function growth and also to the catch-up in lung function. This data, coming from the British study I mentioned before, shows that girls with moderate or high levels of physical activity had higher lung function growth during childhood and adolescence. And these results, coming from a Spanish study, we identified there were 4 trajectories of lung function: low, normal, high, parallel trajectories, and the catch-up group, so those who start low lung function and end at normal lung function levels. And physical activity was strongly related to being in the normal and in the high in relation to the low lung function, but most importantly, it was the physical activity that helped the children who were in the low trajectory at 4 years to be at the normal trajectory when they were adolescents. So the take-home messages are, first, that chronic respiratory diseases represent an important burden in terms of deaths and disability worldwide, and therefore it's crucial to continue with all kinds of prevention measures. Efforts need to continue for tobacco control, air quality, and occupational exposures, but adapted to the new forms that are emerging, being aware of them, and to the regional disparities as well. And finally, that prevention strategies need to address the new risk factors. So we need, as health professionals, also to promote mitigation and adaptation strategies against climate change, and to put an important focus on obesity and physical inactivity. And actually promoting a healthy lifestyle will be positive for respiratory health during the whole life course. Thank you.
Fabulous, Dr. Judith, a tour de force on the old and new in emerging risk factors. It gives me great pleasure now to ask Dr. Monica to come to the stage to give her updates now with respect to prevention and on this session. Thank you. Early detection, of course.
Yes, thank you very much for bearing with us in the afternoon after already a very long day, but I think the topics we are discussing now are at least as important as the actual treatment. So my task is to talk about early detection in obstructive and restrictive lung diseases. Does this work? No? So I use this one. This works. I have no conflicts of interest with regard to this presentation, and this is how I have structured my talk. Just to come back a little bit to the epidemiology, chronic respiratory diseases have a very high prevalence of more than 450 million cases globally. Number 3 in mortality, as we've already heard, and both prevalence and mortality have risen by almost 1/3 over the last 3 decades. Asthma is highest in prevalence, and COPD is leading with regard to death of the chronic respiratory diseases. The risk factors I don't need to discuss again. Judith has just done that. For asthma, I think all of you know that this is as much a pediatric disease as it is an adult disease, and the children actually have a similar disease burden and are facing a much longer time with the disease than an adult. The prevalence in India is estimated to be 35 million, and the challenges, as you know better than I do, are underdiagnosis and inadequate treatment. And although all the treatments, medical treatments, are available, there is a huge gap in available access to healthcare facilities and affordability of the treatment. For COPD, in India, it's number 3 in mortality, as it is globally, and the prevalence is estimated at 105 million, 7% of the population. If we look globally, the cost of COPD is enormous. Compared to zero COPD, the cost is estimated at $4.3 trillion. That's an enormous amount of money. Now, so we have to answer the trillion-dollar question. How can we reduce not only the burden of disease for the individual, but also for our economies and for the society? And here comes early detection. If we detect a disease early, this might reduce the burden of disease and improve long-term outcome, because then we can start tailored treatment plans, which we've heard about today already, which will reduce inflammation, prevent airway remodeling if we start early enough, reduce progression of disease, reduce exacerbations, and therefore the use of healthcare facilities, and may prevent comorbidities. It will certainly lead to an improved quality of life for the individual, improved survival, and thereby reducing healthcare costs. However, does it work? There has been a recent high-ranking publication in the New England Journal of Medicine, which I will briefly summarize here. It's actually a case-finding study in Canada where they have telephoned more than 38,000 people and asked them in interviews for respiratory symptoms. If they reported respiratory symptoms, they were offered a spirometry. And through symptom detection and spirometry, they identified 595 cases of potential cases of COPD or asthma, and they assigned these subjects to intervention either through specialist care, which would include seeing a pulmonologist and receiving specific education on the diseases, or just referred them to their primary care physician. And irrespective of what the level of care was, they all benefited with regard to symptoms, less healthcare utilization, better quality of life, and better lung function, all of these outcomes being better if you saw a specialist rather than a primary care physician, but primary care worked as well. So yes, by early detection, we reduce the burden for the individual patient and can reduce the cost for society. However, this study doesn't tell us whether this would be applicable to other healthcare systems and whether it would also be applicable in lower resource settings. I know that there are protocols starting also in India, but I think we still have to see and wait for the results. As a pediatric pulmonologist, I would like to highlight a different perspective, that is life course of disease. We have started discussing early origins and actually COPD to be a pediatric disease years ago. And there's actually evidence from numerous long-term studies showing that lung function and lung disease, respiratory disease develops very early in life. And I just have put the figures here from the CAM study, which is a big North American asthma study, where you can see that 3/4 of the children with asthma will come to a low lung function as they reach early adulthood, which qualifies them for a diagnosis of COPD. And there are other studies showing the same. And this leads to the concept of the lung function trajectories, where you see growth of lung function. You might just use FEV1 from childhood. Here you've got the age through to adulthood and actually the early ages, reaching a peak in the early 20s and then with a physiological decline thereafter. And you can either be on an average percentile, you can have a higher than normal lung function, or you can have lower than average lung function. And this trajectory actually is set very early in childhood, in infancy, and in many instances even before birth in utero. So this is what we call lung function tracking from very early in life. Now, the question is this clinically relevant with regard to chronic respiratory diseases? And here I'm referring to one of the long-term population-based studies, the Tasmanian Health Study, which has followed up subjects over more than 6 decades. And they also identified these lung function trajectories and could show that the 3 low trajectories are associated with a diagnosis of COPD in later adult life. And the risk factors are those that Judith mentioned already. Is this also relevant with regard to mortality, one of the biggest issues in COPD? And yes, this is another population-based study that was performed in Sweden, and these colleagues have shown that there is increased not only morbidity but also mortality in those subjects with low trajectory, with or without rapid decline. Rapid decline means the curve is even bending earlier than with physiological aging. Oops. And one other thing that is important if we discuss the relevance of lung function and respiratory with regard to overall morbidity. These population-based studies have also shown that low lung function trajectory in childhood is associated with the risk of cardiovascular disease in adults. So by looking at lung function early in life, we are not only able to identify subjects with a risk for chronic respiratory disease, but also those with a risk for cardiovascular disease. So many reasons to go along this line. For you as clinicians, is this relevant for the individual patient? And here I have highlighted an example of an adult patient who has had longitudinal or repeat lung function over time. And what you can see is this patient is starting at an average lung function level, and then as repeat measurements are lined up here, you see that this person is crossing the percentiles or the trajectories downwards. After the second measurement, you might already consider there's something going on, but you can be quite sure after the third measurement and don't have to wait until this person reaches the lowest percentile and is clearly in the abnormal range. And similarly, in children, if you start doing lung function early, you might pick up children who have no symptoms but have a lung function that is at the lower end of the spectrum, clearly abnormal compared to population average. And then in this case, this person is lucky to catch up to normal lung function, but here you could already identify individuals at risk. You can do this yourself practically by going to the ERS website and look for the lung tracker. Why do I think it is important that we consider doing lung function testing early in life? Again, these are collated data from 2 big birth cohorts where they have shown that lung function trajectories remain stable in the majority of subjects. Here, the average, above average, and below average. However, you also see that there are groups, small groups of subjects who change the lung function trajectory. The best is if you change from low to normal or high lung function trajectory. But what this means is, at least for a percentage of patients, there is a chance that you can improve your low lung function to normal lung function if you prevent further damage or if you intervene to improve lung growth. And this brings me already to my conclusion. So I have shown you that early detection of respiratory disease is feasible. It can be traditionally either symptom-driven, or you can do pre-symptomatic lung function risk assessment, which I would like to call lung health checks. And this allows assessment of lung function trajectories from childhood, and thereby would give us the opportunity to address individual risks and implement preventive action. And with this, we can answer the $1 trillion question partially. Yes, early detection can help to reduce the burden of disease and reduce the cost of chronic respiratory diseases, but I asked this the next speaker, prevention might be even more helpful. Thank you very much for your attention.
Thank you so much, Dr. Monica, for that excellent presentation. The next speaker doesn't warrant an introduction in this part of the world because all of us has been looking up to his work for our clinical practice, and we had been reading about his work since our learning days. He's a member of Board of Directors in Gold and Scientific Committee of GINA. He's the face of India to the world when it comes to obstructive airway diseases and pulmonary medicine. I'm more than proud to introduce Dr. Sandeep Salvi to you, ladies and gentlemen. Over to you, sir.
Thank you so much for those kind words of introduction. Wish you all a very good afternoon. The lung is an extremely important organ that nourishes our body with oxygen. On a daily basis, the human body requires 1,000 liters of pure oxygen. Oxygen therefore becomes the most vital nutrient for the human body. It generates 90% of the body's energy, with only 10% coming from the food that we eat and the water that we drink. Apart from nourishing the body with oxygen, the lung also plays a very important role in getting rid of carbon dioxide, 300 liters of carbon dioxide on a daily basis. And these two become the most vital functions of the lung. And for that, we need to breathe about 10,000 liters of air on a daily basis, which gets spread over a surface area of around 75 to 100 square meters. It's a very large surface area where the gas exchange actually takes place. In order to perform this vital role, the lung has a very unique architectural design. It has the branching pattern of the airways, starting from trachea right up to the place where it reaches the alveoli. Somebody has even counted the number of airways in the human lung. There are 120,000 airways in the human lung and 600 million alveoli, which together take part in gas exchange. But because the lung comes in contact with such a large volume of air on a daily basis, which has the potential to carry along with it a large number of toxic substances and microbes, the lung has evolved a very important defense mechanism. And these defense mechanisms actually include the mucociliary clearance, extremely important, the cough reflex. Coughing is a very important act that protects the lung, immune surveillance across the entire respiratory tract, and then finally antioxidant defense, which together helps protect the lungs. So apart from breathing clean air, if any of these defense mechanisms go wrong, you will then develop some form of lung disease. Clean air is vital to keep our lungs healthy. Surprisingly, not many people even understand or know what is clean air. We know clean water is H2O, but what is clean air? It is important for us to at least start appreciating this. The World Health Organization has released a report recently that says that 92% of the global population live in areas with poor air quality. In India, it is 98% of the people who live with poor air quality. Only 2% of India's population live in areas where the air quality is according to the WHO standards. There are certain factors that we just cannot take care of, or we have no control over this, and climate change is one important aspect that is now becoming increasingly realized as an important risk factor for various lung diseases, be it the heat waves or the severe winter conditions or the floods or the droughts, hurricanes, thunderstorms, wildfires, dust storms. These are environmental catastrophic factors which have a significant impact on lung health. But air pollution, when we hear about it, we automatically think about ambient air pollution, the pollution that comes from motor vehicles, industries, and occupational exposures. But that is not the sole truth. In India, perhaps indoor air pollution is more vital than outdoor air pollution. 40% of homes in India use biomass fuel for cooking. And this poor lady who cooks food for the family on a daily basis inhales as much amount of polluted air that is equal to smoking 25 cigarettes. One mosquito coil is equal to 100 cigarettes. And one dhoop agarbatti, which is only 4 inches long, burns for only 20 minutes, produces as much amount of PM 2.5 pollution that is equivalent to smoking 500 cigarettes. So these become the major risk factors for poor lung health. And then you have the agarbattis and the Diwali firecrackers and various other sources that reside within our house. So India is a country that is very rich and fertile, both for outdoor air pollution as well as indoor air pollution. We have tried to overcome the harmful effects of air pollution by protecting ourselves by using these masks. And these are photographs of people who tried to protect themselves during the Philadelphia big smog, the London smog of 1952, the Singapore smog of 2015, and so on. So clearly wearing a mask can help protect the lung from exposure to all these outdoor air pollutants. A very interesting and important study conducted from the University of Chicago a few years ago during the COVID pandemic that looked at potential alternatives to the N95 mask and perhaps the surgical mask, which we know are all efficient in reducing the different types of air pollutants. So they looked at the efficacy of cotton masks, 1 layer, 2 layers. They looked at flannel, chiffon, natural silk, and so on. This is the efficacy tested for particles which are less than 300 nanometers in diameter. But what is interesting is, if you have a combination of a cotton and chiffon, the efficacy against particulate matter pollution of less than 300 microns is as high as 97%, which is as good, if not better, than the N95 mask. So 2 layers of cotton plus chiffon in the middle, or 2 layers of cotton with a flannel layer in the middle, are all very important means by which we can make these masks to protect ourselves from the harmful effects of air pollution. So wearing a mask is one way in which we can protect the health of our lungs. What about nutrition? This is perhaps one of the best studies ever done in India to look at the role of nutrition in preventing lung disease. This was a study that was conducted in Jharkhand state, where we know that it is a relatively poor state with a large number of people suffering from undernutrition. So the study that they did was, if we administer food to the members of a family who has got active pulmonary tuberculosis, will it reduce the risk of developing new tuberculosis, incident new tuberculosis among the family members? So the intervention was nutrition, simple nutrition of 52 grams of protein, 1200 kilocalories, and a micronutrient pill only for 6 months. What did they find? This was a randomized controlled trial. And they found that a simple intervention of nutrition can reduce the risk of developing incident pulmonary tuberculosis among family members by around 40%. This is amazing how nutrition itself can become such an important intervention to protect your lung health. Based on this study, there has been some mathematical analysis and modeling studies that have done to estimate what if we transfer this new information to all the people across India. Nutritional intervention has the potential to prevent 400,000 TB deaths and 850,000 disease episodes. So clearly nutrition becomes a very, very vital parameter to prevent developing lung diseases. And today there is a lot of emerging literature that talks about foods that have inflammatory basis and foods that have anti-inflammatory effects. And this is a meta-analysis of a very interesting study that looked at, if you consume food that has a high inflammatory index, does that increase your risk of developing COPD? And the answer is yes. And below this I've given you foods that have high inflammatory index. In contrast, if you consume food that has antioxidant benefit, so composite dietary antioxidant index, if it is high, it significantly reduces the risk of developing COPD. So food has the power and the potential to increase your risk or reduce your risk of developing chronic lung diseases like COPD. Antioxidants are a very important defense line that protect the lung from the harmful pollutants that we breathe. So this antioxidant defense comprises of vitamin C, glutathione, vitamin E, uric acid, and carbon monoxide. And we conducted a randomized controlled, placebo-controlled trial in bus drivers in Pune city a few years ago. On the y-axis is the exhaled carbon monoxide levels in parts per million, which is a very good marker for lung oxidative stress. We treated them with 3 different treatments, so placebo, N-acetylcysteine in a dose of 600 milligram once a day, N-acetylcysteine in a dose of 600 milligram twice a day for a period of 30 days, and then we stopped the treatment. And as you can see over here, giving supplements of N-acetylcysteine reduced the exhaled carbon monoxide levels significantly in the high dose of N-acetylcysteine, And despite stopping the treatment after 30 days, the effect lasted for an additional period of at least another 30 days. So clearly, an antioxidant like N-acetylcysteine has the potential to protect our lung health, and this was associated with an increase in forced vital capacity. Mind you, these were bus drivers who were relatively healthy and non-smokers. Apart from the N-acetylcysteine, there's a lot of talk about other antioxidants, especially the mitochondrial antioxidants that have the potential to protect our lung health. So exercise, diet, metformin are the new ones that have come. Pyrroloquinone quinine is perhaps rated as one of the best antioxidants for the lung health. But there is emerging evidence to suggest that melatonin is also a very important antioxidant for the mitochondria. Melatonin is not only released by the pineal gland, but it is also released by the mitochondria itself. And this melatonin has been shown over a period of time to be one of the best antioxidants. So sleep is important if you want to have good health, and a high level of melatonin will protect you. We sort of underplay the value of exercise, regular exercise, for lung health. We know the value of exercise for cardiac health, for the neurological health, and for the musculoskeletal health. But we don't talk about exercise as for lung health. Walking is perhaps one of the most efficient, most effective exercises that can keep our lungs healthy. Other forms of exercise that could be Tai Chi, yoga, diaphragmatic breathing, pursed lip breathing have also been shown to be very, very useful. But here is a very interesting meta-analysis of 15 international studies that was published a couple of years ago that looked at the number of steps that you can count on your smartphone and what impact does it have on all-cause mortality. So there are two lines over here. The orange one represents those that are less than 60 years, and the blue line represents those that are more than 60 years. So if you're more than 60 years, the minimum number of steps that you need to walk every day to have no risk of having any mortality is minimum 3,000, and for the less than 60 years, you need 5,000 steps. If you walk this much, then you are at zero risk. But if you walk more than that, that is going to significantly reduce your risk for all-cause mortality that also includes lung. Vaccination is a very important intervention that has been shown to protect the lung from various additional infections. So these are the vaccines that we have always talked about. One of my first PhD students from Iran looked at the risk factors associated with asthma in the Indian population. This was a study done in Pune. And what she found was something very fascinating. Family history contributed to 32% of the total population attributable risk for developing asthma, which we all know. Asthma is a genetic disease. But more importantly, 18% of the risk was attributed by cesarean delivery, 10% by mixed feeds, 10% by absence of separate kitchen, and so on. So these are all the potentially preventable factors, apart from family history, that we could think about to prevent the risk of developing asthma. A meta-analysis of 12 studies published a few years ago looked at the real story behind the cesarean delivery. The data is very heterogeneous, but by and large, whether it is elective cesarean section or whether it is emergency cesarean section, both of them have been shown to increase the odds of developing asthma in these children by about 41%. So wherever possible, if you can avoid cesarean delivery, you can help promote lung health. The trees take in carbon dioxide and give out oxygen, and the lungs take in oxygen and give out carbon dioxide. What a perfect example of made for each other. So trees and the lungs, they actually benefit each other. But these certain variety of trees have been shown to reduce the ambient air pollution. There's a lot of research in the last 10 years that have identified certain trees that reduce the levels of particulate matter pollution. Indoor air pollution can also be significantly enhanced by having some of these indoor plants. Most of the research has been conducted by NASA, and over the last 2 years, I've seen a flurry of publications of the therapeutic efficacy of these indoor plants in reducing indoor air pollution. So what are the carry-home messages that I would like you to take from my presentation? First and foremost, learn to breathe clean air. Vital. If you cannot breathe clean air, at least protect yourself by wearing a mask. eat healthy, nourishing food. We seem to have undervalued the importance of nutrition for lung health. It's extremely important. Perform regular exercise. We all know that pulmonary rehabilitation works in patients who have already a chronic lung disease, but we can protect this by performing regular physical exercise. Sleep well, melatonin is important. Perhaps some supplements like N-acetylcysteine or even pyrroloquinone quinine could be very useful supplements to protect our lung health. And finally, encouraging everybody to grow trees, both indoor as well as outdoor, so that you can improve the quality of air that you breathe. Thank you so much.
Thank you, sir, for very relevant topic. And now we will, after the topics on risk factors, early detection and prevention of pulmonary disease, now we will move to the panel discussion. I invite Dr. Mahesh P.A., Professor Respiratory Medicine, JS Hospital, Mysore, as a moderator. I also invite Professor Judith Garcia. Okay, Dr. Monica Gappa, and also invite Professor Asmita Mehta, Dr. K.S. Sadish, and also Dr. Salvi sir. Dr. K.S. Sadish is consultant pulmonologist, Chest and Maternity Center, Fortis Hospital, Bangalore, and Professor Asmita Mehta is Professor and Head, Department of Respiratory Medicine, AIIMS, Kochi. Over to Mahesh sir.
At the outset, I would like to thank the ICS and ERS for having me here. It's been a real privilege to be here and have a panel discussion. And I would like to thank Rajadhar and Sandeep in particular for this. So we'd like to, I think a lot of ideas and thoughts have already come from the three speakers already. And I would like to start with the senior-most faculty here, Dr. Satish, as to what in his opinion are the barriers to early diagnosis of pulmonary diseases in India.
Hi, Amesh. Good afternoon, everyone, fellow panelists. Excellent talks preceded this panel discussion. And there were many thoughts and many answers in those talks. Several barriers that one can identify, especially countries like India and in Southeast Asia. Social reasons, economic reasons, literacy levels, and gender, discrimination, and various things, and not being aware of respiratory problems. In fact, to take a leaf out of the talk or the slide out of the talk by Hillary, I was just going through and then I said, oh, my question can be answered by this barriers of PR, pulmonary rehab. And it states very clearly what are the barriers that we have. And the same thing can also be barriers here for respiratory diseases. For example, not being aware of this, not available consultation, no links, proper between GPs and others. And unlike other diseases, for example, oncology, I don't think anyone will touch oncology, but the respiratory diseases everyone wants to treat, including homeopaths, Ayurvedic physicians, so on and so forth. So a lot of things have to be done to create awareness, more than talking about the barriers, how we overcome these barriers. And being political or non-political, one of the things is NMC or, new rules which says that, take away the undergraduate subject. So I think I'm just saying that there are several barriers that, once we identify and we can rectify them, that's what I'm saying.
Thank you. Thank you, sir, very much for your answer. Now we'll come to Dr. Asmita. And do you think COPD sort of presents itself differently in younger women, such as those under the age of 40, and what can we do to improve screening and diagnosis in such a population?
COPD itself, to diagnose below 40 years in general is going to be difficult. And now if you are asking me about particular group of female or women, it is going to be almost next to impossible because as rightly pointed out by morning Professor Hillary, that female people or population coming to clinic itself is less. Now coming to the, so I don't think there is a special investigation which we can specifically address female population who are suffering less than 40 years. It should be in general, like Gold 23 has addressed that pre-COPD PRISM and the CT scan which has come in a picture rather than relying only on spirometry where the disease has already happened. We have to catch them early, and nicely shown by your diagram in which the PFT or FEV1 starts falling at the age of 30, 40, and then 50 is the age when we diagnose. So the same diagnostic techniques which we are using for man can be used for female. Is it underdiagnosed? Yes, it is underdiagnosed because of nobody suspects. And Sandeep Salvi sir showed that how 25 cigarettes per day of female, and sir's study on the global public health burden in Lancet, which came in which more than 46%, if I am not mistaken, of non-smoker COPD happens in female. So yes, there are many factors which we can address.
If I can add something to that, Mahesh. Sandeep. So developing new screening tools that incorporate simple questions, the use of a peak flow meter in either in the community or in the clinical practice, and more recently there is a lot of emphasis on developing a mono-frequency oscillometer. So not a full-fledged oscillometer, but a single frequency oscillometer that has the potential to screen people in the community to identify people who are at risk of having lung diseases. So I think that's the way to the future.
Yeah, please. But if I may just re-emphasize, I think the awareness that you've been speaking about, that's the main thing. And unless people are aware of risk factors and of risk factors associated with respiratory disease, and respiratory disease starts before symptoms, and symptoms of cough may represent respiratory disease, you will not be able to diagnose and treat.
So one more point I would like to add, which has come, the beautiful article COPD Commission in Lancet that said about dysynapsis and parametric CT. And I won't be surprised we might start using it more frequently than what we are using, because everywhere AI is coming. So I won't be surprised in COPD also AI comes in a picture.
Thank you. I would like to sort of request the Professor Garcia to look at with the increased emphasis on PRISM and early COPD, do you feel screening for COPD and hence starting treatment early can alter the natural course of COPD?
Yes, no doubt. So as my colleagues presented before, you can obviously alter the evolution of the disease. So basically, in the case of COPD, so the natural course is an age-related decline of lung function, right? And this can be more accelerated or less accelerated. And anything you can do to be it less accelerated, it's going to improve the prognosis. Being it non-smoking, use masks, do more exercise, eat more healthy, and many things even before any drug treatment is considered. So certainly the answer is yes.
Absolutely. I think a lot of data was already presented by both of you. And I would like to quickly go through the study that we have been doing. It's a welcome DBT study, and it's done in 4 centers with different PM 2.5, with the Mysore, where I stay as the clinist, and then Bangalore, and then Bombay, and then Delhi. The PM 2.5 range from 9 to 1,425. Now that's the range we have been dealing with. We screened about 5,450, and we had a reproducible pre and post bronchodilator spirometry for about 4,100 plus. We have collected their nails, hair, and blood as well. And we found that the worst lung functions was in Bombay. We expected to find in Delhi because Delhi has much more higher PM 2.5 than Bombay. But we found that the worst lung functions were actually in Bombay, wherein almost 66% of them had low lung functions. Overall in India, more than 50% of children, these were 11 to 14-year-old adolescents, we are going to follow them up for 3 years now, more than 50% of them actually had low lung functions. And one of the interesting things to see here was, as if you look at the physical activity, people with low lung functions had lower physical activity. People who took greater amount of dietary fiber had better lung functions. So all the points that you have already mentioned in the previous are picked up here. People with better BMI had better lung functions, but our BMI is not like the Western one. It is still less than 20. The better BMI is still less than 20. So this BMI is an entirely different BMI compared to the West. We found a biomarker, CC16, to be extremely well correlated to the baseline lung function. We have now about 2,500 children followed up, and CC16 levels correlate with how lung function improves as well. It's an absolutely fantastic sort of biomarker. And we also measured oxidative resilience. That is, you take the serum and you put in the molecules to relieve the oxidative stress molecules and see how well it is quenched. And this is measured by what we call as lag time. So children with smaller lag time had lower lung functions. And children whose lipid peroxidation was high actually had lower lung function. So almost all the points that have been mentioned are here. And we also found, of course, the low birth weight was a risk factor. And dietary fiber was protective. Incense sticks, though only about 3% of the population use incense sticks regularly, it was one of the worst risk factors. So I took it from Sandeep Salvi's work that we should actually ask for the incense sticks, and it actually showed up. I'd like to now request Professor Monica for her comments. So what are some of the novel biomarkers in the diagnosis of OADs we can expect to see in the routine practice a few years down the line, and anything you can suggest for developing countries like India to help in the early diagnosis?
Well, you have just mentioned some of the novel biomarkers that are available in the blood, but this takes resources and is an invasive procedure, so the question is what you want. These will become more readily available and will certainly become cheaper, so they might play a role as some gene markers may, but we will also have to stick with lung function and with markers of eosinophilic inflammation.
Yeah, anyone else would like to comment on that? Professor Usmani?
So we were just saying there may be some urinary surrogates that correlate with
It's off. I think mic is off.
We think, okay, so there may be some urinary correlates with BAL on CC16 derivatives actually, and also some work looking at nasoabsorption filters that may actually be very easy accessible, the nose, with respect to that. So there may be relatively non-invasive methods for children, but also for adults.
Yeah, thank you. Now, Sandeep, your pet topic, post-tuberculosis COPD is a relatively unexplored field, and what can healthcare practitioners do to prevent the progression of TB into COPD?
Yeah, this is an extremely important point from an Indian perspective. The realization that TB is followed by COPD in a significant majority of patients needs to be taken very seriously. Now, how can we prevent the presence of COPD amongst patients who are already diagnosed and treated with tuberculosis? There is no data available to tell us, to give us that information. But I can only speculate, and I would like to give some thoughts on that. Early diagnosis of TB, correct diagnosis of TB, perhaps I'm speculating now. Whilst you're on anti-TB treatment, if you give them antioxidant supplements, will that prevent the risk of developing COPD later on? I do not know, but it is a research question that is worth addressing. Nutrition, clean, healthy air, I think would also add value to the intervention of preventing the development of COPD. So exciting, this is exciting area, but a lot of research needs to be done to find answers for this. Do some of the anti-TB drugs increase the risk of developing post-TB COPD? Or do some of the anti-TB drugs reduce the risk of developing post-TB COPD? We don't know. It would be really worthwhile finding answers for this.
You know, one of the biomarkers we did, with one of our students for her thesis was looking at TNF alpha. So people, after post-treatment, we looked at people with post-TB sequelae. Almost 2/3 of the patients, land up with both radiological and physiological sequelae. And people with high TNF alpha had much higher risk of developing post-TB sequelae. And about 20 or 25 years ago, I remember reading a study which has used thalidomide, which is a TNF alpha inhibitor, and actually showed that the post-TB lung fibrosis is reduced. But because now thalidomide is so, actually, I don't know what to call it, it's really put down in the dumps. Your thoughts?
Yeah, just a comment on this. Some of these biomarkers may be useful if there is an ongoing acute process and you want to check monitoring, but I wouldn't use them, let's say, for early diagnosis because they are inspecific in the sense that they are not lung specific. So
Yes,
CC16 is lung
Lung
specific,
specific.
but not TNF alpha or
Correct.
CRP. Right.
Although, so cough, thalidomide has been explored for that with respect to mucus and fibrosis, and analogues now synthetically are being looked where the therapeutic ratio is obviously increased. I did want to say, not to close the session, but you and I were just speaking, and healthcare practitioners, to prevent the progression of TB, and maybe you don't know this, they need to know about TB, they need to know about COPD, and what I've just heard is that respiratory medicine may actually not be in the undergraduate curriculum in India, and you are doing a lot of advocacy in this. So this is a big worry for respiratory medicine, that it may be removed from the
because if they've had exacerbations in the past, they will have exacerbations in the future. And then gram-negative infections. It's so important to send sputum samples for our bronchiectasis patients because they guide our management. And if we zoom in on the outcomes for the gram-negative bacteria that we identified in this study, consistent with what we know, Pseudomonas aeruginosa was associated with a 40% in exacerbations, and quite unique to the Indian context, Klebsiella in sputum was associated with a 56% increase in exacerbations, a 67% increase in hospitalizations, and a significant increase in mortality. So the isolation of any of these enteric gram-negatives in sputum should be a red flag and should make us think about prophylactic therapy. We will only know about these things if we send sputum samples, so that's a key clinical message. Once we've identified that this is a patient in need of treatment, what are the treatments that we recommend? Well, we have guidelines from the ERS from 2017, and these recommend firstly that we should test for underlying causes, because immune deficiency, AVPA, NTA, so a major undertaking, particularly as part of this was during the COVID pandemic. As you can see, the majority of patients completed the study, and the primary outcome was the frequency of exacerbations, and there was a statistically significant, roughly 20% reduction in exacerbations at both of the doses. And this is something that's interesting. We've seen with other compounds in this class that the ramping up the dose doesn't seem to give you a greater exacerbation benefit. The 10 here gave the same level of benefit as the 25. However, there was a differential effect on lung function. Bronchiectasis is a progressive disease. As patients live with the disease, their lung function declines, just like in COPD. And you can see here in the placebo group, over a year, on average, they lost 62 mils of lung function. So a relatively rapid decline in lung function. This was prevented, but only at the 25 milligram dose. And you see this nice pharmacology with the effect on the bone marrow here, that it's in the second half of the study, once those neutrophils have been replenished with the inhibited neutrophils, that you see this effect. We also saw a greater effect on symptoms with the 25 milligram dose, which you can see here. There's a placebo effect, as we see in all trials, but a greater effect on symptoms that's statistically significant with the 25 milligram dose. Of course, safety is really important with novel drugs, and we didn't see any major safety issues. There is one side effect to note with these drugs, which is an increase in hyperkeratosis, thickening of the hands or small red dots on the skin. 4 cases in placebo, 8 in 10, and 17 cases in 25 milligrams. Unlikely to be a major issue, but it is a recognized side effect with these drugs. So this is a really exciting time for bronchiectasis. We have the first effective anti-inflammatory, and this is leading to a massive expansion in clinical trials and a greater interest in repurposing anti-inflammatory drugs for bronchiectasis that I hope will lead us to multiple effective compounds in the near future. And this graphic illustrates a number of the potential targets within this disease. So this is a really exciting time for bronchiectasis. 2024 was a landmark year. So thank you to everybody in the room who's contributed to our bronchiectasis research as part of EMBARK India. And Raja has had more than one call out today, but I'll give him another one to say that he really has been a champion of this disease in India and deserves a huge amount of credit for that. Thank you very much for your attention.
Thank you very much indeed, James, for that overview of some of the exciting developments in bronchiectasis. I'm now delighted to introduce Carlos Rabalo-Rudkudira, who is going to take us through similarly some exciting progress that's being made in the ILD sphere. Thank you, Carlos.
Thank you, Hilary. My pleasure to be here again, speaking on the progressive pulmonary fibrosis for this very nice audience. This is my conflicts of interest for this lecture. And I would like, first of all, to remind you some concepts on this concept of progressive pulmonary fibrosis. First of all, coming from the latest guidelines on IPF that were published in 2022, where we can see, first of all, that this is not only on IPF, but also on IPF and PPF. And so, coming with this, we understand perfectly that those are different entities. PPF is not exactly the same as IPF, and also the contrary. And it is not an entity. Of course, we will come back to that. The behavior is the same. The behavior of progressive pulmonary fibrosis and IPF is exactly the same, following up with clinic, with lung function, with radiological evolution, and looking at the right side of the slide, the survival studies from different studies that we had, not only from the guidelines, but also from different clinical trials with nintedanib and also with pirfenidone, so with both antifibrotics, the behavior is exactly the same. And I think this is a very important notion for someone to follow up a patient with interstitial lung diseases, the clinical disease behavior. This was for the first time released in 2013 for the idiopathic interstitial pneumonias, and we can see that those progressive diseases and the irreversible diseases that were pointed out as a clinical disease behavior for IIPs are exactly the progressive fibrotic phenotype that we know now as progressive pulmonary fibrosis. If we look at independently of the background of the disease, so connective tissue diseases or hypersensitivity pneumonitis, if we look at these figures, we understand perfectly, and it is something that we already know from IPF, that the presence of fibrosis is related with a worse prognosis. So this is the last slide for this conceptualization. It is important that in the diagnostic workflow we should be paid attention and follow 3 important steps. First of all, a complete and a comprehensive evaluation with serology, with bronchoalveolar lavage when we need when we have and when we live in a country with a high prevalence of hypersensitivity pneumonitis. It is the case in Portugal, as I know it is the case here in India. And so the second important step is to have this multidisciplinary team discussion to try to get to a diagnosis, and even if not possible, of course, to look at the disease behavior corresponding to the clinical, to the functional, and to the radiological evolution of the disease, and then to come back again for the multidisciplinary discussion. This is the way how we can eventually get to the different profiles of no progression or of the disease progression to a progressive fibrotic phenotype that, of course, has a different prognosis and that eventually is deserved different therapeutics. How can we define this phenotype? I would call it phenotype. Well, with three criteria, but we must have two of these three. Finally, the evidence of progression of pulmonary fibrosis from the different components of from where we can identify fibrosis in a HRCT. Of course, if we look at the different studies in here we have, for instance, the main criteria used for the patients that were included in the inbuilt study. I will come back to that. We can have a combination of lung function, of symptoms, and of radiology features to define the progressive pulmonary fibrotic phenotype. So, if we look, as it is the case here in this, with this paper, to the different entities that compose the interstitial lung diseases, and we know that there are more than 200 entities that can be included in this interstitial field, we perfectly identify that almost all of the entities that are present in every branch can have a phenotype of progressive fibrotic disease. Of course, IPF is the paradigm here, but in every of these in every branch of these interstitial lung diseases, we can have this. And so this is truly important in order to have in mind that when we diagnose a patient with interstitial lung disease, we should always think that that patient can have in the future, in the near future, this kind of evolution. This is a very nice consensus made by an expert group, where, for instance, Raja is also part of this consensus, where it was clearly from a large group of patients defined that, of course, the PPF can be present in many interstitial lung diseases entities, but it is more when we have the unclassifiable disease, the connective tissue diseases with interstitial involvement, and also the chronic HP, that we can have the higher prevalence of this phenotype. So it's important, first of all, when we are looking at the patient with interstitial lung diseases, to look at the general factors for the fibrosis, for having fibrosis in a patient, not only related with the patient, age, some genetic susceptibility, some comorbidities like reflux or obstructive sleep apnea, and also some autoimmune diseases, but also some external factors like smoking, occupational activities, and also viral infections. But there are specific risk factors for a more progressive phenotype, as it is the usual interstitial, the UIP pattern in HRCT, and so the more extensive traction bronchiectasis in this radiology, and also the more rapid progression of disease, no response to the initial therapy, and some other characteristics that we already saw. And when but there are some specific risk factors for certain of these clinical conditions, like it is the case in HP when we do not identify the antigen, or in CTD associated with ILD when the disease is more extensive and there are positive serology and some other characteristics. And this is a very interesting registry, a prospective registry, a large one. You can see the numbers here, where it was clearly shown the main risk factors for having this progressive phenotype. So the age at diagnosis, the gender with the more risky in male, the history of reflux, and also the lower baseline lung function in terms of FEVC numbers and in terms of also of diffusion capacity. How can we monitor these patients? And this is truly important because we get very late to these patients. First of all, we get very late to every patient with ILD. And we have at least 1 year here in this large, in this paper where more than 500 doctors from different fields were surveyed, and it is at least 1 year or more since the initial symptoms until the diagnostic of ILD, and at least 2 years after that, until, if the patient has a progressive phenotype, until that detection by physician. So this is 2 to 3 to 4 years, and eventually 1 more year until the final result, which is a lot. And so early detection, it's fundamental. For instance, in rheumatoid arthritis, a very prevalent disease, it is important that to look at the eventuality of having a patient with high risk, as I mentioned before, and adding to the other diagnostic tools the HRCT to this patient. And stratifying that population, we have to follow them mainly with lung function regularly, and eventually also with radiology to follow up this evolution. This is a statement, joint statement that we released recently from together with the Portuguese pulmonology, also the Portuguese radiology, and also the rheumatology societies. And this is truly important also because acute exacerbations is a characteristic of this phenotype. It's not only exclusive of IPF. When we have mainly a UIP pattern, we can have important high prevalence of this acute phenotype, acute exacerbation in these patients, with a high mortality, as you can see here in these figures. We can get to this, evolution not only with that criteria that I already mentioned, but also coming from some exercise tests that might be done and important for this evaluation. Of course, the trend to have acute exacerbations, and also the need for oxygen and impact in daily activity of these patients. That's why it is important also to think on the home monitoring in these patients, and home spirometry, home oximetry, so the proms that we can have assess also in this home monitoring. It's very important not only to evaluate the disease behavior of this interstitial lung disease patient, but also to eventually early identify the eventual acute exacerbation in a patient through this monitoring. So finally, the treatment. We must have in mind 3 points. First, that eventually we will need to avoid the exposure to an antigen if identified. Secondly, that inflammation and fibrosis may exist, and so immunosuppressors might be important, at least in some entities, but eventually antifibrotics are, of course, the second-line treatment in some of these entities and the first-line treatment in other entities. And this is truly important that we recognize that the use of antifibrotics since 10 years ago changed completely the survival profile of patients with IPF, as it is well shown here. And it is, and I will get back to that. But when we think on the immunosuppressive options, it is interesting to see from that registry I already mentioned that there are a lot of heterogeneity in terms of options for even for first line, although steroids are more present in the first line, but mainly for second line options. So getting to the way to look at this trajectory of these patients and to find the right way to manage it. We might have patients with low risk of progression, and we have to, of course, to evaluate it, to evaluate them regularly. But when they need immunomodulatory treatment, it's important to find if that patient is evoluting or not to the more progressive phenotype, needing at the very end the antifibrotic therapy. And this is what is shown here. This study is a whole study, as you know, coming from IPF patients where it was with the nintedanib, well shown the decrease, the better results in terms of decrease of FCVC. And the in-build study in non-IPF PPF exactly showed the same results with a decrease, a better result in terms of decrease of FVC. We had some studies last year's, negative studies, but we had some molecule that appear recently, interestingly, with results interesting for interstitial lung diseases with rheumatic disease, and also coming from this recent announcement that Fibroneer IPF trial of this PD inhibitor met the primary endpoint, which was the rate of decline of FEVC from baseline at week 52. Those results will be presented very soon this year, and also the same results in non-IPF progressive pulmonary fibrosis. So, coming to an end, of course, this is the key word, get early to the diagnosis, not only of ILD, but also of this phenotype. With that, I think it's important to remind that we need to awareness not only our community, but all the medical community. We do not have biomarkers to identify the risk factors of progression, but we do know that there are risk factors, and so it's fundamental to have the best management in clinical practice. And to remind you, just as a final sentence, that this is not a diagnosis, it is much more a phenotype. Thank you for your attention.
Thank you, Professor Carlos, for the excellent session. So now something we have from India. Next session is about novel screening tool for early diagnosis in ILD. I'll invite Dr. Sandeep Salvi for the next session.
Thank you. I will take off from where Professor Carlos Cordero left. Early diagnosis of interstitial pulmonary fibrosis is necessary. And the second point he said is primary care physicians must be educated about how to diagnose or at least screen interstitial lung disease cases. So what I'm going to tell you is some very interesting story and research that we have been conducting in our country with the aim of developing a screening tool for primary care physicians for detecting early interstitial lung disease.
So
the global burden of disease is perhaps the most authentic source of health-related information which many countries use to decide healthcare policies. The GBD was initiated in India in 2015, and the first GBD India report was published in 2017 under the aegis of Vice President of India. Since then, we have reports in 2019, 2021. The 2021 is the latest report that was released last year, and the 2023 report will probably be released sometime this year. The 2021 report has actually given us some insight into the potential burden of interstitial lung disease across the globe.
And as you can see over here, the burden of interstitial lung disease seems to be at least reported in the United States, India, China, and Japan. Doesn't mean that there is no interstitial lung disease in the rest of the world. It's just that there is no information at all to even make some estimates of the burden. So as you can see in this potential burden of interstitial lung disease globally, the United States leads the world with an estimated 0.7 million cases, followed by India as number 2 with an estimated 0.65 million cases, followed by China and Japan. I genuinely believe that this is a gross underestimate because there is no simple tool to pick up interstitial lung disease in the community or even in patients visiting the primary care. So these are just estimates that at least give you some insight into the burden of ILD. There has been a report on the state-wise burden of interstitial lung disease in India, which is a component of the GBD India report. And as you can see here, the highest burden is estimated to be in Uttar Pradesh with an estimated 100,000 cases of ILD, followed by Maharashtra, then Karnataka, Rajasthan, and West Bengal. So there is some information related to the burden of interstitial lung disease that we have. But what is more important is interstitial lung disease remains diagnosed much later on in life. And there are studies that have looked at the average duration between the onset of symptoms of ILD and the diagnosis that was made, both globally as well as in India. And in the high-income countries, such as the Western world, the duration of diagnosis from the onset of symptoms has been shown to be around 12 months. So the patient loses on an average 1 year to ultimately arrive at a diagnosis of interstitial lung disease. What is the state of affairs in India? And the Indian ILD registry, which was led by Dr. Sheetu Singh, showed that in her data, the average duration from the onset of symptoms to the diagnosis of ILD was around 4.1 years. So clearly there is a significant challenge and a problem of a delay in diagnosis of interstitial lung disease in our country. Now once that happens, what actually gets translated into patients' health care? So 55% reported having at least one wrong diagnosis before they were correctly labeled to have interstitial lung disease. 38% had at least 2 wrong diagnoses. The most wrong diagnoses made were asthma, pneumonia, and bronchitis. And this is data from the Western world. I'm sure in India, we could add tuberculosis as well. 30% visited their primary care doctor at least on 4 separate times before they were referred to a lung specialist for a potential diagnosis. 75% visited at least 3 different doctors before they were correctly diagnosed. Nearly every person had some procedure in the lung which they honestly did not require. And many patients were prescribed antibiotics, steroids, or asthma medication, obviously which they did not need. So this is the current state of affairs of the burden and the impact of delayed diagnosis of interstitial lung disease globally. There have been some serious attempts to develop a simple screening tool, especially in primary care, so that these patients could be picked up early on and then referred to a pulmonologist for further workup. And the best one that I found was a clinician toolkit, which is actually a checklist that was developed by the Chest Foundation, Boehringer Ingelheim, and the 3 Lakes Foundation. This has been published in the journal Chest, the American College of Chest Physicians. It contains some 25 items which the physician has to administer to the patient in order to pick up interstitial lung disease. But this is not a screening tool. This is a checklist. So another study which was published just very recently, which is in fact ahead of print, was looking at the potential of using a digital stethoscope to pick up basal Velcro crepitations and then use that as a potential marker of an underlying interstitial lung disease. So this study included 24 patients who had fibrotic interstitial lung disease and 24 patients who had non-fibrotic lung disease picked up on high-resolution CT scan that was evaluated by 2 expert radiologists. And then 2 expert chest physicians used a stethoscope to listen to the basal, if there is presence of basal Velcro crackles. And the digital sounds were collected, stored, and then using artificial intelligence, it actually looked for signature sounds that identify Velcro crackles. Now, this is an innovative way of picking up early interstitial lung disease. The reported sensitivity was 83% and specificity was a little on the lower side of 59%, but an overall accuracy of around 85%. Not bad, but it uses a digital stethoscope to pick up early COPD. So with this background about the need to have a simple screening tool for interstitial lung disease, especially for primary care physicians, we undertook this study called as the DSTIL study, or the development of a screening tool for interstitial lung disease. The brainchild behind this was Dr. Deepak Mutreja, who is a pulmonologist based in Nagpur, and he actually came to us with this knowledge gap, and we had a long bit of discussion, and finally, with the support of CIPLA, we went ahead in conducting a real-life study to finally come up with a screening tool for interstitial lung disease. So the way we went about doing that was, first of all, we did a complete review of literature as to identify the variables that will help us identify patients of interstitial lung disease, be it demographics, be it symptoms, be it signs, risk factors, or comorbid conditions. So all this review of literature was collected, and then we pooled all the variables, and we collected a total of around 100 variables. But clearly we can't ask 100 questions to a patient in a primary care clinic. So then we filtered out from this list that we collected using 5 expert pulmonologists to say, can you please identify the least important variables from within that 100 variables that we had listed. So this was then further reduced by content validation with another 15 expert pulmonologists. And finally, we filtered off all those variables to a total of around 21 items that we believed we could administer and then find out of these 21, which one would give us the highest sensitivity, specificity, positive predicted value, and the negative predicted value. So with this, we then went on to do the study in 1,184 patients across 23 centers in India. So you can see that this is a nationwide study in which we took 619 patients of ILD proved on HRCT, and then 565 patients visiting a respiratory clinic who had an underlying HRCT but had no underlying interstitial lung disease. Then the 21-item questionnaire was administered to both the groups. And then finally we looked at whether we could reduce from 21 items, so finally from 100 to 21 to whatever is the minimum number that gives us the highest sensitivity, specificity, positive predicted value, negative predicted value, and therefore the accuracy. So we developed, so this was the derivation cohort for the tool, and then in a second population, which was 14 centers across India, we did the validation study. So for the validation, the tool that we had developed was tested in 75 patients of ILD, 81 patients of non-ILD in a prospective manner, and then verified whether the sensitivity, specificity, and the other parameters which we had derived in the derivation cohort was also the same in the validation cohort. Unfortunately, I cannot show you the results because the abstract for the derivation cohort has been submitted to the American Thoracic Society conference, which will be held in May. It has been accepted for a presentation, and the validation cohort, the abstract has been submitted to the European Respiratory Society Congress. So because the data is not yet made publicly available, I cannot show you the results. But I can tell you that the results are quite exciting, and I hope that perhaps this could be one of the first screening tools developed in the world that could have a potential application in primary care practice so that, we can reduce the delay in the diagnosis that occurs in these patients. So with these exciting news, although I'm sorry I cannot share the results with you, I hope that the DSTIL study will get recognition and will be used by primary care physicians, not only across India, but hopefully across the globe as well. Thank you so much.
Thank you, sir. Thank you for the presentation. Let me have the expert viewpoints from Dr. Murli Mohan BV. He is a senior consultant, pulmonologist and academic director, Department of Internal Medicine and Pulmonology, Narayana Hridayalaya, Bangalore.
Thank you. It's unfortunate that the data could not be shared, but it is exciting data. Dr. Sandeep has shared it with us. And I think it's going to be very, very simple, actually, to apply this. The average delay you heard was about 4 years, and most of it is happening at GP and physician level. So the application of this, we hope, and its popularization will take it further in picking up this disease early, preventing the mistreatment. As Dr. Sandeep Salvi said, most patients are treated in India as tuberculosis. Our own study shows a delay of at least 15 months. And most patients have received 1 or more courses of anti-TB treatment before a diagnosis was picked up. And before I blame physicians and GPs, physicians, pulmonologists too have treated them as TB in the past. So that's something we should really not pat ourselves on the back about. Last of all, I think what we hope is that this will be universally applicable. So let's hope it gets approval from the international organizations.
Yeah, I hope so. I think these are exciting times. We have tried to address a very important knowledge gap and a tool that has got tremendous application. So let us see how it goes in real life clinical practice.
Next, I think we'll have a question and answer session about the 2 topics which we have already discussed about bronchiectasis and the ILD PPF part. Let me invite Dr. Sujit Rajan. He's a consultant respiratory physician, Bombay Hospital, Institute of Medical Sciences, Bhartiya Hospital, Mumbai.
Thank you everyone, and some great talks heard, and I hope we can, in the 10 minutes I think we have, 10 minutes, Sandeep,
Yes.
Go through some questions that that have been covered in the last 2 sessions. So James, first to you. What do you think has been the most significant landmark, in your opinion, in bronchiectasis research in the last year? Let's look at the last 1 year, because COVID had almost passed by then. Research, RCTs were good. And another question that I'd follow through on, are there any unmet needs, both diagnostic or therapeutic, that need to be filled in clinical practice?
Thank you very much, and great to see you again.
Thank you.
I think that for landmarks, we can't look past the development of the first specific drug for this disease. So that's going to be a huge stimulus to this field. If we look at pulmonary fibrosis, the development of pirfenidone and nintedanib made a huge difference to the disease, not just the impact of those drugs, but also then the impetus that gives to clinicians to go, there's something specific here,
Sure.
so I'll investigate more aggressively and I'll treat more aggressively.
Right.
And so I think that's the major landmark. In terms of unmet needs, where do we start? I mean, bronchiectasis is such a, at the moment, neglected condition, as you saw from the data that I
Yes.
presented.
Yes.
For all the fancy treatments that we have,
Right.
I think the biggest unmet need is doing the simple things well. We don't investigate enough, so we should be doing
Sure.
immunoglobulins, ABPA testing for every patient, offering pulmonary airway clearance for every patient wherever possible, and using the prophylactic treatments that we have, like azithromycin, which are very effective, much more than we currently do. And if we do all of those things, we'll be doing a much better job for our patients.
Thank you, James. Simple messages, though, very important. Always tell our postgraduate students, don't forget that. They probably fail their MD if they forget postural drainage, and you said it 3 times. Carlos, over to you. In ILD and PPF, in the research landscape the last 2 years, I mean, you mentioned the nerandomilast meeting its primary endpoint in IPF and probably looking at results for PPF also very soon to be announced. But do you think that's the biggest step in the last 2 years? What do you think has really changed in the last 2 years, Carlos?
Thank you. So I think first of all that many things changed after we had the antifibrotic option 10 years ago. So the profile of the evolution in our patients with IPF and the survival is completely different. This is one.
Sure.
Secondly, this notion of PPF also is very important. It is more recent, of course, very important because it has also indication for getting this medication as the results within nintedanib showed very elegantly within BUILD study as the paradigm example. Secondly, having in mind these two notions, I think I go back to what is the most important issue here. It's to get early to these patients. And they are not only, I think they are not only lost, I would say, in the GP setting. We have to go to other disciplines because these patients have comorbidities. And if we, for instance, to create more awareness of these entities in the cardiology field can be very important because many of these patients might be followed by a cardiologist because of heart failure. And the symptomatology might be, well, similar somehow with the, so this is also for me very important, not only to look at, to create more awareness and to promote among the GP the need of identification of this patient in an early basis, but also in other disciplines. And I'm very impressed with the 4 years to get to the diagnosis here because this is something that even makes more importance to this early approach.
And 4 times longer is just not an excuse, if you ask me, in India, when we have enough CT scanners across the country. In fact, there's been a mushrooming.
Auscultation is very important.
Sorry?
To auscultate the patient.
Absolutely.
Before the CT, we need to identify the posterobasal crackles. This is the basis.
I had heard of that sound lab in Southampton and where they were doing this research. But the specificity is a little low because we do see crackles in normals as well. But it's interesting how that late diagnosis space is really evolving. I'd put it in, and transcending from that question to the next, Sandeep, you talked about this screening tool to improve ILD diagnosis. Unfortunately, you couldn't share results, and we were hoping it would be presented at the WASOG conference, actually. But if this gives, I mean, looking at it, I think if GPs or primary care physicians, general physicians pick up ILD early, it'll be fantastic. Especially with the time lapse. But do you think, just thinking about doing a thin section CT would be less time consuming than a questionnaire and equally useful, if not more? What's your thought there, Sandeep?
So ideally, yes, a thin CT would give you that more sensitivity and specificity to pick up interstitial lung disease, but it is not a practical tool. The moment you suspect interstitial lung disease, please go and get a thin CT scan. Would rather be not cost effective, would not be practical as well. So perhaps we could use a two-step method. Administer a screening tool, and those who are screened positive may then be referred for a thin section CT scan. Maybe that would be more cost effective and more practical in a real life setting.
Yeah, I just see the history-taking skills of the average primary care physician just going down because of just time constraints.
Absolutely.
The number of patients they see, even at the specialist level, the time constraints have come down, Sandeep. You know, so I'm just wondering, and I know the UK is debating lung cancer screening and say, yes, Hillary, please.
I feel I need to say something as the primary care representative
Please.
on this panel.
Please.
It is, of course, a real challenge. Well, it's a challenge for all clinicians, actually, but it's a particular challenge for primary care to find the one patient that's got a rare lung disease out of the hundreds that we see, thousands even, with these common symptoms.
Sure.
And if they're only seeing a primary care clinician 4 times before they're referred, that may not be, it may even be that actually seeing your primary care physician 3 times for a symptom is the type of red flag that we need to make a referral.
Sure.
You really don't want to see all my patients with cough.
Yes,
Okay.
yes.
So we need red flags. We
Yes.
need, and this is where I'm really interested in this work that Sandeep is working on.
Sure.
Because as a primary care clinician, it's not my job to diagnose ILD.
Right.
It's not, I actually do have access to CT scanning,
Right.
but very many of my colleagues, even in the UK, would not.
Right.
So that isn't really going to work in
Right.
practice. What I need are the flags that say, this is the patient with this common symptom that needs to go to the specialist to be investigated, and then they can work out
Sure. No,
the
it's a
investigations.
fascinating topic to
So
discuss, really.
It's an important topic, and it's the only way into the problems of early diagnosis that we've heard a lot about this afternoon.
Sure, sure. No, I know the challenges in the UK on getting a scan done in primary care. Those challenges are not there in India that much. The chance of getting a scan done is very fast here. And it's even less in Japan. Japan, there are a lot of primary care physicians who own scanners. So
Who pays for the scan?
The patient.
Right, well there you are, you see. If the patient has the money, presumably they can pay for the scan,
Right.
and anybody can refer them.
That's right.
In my setting, of course, the patient does not pay for the scan.
I understand.
And the restriction is there.
Yes, Murli, please.
No, I completely agree with both of them that it has to be at every level. A lot of the referrals now, Deepak Matreja was telling us that he applied this questionnaire, gave it to his cardiology colleagues, and got promptly 3 pickups of ILD.
Oh, fantastic.
From a cardiologist. So that's actually very interesting.
Fantastic.
The second is we're getting a lot of referrals from cardiologists when they do a calcium scoring CT. And then they pick up interstitial lung disease, they pick up, the small airways disease on the CT. So we're getting a lot of referrals from...
Yeah, but that's the CT done.
The CT already
They're
done.
already
Absolutely.
done. That's
yeah.
right. That's right. So I know that debate is going on in the UK also on lung cancer screening with CT. So it's an evolving space. I go to you, Murli. Screening tools, thin section CT, possibly biomarkers in India's healthcare system, because this is India, and you know our system, you know how scans get done, blood tests get done. What do you think of this moving forward?
So there's no one India. There's a huge number of Indias.
Right.
Some of them can get everything done. A lot of them can't get anything done. So we need to be
true.
aware of that, which is why a screening tool, like Sandeep said, is
Sure.
very, very useful. And as I said, when you can get, and CTs are widely available, I can get a CT within a couple of hours in the same hospital. But at the same time, it's expensive. It's much less expensive than in the West. So I think we can get a scan for like 20 pounds. So it is much less expensive, but it still costs a lot. The biomarkers, not that easy. I don't see it coming for some time. But the other thing that we've been increasingly using is a whole genome or a whole exome sequencing in individual patients with interstitial lung disease, and it's been giving us a lot of very useful data. Again,
For
expensive.
familial disease.
Yes, for familial disease and others. I think we are picking up a lot of things where we did not suspect a familial disease with genome sequencing.
Sure. Interesting. Yes, Carlos, please.
Just to
please.
wrap it. This is a multidisciplinary, multidimensional approach,
Yes.
because we can have many variables. So from the clinical demographics, genetics, lung function, radiology, and I think, of course, artificial intelligence will help with this in the near future. Biomarkers, we are lacking a lot. Biomarkers for the disease identification, the diagnosis, and even for the evolution, for the worst evolution of these patients. But where we have to be, and I think we have to push more for an optimized report in terms of HRCT from our radiologists, because a quantification of the different alterations that are shown in those.
The algorithm has to change.
And the deep learning approach that can be done after that, this is truly important. Of course, radiology is key for this.
I'm going to have to take the chairman's task very seriously now and call the session to an end, unfortunately. We could go on talking for ages. We've raised lots of really interesting topics, but time is up.
Yes.
And we shall have to say thank you to everybody for contributing. Thank you.
Thank you very much, everyone. Thank you.
So we move on to the final session of the day. So I would request Dr. Chalmers to be on the dais, and I invite Dr. DJ Christopher, Professor and Head of CMC Vellore, to do the honors and invite the rest of the faculty.
So we finally come to the last session. We will try and use the time as wisely as possible so we can wind up soon. So I invite all the players here in one go so we can save some time. Dr. Kushbu Pilania, Dr. Lakshmi Narsimhan, Dr. Balmurugan, Dr. Vishwanath Kela, Dr. Anjana Babu, Dr. Vishweshwaran, and Professor Ashmita Mehta. So please come. And I hope there are enough chairs for all of us. I think there is. Right. We will now start the case presentations. The first case will be presented by Dr. Vishwanath Jella. Okay, you want to present first? Okay, right. So Dr. Anjana Babu will present the first case. May I invite Dr. Murli Mohan also to come up?
Good evening all. At the outset, let me thank the organizers for this wonderful opportunity. So today I'll take you through an interesting case of bronchiectasis. So this is a story of a 15-year-old boy who was born of a non-consanguineous marriage with no significant family history or childhood illness. And he presented to us with history of recurrent pneumonia and cough with copious expectoration since 3 years duration. He was referred as a case of right lower lobe pneumonia to us with bilateral bronchiectasis, and he was put on empirical anti-tuberculous therapy. On admission, he was in shock and respiratory failure. He was mechanically ventilated and started on inotropes. He was started on broad spectrum antibiotics. This was his X-ray on admission, which shows bilateral cystic and alveolar shadows with denser shadows in the upper zone and lower zone with some suspicion of a right lower lobe collapse and air bronchograms. And this is the CT thorax. I'll show a closer picture. In this itself, we can see the bilateral bronchiectasis. Here you can see the bilateral bronchiectasis with signature sign and consolidation with right lower lobe collapse and some amount of ground glassing with mosaic attenuation. So since after 2 weeks, the patient improved and he was extubated, and then we went in for a FOB, fiber optic bronchoscopy, because there is some evidence of right lower lobe collapse, and we wanted to rule out a foreign body aspiration or a slow growing tumor. So the findings were narrowing of medial segment of middle lobe was noted, and there were purulent secretions from the right lower lobe basal segments. And we also wanted to rule out tuberculosis and NTM infection. So we went in for a BAL, and the AFB smear and CBNAT was negative, and BAL AFB culture was also negative. So NTM infection was also ruled out, and BAL routine culture yielded Pseudomonas aeruginosa. So this is an adolescent boy with no history of childhood illness from a non-consanguineous marriage. So we were suspecting of immunoglobulin deficiency. So when we investigated regarding the IgG, IgM, IgA and IgE levels, and you can see all the IgG, IgM and IgA were reduced. And it was present on serial occasions. Twice it was after detecting on serial occasions, we could identify that there is significant immunoglobulin level decrease. So we wanted to assess the cells, characterize the cells, but the B cells, CD4 and CD8 cells were within normal limits. We assessed that with the flow cytometry. So that with that we understood that B cell levels are normal, but there is impaired function of the B cells, which again points to an immunoglobulin deficiency syndrome. Now we went in for an exome sequencing, which is a study of exons to identify the genetic mutations which will characterize the combined variable immunoglobulin deficiency, which usually presents in adolescents and adults. And we could get a heterozygous autosomal dominant mutation in exon 1, and we advised parental testing, but they were not willing. So the complete diagnosis is common variable immunodeficiency with bilateral bronchiectasis, and the cornerstone of management of bronchiectasis is to identify the etiology. So in this case we have identified the etiology, and we have started him on IVIG supplementation, and he was given eradication therapy to decrease the inflammation, and patient clinically improved, and this is the chest x-ray after 1 month. So the take home point is leave no stone unturned in the workup of bronchiectasis. As we know, CVID is having a very low prevalence in India, but maybe it may be because of lack of awareness, or maybe due to underdiagnosis. Thank you.
Very good presentation, Anjana. So you have presented a unique case in many ways that has not so far been covered in today's symposium. So it gives us the opportunity to quickly look at this entity. James, would you like to chime in a bit?
So this is a very important case because 10% of bronchiectasis patients overall, and that includes children and adults, and much more than 10% in children will have some form of immunodeficiency. Certainly in the UK, common variable immunodeficiency is the most common, but we increasingly see other types of immune deficiency presenting with bronchiectasis. This is very eminently treatable if you identify it early in institute IVIG. So patients like this, the earlier you can identify the immune deficiency, you can avoid the development of cystic bronchiectasis and the long-term sequelae that's associated with that. So it's really, immunoglobulins are not an expensive test, and they will pick up the majority of immune deficiencies, and so it's really important we do this at an early stage in people that have bronchiectasis, but also I would say recurrent pneumonia, which I think this patient had. It's a very, very good test, particularly in children who have recurrent pneumonia, to find these immune deficiencies early.
So how old was this patient, Anjana?
He's 15-year-old, sir. 15,
right. So, well, patients, one might intuitively think that patients would have recurrent infections from birth, but that's often not the case, right? Many of them are detected after 20 years.
Yes, 20 to 40 years
Is,
CVID,
right.
they can present at that age.
Right. And the second point that you that you made, which should be a take-home message for all of us, is that don't take evaluation of bronchiectasis lightly. I think in our practice, bronchiectasis is just one other condition, and you straight away go on to give postural drainage, bronchial hygiene measures, give antibiotics, and send the patient away. But if the etiology is not apparent, is not evident, then I think it's very important to work that patient up and see if there's something more you can do for the patient. Right? Any other views from the panelists, quickly? Quick comment.
Just one question to Dr. James. So when we speak about CVID, sometimes we see the immunoglobulin values being normal, but functionally they may not be having a good response. So do you do the challenge to the vaccination routinely to look for immunoglobulin response in UK, or how? Because in India we hardly do, except for few centers where they give a vaccine and look for the augmentation of the immune response.
Exactly. So in true CVID, the immunoglobulin should be low. So in true CVID, they're low. What you're talking about is really identifying a subcondition of this, which is specific polysaccharide antibody deficiency, which is where the immunoglobulins are normal, but the B cells are unable to make a coordinated response against a challenge. So there, the best test is to do the pneumococcal polysaccharide vaccine, PPV23 antibody levels, and if they're low, vaccinate the patient and then recheck them 6 weeks later. And there are a subset of patients that will be unable to make a response to the vaccine, and they benefit from immunoglobulin replacement. So they're a small group, but we do that routinely for all of our patients. But true CVID should have low immunoglobulin levels, or at least low IgG levels.
James, quickly on that one, you said to use PPSV23 pneumococcal vaccine. There's a PCV13. Does it really matter what you give?
No, as long as your assay will detect the specific antibody levels that you're looking for.
Yeah, depending on the availability of the assay, you go
exactly.
For it. Yeah.
So there are commercially available assays for the serotypes that are within the PCV13. Yeah. So if that's what's available, then you can use that as long as you use the associated assay.
Yeah, maybe one of you.
Yeah, the treatment is also lifelong. So most of the patients, they're required to take it, maybe you can reduce the frequency if they're stable, but it has to be continued lifelong. Yes.
Sure. Last point?
Last point is selective IgA deficiency associated with bronchiectasis?
Yes, absolutely. IgA is your primary mucosal defense, and so there's very clearly an association between IgA deficiency and bronchiectasis. It's probably the second most common immune deficiency that we find in our bronchiectasis patients.
Okay, thank you.
Unfortunately, there's very little evidence that those patients respond to immunoglobulin replacement, and so prophylactic antibiotic treatment with things like azithromycin is the primary treatment.
Okay, so we'll move on to the second case. Thank you, Anjana. Good presentation. The next case would be presented by Dr. Vishwanath Gilla.
Very good evening, one and all. It's my pleasure and privilege to be a part of this ERS India Summit, and I thank the organizers, ICS, ERS, and Dr. Rajendra for giving me this opportunity. Today I'm going to present a very interesting case of bronchiectasis, who presented with an unusual infection, contrary to what we generally think actually. So we had a 51-year-old female who presented with history of cough and purulent sputum for 6 months duration, and during this 6 months duration she received multiple courses of oral antibiotics empirically. Sputum cultures were done, but they were negative. She also started having streaky hemoptysis of late. She presented to us 2 months ago actually. she had significant loss of appetite and significant loss of weight. In the past, she had history of pulmonary tuberculosis, for which she was appropriately treated 15 years ago. And later on, actually, she had seasonal cough and cold, but it used to subside on its own with symptomatic medications, actually. And this is the X-ray which you can see here, actually. You can see that there is inhomogeneous opacities in the right lower zone with air fluid levels, and there is obscuration of the right lateral margin of the heart, suggesting that there could be a possibility of bronchiectasis here in the right middle lobe. And then again, the left cardiac border is obvious, but in the left lower margin is not very clear, actually, suggesting that there could be some pathology in the left lingula as well. Again, these are the CT images of this patient. Actually, there were scattered centrilobular nodules in the right upper lobe, and there is also right middle lobe bronchiectasis, actually. We can see that the bronchial tree, there is nothing obstructing the bronchial tree in the visualized sections, actually. Further down, we could see that the bronchiectasis was extensive here. The entire middle lobe is replaced by bronchiectatic areas. There are areas of air fluid levels, and suggesting that there could be secondary bacterial infection based on the clinical and the radiological presentation of this patient. Here at this point of time, we thought of differential diagnosis of tuberculosis reactivation, or we need drug-resistant bacterial infection because of the history of recent multiple course of antibiotics, or sometimes we have seen nocardia and NTM also causing infective exacerbation of bronchiectasis. So sputum was again done for this patient to check for gene expert and AFB stain, which were negative. In view of this predominant right middle lobe bronchiectasis, we wanted to rule out an endobronchial obstruction and also take cultures from this right middle lobe area. So these are the findings of the bronchoalveolar lavage. Actually, there was nothing endobronchially, there was no obstruction, actually. So we could see gram-positive cocci and then few gram-negative coccobacilli and gram-negative bacilli. The culture and sensitivity was positive for Haemophilus influenza. The tuberculosis workup was negative for AFB stain, expert MTB ultra, and also AFB cultures were negative at 6 weeks finally. KOH mount and initial fungal cultures were negative. However, the Ball galactomannan was positive, around 1.5 actually. So we thought whether we are dealing with a case of pulmonary aspergillosis with secondary infection in the background of bronchiectasis, and then subsequently after initially started treatment for this patient with amoxicillin and clavulanic acid for the proven Haemophilus influenza infection, because we already have a positive culture here. And then subsequently at day 10, we had the final fungal cultures actually, which grew Aspergillus fumigatus actually. We also looked for modified AFB stain for nocardia, which was negative. In this actually total IG was done in the past, but this episode we did not do total IG or Aspergillus fumigatus specific IG and IgG. And in view of the fungal infection, this patient was also treated with voriconazole. Actually, symptomatically the patient is better, the cough, purulence has come down, the appetite has improved again, she started gaining weight. She has come for follow-up after a month of voriconazole recently actually. So with this case actually, I would like to highlight that though bacterial infections are the most common cause of secondary infection in bronchiectasis, sometimes there could be a polymicrobial infection, like in this case we had a combination of bacterial plus a fungal infection. Fungal infection we don't see very frequently. One is we don't evaluate for this, evaluate this patient, or sometimes even if it's positive, they're discarded as probably a colonizer actually. In this patient, because the symptoms of 6 months duration were pointing towards beyond bacterial pathogen actually. And in patients who have a localized and severe bronchiectasis, we need to look for an endobronchial obstruction to see if it can be corrected actually. In this patient after treatment with voriconazole, we have referred this patient for thoracic surgeon opinion as well to consider surgical resection after she is slightly better.
Thank you, Vishwanath.
Yes, thanks.
So, will you quickly go back to the CT scan images? We'll ask Dr. Khushbu Pilania to tell us if there are any clues towards the fungal etiology.
So very frankly, what we are seeing is there is bronchiectasis. It looks like a long-standing bronchiectasis, with some superimposed infection, especially in this right middle lobe region. Very difficult to say what could be the underlying cause, but yes, it's a secondary infection. That is what it tells us. It's it's difficult on this because both fungal as well as any other bacterial infection can complicate. The only thing radiologically we can say is that yes, there is a secondary active infection going on and the patient needs to be evaluated.
Thank you, Kushbu. Vishwanath, please come back.
Yes.
We'll discuss the 2 cases of infection together at the end since we are short of time. So may I request Dr. B. Visweswaran to present his case. So there's some technical hassle here, so we can skip it. May I hand over to Dr. Murali to continue the panel discussion?
Going back to your case, did you show us mediastinal windows? Did they show anything? Because this is isolated to the right middle lobe. I'm just wondering if she had a previous history of TB. So is there any endobronchial disease? Is there any extrinsic compression? You know, as Dr. Kushbu was saying, this looks like a secondary bronchiectasis, unlike the first case that Dr. Anjana showed us. And we don't see this this is quite common in India.
So there was no evidence of obstructions or extrinsic compression. Even during the bronch also there was no extrinsic compression. Even in the mediastinal window, there was no extrinsic compression.
One doubt what I had was regarding the mediastinal window. There was something very dense in the middle lobe. Probably some high attenuation mucus is what we could have looked for if the mediastinal window was seen.
Exactly.
Because there was a very dense region in the middle lobe if the scan can be again played. And probably, I think the ABPA and chronic pulmonary aspergillosis workup was incomplete. Probably if that's completed, then we can get because there is seems to be an overlap. Is it a case of old pulmonary TB with chronic pulmonary aspergillosis, or is it a case of old pulmonary TB with now going on for an ABPA?
Exactly. Is what the points are much more in favor of chronic pulmonary aspergillosis here, but obviously we need to investigate. Professor Chalmers, I have a particular affinity to, I know everybody here are good friends, and my main connection with you, Professor Chalmers, apart from the Embark India study, is that I started my pulmonary medicine training in Dundee, so I'm very happy to see you here. What is the bare minimum test that you'd advise for a patient with bronchiectasis?
So the bare minimum would be a CT. We need that to make the diagnosis. For underlying causes would be immunoglobulins and testing for ABPA, and would be a sputum culture. And in India, that must include an AFB culture. Those are the bare minimum. There's many other things I could recommend, but those will capture most of the underlying causes and most of the things that you need to exclude from a therapeutic point of view.
Yeah. And, Dr. Anjana showed us they did the IgG levels twice. Is it necessary when a person's having an acute infection, you have a low IgG level, is it necessary to repeat it to confirm?
So IgG is actually an acute phase reactant, so often it will go up during an infection. So it is useful to do it when patients are clinically stable. The one trap to not fall into is it can be suppressed by steroid therapy. So people who've got recurrent exacerbations of COPD, for example, and you measure it and it's low, that may be related to steroid therapy rather than being a true immune deficiency.
Good evening, everyone. At the outset, I would like to thank Dr. Rajadhar and ICS for giving us this opportunity, and it's always a pleasure to be with Professor Chams. So this is a unique case of bronchiectasis. So we had this patient who is a 51-year-old female, diabetic, no other comorbidities. BMI was on the lower side, 18 kilogram per meter square, presented with cough with mucopurulent expectoration for 3 to 4 months with occasional streaky hemoptysis, dyspnea on exertion, which progressed from MMRC grade 1 over the year to MMRC grade 3 for the past 15 days. History of fever for past 10 days, loss of weight and loss of appetite, and seasonal cough and sputum. So this was the X-ray at the presentation. You can see there's a lot of interstitial shadows as well as bilaterally. And we got a CT chest done, and the CT chest was suggestive of more of varicoid and cystic bronchiectasis, which was predominant in the lower lobes. And also there was an element of peribronchiectatic consolidations, especially in the left lower zone. So we did an evaluation for the bronchiectasis to rule out CVID. All immunological immunoglobulin levels were normal. Connective tissue disorder workup was done, which was inconclusive. The sputum was sent for testing. It was inconclusive, so we took up this patient for a bronchoscopy. The gram stain was not suggestive of any pathogenic organisms. The tuberculosis workup, including the AFB stain and the gene expert, turned out to be negative. Fungal stains were negative. But we got a modified AFB stain positive, which was suggestive of nocardiosis, and even the culture grew Nocardia asteroidis. So as a part of an evaluation of the, to rule out a disseminated nocardiosis, MRI brain was done, which was suggestive of a focal enhancing lesion in the left parietal lobe, suspicious of a disseminated nocardiosis, but the patient was not having any sort of a skin lesions. So ID consultation was sought, and together it was decided to start this patient on injection imipenem, linezolid, and injection trimethoprim, sulfamethoxazole. So there are a few questions. Should reflex testing for nocardiosis be done routinely in the microbiological evaluation of all patients of bronchiectasis? And let's say we have a case like this where there is a presence of bilateral bronchiectasis. Is there still a role of lobectomy or at least a wedge resection of that particular part, which is contributing more towards the infective episodes? And we know that we have evidence for inhaled antibiotics, but in such complicated scenarios, let's say we have a fungal infection or we have a nocardiosis, should we go out of the way to give an inhaled antibiotic to control these infections?
So why I'm saying this is, we do not suspect nocardiosis in our patients. Mostly our microbiologist calls us and tells. So we do not do any separate investigation for diagnosis nocardia as such. It is if you have a good microbiologist in your hospital, they will pick it up and they will call you back and tell you that this is this, and you send for nocardia culture. And next time when we are sending for eradication, we mention that we are doing this particular. And second thing is, the gene expert will come negative, but if you are, your team will do AFB acid fast bacilli for 20%, they might pick it up. So there are many clues, and I have never done a special investigation for diagnosing nocardia in my career, but I have treated enough nocardia.
Yeah, doesn't the smear show branching filamentous organisms typically, and then that triggers off a search for, yeah.
Professor Chams, how does it work in UK? Because what we have observed of late is, unlike the prior teaching that we get nocardiosis in immunocompromised patients, not only in terms of bronchiectasis, we are getting a lot of these pneumonias, even in an immunocompetent, who is turning out to be nocardiosis. And unfortunately, sometimes the biopsy gives a diagnosis of granulomatous inflammation, where in a TB endemic country, we get skewed to treating as tuberculosis, until and unless we ask for a special modified AFB stain or the Kinneon stain. We generally miss out on nocardiosis as long as it grows up in the culture. So is it your practice in the UK as well to send for nocardiosis as a reflex? Because I saw a recent article in the ERS when I was presenting this case. There is a lot of data coming up on the increased incidence of nocardiosis even in a bronchiectasis patient. So what's your opinion on it?
Yeah, that's correct. It is still relatively uncommon in bronchiectasis, but it may be that we miss it because it does depend on the identification by the microbiologist. So it's not our practice to specifically request a specific test for nocardia. We send off a standard culture, and as you say, the microbiologist will identify features that suggest nocardia and will then perform the appropriate tests. It is something that is important to think about in any patient that's not responding the way that you expect to standard antibiotic therapy. And there's nothing to me from the CT that would suggest that this was nocardia. And so your initial therapy would be treat for typical bacterial infection. The patient won't respond, and that's when having a good dialogue with your microbiologist is really, really helpful, because you can say, look, this patient is behaving as if they've got an atypical infection, which may be fungi, it may be NTM, it may be nocardia, and they may well perform additional investigations for you.
I think it kind of highlights the importance of working with your microbiologist very, very closely, especially in conditions like this. They're very good these days. With Malditoff, they're giving us the names of bugs we've never heard of earlier. And I think the other thing is, when a patient is not responding as quickly as you'd expect them to, you really need to make sure that you talk to them and ask them to keep it for an extended culture and wait for those cultures to come. So high suspicion is extremely important when you're handling these
But
problems.
upfront, we cannot suspect nocardiosis in these patients. We usually think in terms of aspergillosis or something else, but having nocardiosis in mind is something pretty difficult.
Yeah, but I think the point that Dr. Vishweshwar is making is keep your mind open. So any bug could be involved, and nocardiosis is not as uncommon as we used to think earlier, especially in so-called immunocompetent persons.
So that was sort of my point, is if I had a patient like this who after 2 weeks of anti-pseudomonal antibiotics wasn't responding, was still coughing, and I went to my microbiologist and I said, I think it's nocardia, they would look at me like, are you crazy? But what you should say to your microbiologist is, this patient is not responding to standard therapy. They may have an atypical organism, and the differential then is fungal infection, non-tuberculous mycobacteria, or other unusual pathogens, and that's where, as you say, the close discussion with your microbiologist, and often in our case would be invasive sampling. So if it's sputum, then we would go for a BAL at that stage.
What about the role of surgery? There was a question about the role of surgery. Can you throw some?
Yeah,
bilateral.
So very, very interesting. So the second case that was presented with the very severe middle lobe disease, my first thought was, would that be amenable to surgery? Because that's a patient with relatively mild disease elsewhere, with a real sump of infection in one area of the lung. That's often a very good candidate for surgery. People think, oh, I would only do surgery if it's very localized disease and not any disease anywhere else. Actually, in cases like that, where all of the pathology is being driven by one destroyed area of lung, the patient can do really well with surgery. So I think that case would be a good discussion with a surgeon. This one, you have really extensive bilateral disease. I have never seen a patient like this successfully operated, so this wouldn't be high up on my list of surgical candidates.
Regarding the second case, actually, often we see that there is overlap between ABP and chronic pulmonary aspergillosis, actually. When in doubt, we prefer to give antifungals, because there is also some evidence to voriconazole in allergic bronchopulmonary aspergillosis. Yeah. So do you also practice the same when there is overlap or suspicion about the overlap?
Absolutely. So unfortunately in that case, the IgG and the IgE were not available, so it's very difficult to say, is this CPA, is this ABPA, CPA overlap? But certainly in cases where we've got positive aspergillus culture, or we've got other evidence to suggest that this is infection with aspergillus rather than just sensitization to aspergillus, we prefer a combination treatment with including an azole.
Yeah,
because there's a significant risk if you give unopposed steroids in somebody who may have infection with aspergillus, you're going to cause a more significant problem.
Yes.
Yeah, but when we think about surgery, usually certain patient characteristics, like for example the age, the comorbids, surgical fitness, and all these things matter. Like for example, if it is going to be confined for only a particular lobe, we can think in terms of surgery in a young patient. But bilateral bronchiectasis, thinking in terms of spillover infection, we generally do not resort to surgery in bronchiectasis.
Especially if there's some other underlying cause, like CVID or something, you certainly don't want to be whittling away at the lungs.
Yeah, absolutely. And an important thing I would say is with appropriate management, most cases of even very severe bronchiectasis can be managed and have a good quality of life. So surgery is often very much the last resort, or only in very specific cases where there's highly localized disease.
Sorry. Yeah, any questions from the audience? We decided to skip, the questions we had set and request questions from the audience. The last session was actually supposed to be on cough and bronchiectasis, but I think we'll skip that for lack of time. Welcome questions from the audience. Anybody would like to ask any questions in any area? You have a brilliant panel up here, so it need not, and down there. So we don't need to keep it only to bronchiectasis.
Good evening, everybody. There is the concept that, as we all know, that we give inhalational antibiotics in bronchiectasis. Is there any evidence in literature where we can give direct antibiotics via the bronchoscopic working channel in the patient is a long-standing bronchiectasis?
Bronchoscopic installation.
Yeah.
So I'm not aware of any studies on that, and it intuitively doesn't make a great deal of sense because in these situations, usually infection is throughout the bronchial tree, so you'd have to do multiple installations of antibiotics or instill it through the trachea, in which case, why you're not just nebulizing the antibiotic. And antibiotics generally will last for 24 hours, best case scenario with an aminoglycoside. So you'd have to do repeated bronchoscopies to suppress a chronic infection like Pseudomonas. So no, the approach that we take of giving nebulized antibiotics twice a day is probably the most effective way of suppressing chronic infections.
Thank you.
Professor James, so what about with respect to the inhaled antibiotics? Is there a particular sort of a nebulizer you use? Because we know that we have different nebulizers and these are extremely expensive medications. Let's say a colistin is going to be highly expensive. So would you try to use some sort of a mesh nebulizer in comparison to a jet nebulizer, or it doesn't matter?
So it probably does matter. So mesh nebulizers deliver more effectively and during shorter durations, and adherence is one of our biggest problems. And so the mesh nebulizers that deliver in 2 to 5 minutes, like the iNeb that I showed earlier, are likely to be better adhered to than jet nebulizers that take 10 to 15 minutes to deliver a dose. But often it's what you can get available. And in the UK, we have a resource-limited healthcare system. Most of the time, I'm required to use a jet nebulizer because of cost.
Yeah, on the same lines, maybe the last question. Okay. So, we may not have nebulized, let's say, gentamicin, right? Would it be appropriate to use injectable gentamicin as a nebulizer solution?
Yes. So the landmark trial that we did, one of the first trials of inhaled antibiotics in non-CF bronchiectasis, was our Edinburgh trial published in 2011, and it was with injectable gentamicin, and it was highly effective. So there's almost nothing I haven't put into a nebulizer in terms of trying to treat these chronic infections. So I've used injectable ceftazidime, injectable meropenem. I could go on. There's pretty much nothing I haven't put in a nebulizer. But the best evidence for things that are widely available is gentamicin, 80 milligrams twice daily gentamicin. It works really well.
Professor Jay,
be sure that your mesh is maintained properly.
Yeah. The other one is just check the additives that are in the specific brand of gentamicin, because some of them have additives that are irritant to the airway. There's specific ones that are quite or better for nebulization. So we use a brand called Netacin in the UK.
For that matter, even an ultrasonic nebulizer is going to work much better in comparison to the jet nebulizers. And, because the delivery is much better in terms of the small airways.
And Professor James, one last question from my side. So what is your take on antibiotic rotational policy in terms of bronchiectasis? Let's say that you start a patient on nebulization with tobramycin. You give it for 3 months. You find the patient to be still exacerbating. And would you like to shift to a nebulization with colistin and again come back to tobramycin, making sure that you don't breed a drug-resistant organism to the same antibiotic nebulizations?
Yeah, that's a really interesting question. So all of the CF antibiotics were licensed on the basis of rotation with the idea that it would reduce resistance. There's actually no evidence that reduces resistance at all, and it just makes the regimens more complex for the patient. So our ERS guidelines now are give whatever antibiotic you've chosen continuously and just keep using it as long as it's effective. So in the scenario that you've talked about, I would give it 3 months. If the patient's doing well, I would continue it until the patient says they're not doing well. If they're not doing well, then yes, you can change to something like colistin on the assumption that it may be more effective for that patient. But I don't do rotation one after the other because there's no evidence that it makes any difference.
Yeah, I hate to put an end to this very active, very interactive discussion. Unfortunately, time is against us. So I want to thank the panelists and Dr. Murli, and particularly Dr. James Chalmers. We really overworked him today. He has been talking more than most of us. A round of applause. And the audience for your patience and sitting through all this. Thank you.
I'm amazed there's still so many people in the audience at 6:30. Thank you very much.
So thanks a lot, your faculties. So we are at the end of the sessions, and we are at the fag end, and it's time to wrap up. So once the photo session is over, I would be inviting the ERS President, Professor Silke Ryan, Dr. Salvi, and Dr. Parmez to conduct the valedictory function and the vote of thanks. Professor Ryan, Dr. Salvi, Dr. Parmez, onto the dais, please.
Absolutely mind-blowing discussion in the last 15 odd minutes, and we actually think that it should not stop for the sake of the audience. But yeah, every good thing has to come to an end, and I am actually proud, pleased, and to stand before you, because it's been an honor to stand in front of the esteemed faculty of ERS, Infectious Society, and also the delegates. And on behalf of Infectious Society, I'm Dr. Paramesh Ayar. I'm the governing body member of Infectious Society. And I would like to invite once again the ERS President, Professor Suke, and immediate past president of Infectious Society, Dr. Sandeep Salvi. Before moving to my actual job, I would like to announce 2 winners' names so that they can also hand over the certificates for the poster presentation. If they are available over here, Dr. Krishna Pillai. Give a grand round of applause for Krishna Pillai. She had won prize in the poster presentation. Yeah, her teacher is always here. And the second one is Dr. Aishwarya Alavanda. Congratulations. just for a formality's sake, Dr. Rajadhar had informed me not to miss a single entity or a name to, to do the honors. So I'd like to, first of all, from the bottom of my heart, thank the entire faculty from European Respiratory Society who had taken the pain, and they have been in India for almost a week and going to places like Delhi, Bombay, and Mumbai, and Cochin. I hope so. It's a God's own country. So I'd like to invite you on an annual basis to India for delivering your knowledge to all of us. And also the stalwarts of Indian Society under the leadership of Sandeep Salvi sir, and the ever fantabulous Rajadhar, Dr. Rajadhar, you have mentioned he's the one who is the core reason for by which this meeting has happened. And also the entire faculty of Indian origin, as well as the European Respiratory Society, I would like to thank once again. I would like to thank CIPLA, the platinum sponsors, and the entire team of CIPLA who had worked tirelessly for making this event a huge success. A grand round of applause for our entire CIPLA team. And also the support rendered by other pharmaceutical companies like Sedna, Suventus, and Schiller for supporting the event to such a grand event. I would like to thank the hotel as well as the impresario, Mr. Naveen and Sagar from Impresario for all the arrangements that they have done. And once and all the delegates and faculties, thank you. And I will hand over my mic to Sandeep Salvi sir.
I would also like to express my very sincere thanks to those doctors who have listened to this summit live on the internet. I believe there were more than 2,200 doctors who participated in today's program. So thank you to each one of them for spending their valuable time with us. And with this, I would now like to declare that the ERS India Summit 2025 is now closed, and I sincerely hope that we will continue to have such partnerships and collaborations with the ERS in the forthcoming years. Thank you so much.
Thank you everyone. I guess it's time to officially close, and until next time, stay inspired, continue your quest for acquiring more knowledge, and we know delegates are very important for any conference. Continue attending conferences on a regular basis. Thank you.
I request all CIPLA employees to be on the stage. Request CIPLA employee, please be on the stage. Come on. For the photograph.
Sound? Podium off.